Deborah DeVoe. I'm the chair of the Health Policy Commission. And on behalf of my fellow commissioners and our partners at the Center for Health Information and Analysis and the Office of the Attorney General, let me welcome you all to the Massachusetts Health Policy Commission's annual cost trends hearing. We'd like to welcome all of our panelists today and offer our gratitude to the providers, workers, and communities and the opportunity to provide insights and reflections on what's happening in our Commonwealth for patients, communities, and our healthcare system as a whole. Very much looking forward to the discussion. And a welcome to Attorney General Andrea Campbell, who we're honored to have join us here today, and our Governor, Maura, Healey, who will join us shortly. I'd also like to acknowledge Senator Cindy Friedman and Representative John Long. Thank you, John Long, chairs of the Joint Committee on Healthcare Financing, and welcome to those here in person at Suffolk Law School and to those joining us via our live stream. Before we begin, I'd like to ask each person with me here on the dais to introduce themselves. Commissioners, please also include the area of expertise you were appointed to provide. And can I start with you, Commissioner Kwasnick?
Hi, Martha Kwasnick, designee for Secretary Matthew Gorkowitz, ANF.
Ron Mastrogiovanni, corporate health, selecting health system, health insurance.
Good morning, everyone. I'm Barbara Blakeney, and I'm here representing Innovation.
Good morning, everyone. My name is Tim Foley. I'm here representing the healthcare workforce.
Hello, everyone. My name is Maddie Castillo. I'm the Commissioner of Health and Human Services for the City of Worcester. I'm a primary care physician, and I'm also part of the Health Equity Compact. Thank you.
Marty Cohen. I am the Behavioral Health appointment to the Commission.
Good morning, Alicia McGregor, the appointee with expertise in consumer advocacy, and my day job is a faculty member at the Harvard Chan School of Public Health.
Good morning, my name is Patty Haupt, and I represent employer purchasers of healthcare.
Good morning, I'm David Seltze, Executive Director of the Health Policy Commission.
Good morning, Lauren Peters, Executive Director of CHIA.
Hello, Sandy Walitsky. I'm the Chief of the Healthcare Division at the Attorney General's Office.
Thank you. The theme of our hearing this year is From Crisis to Stability, the path to a more affordable, accessible, and equitable healthcare system. Our hearing takes place in a period of significant upheaval and reflection for the Commonwealth healthcare system and, of course, for our country's healthcare system. A lot to talk about today and much happening that is of great concern and much progress and work that needs to be made. I guess I just want to take 1 minute to reflect on my own feelings as I come into this room, which is, well, two things. One, I'm very glad to live and work in Massachusetts. And second, I'm very honored to be part of the partnership between the Health Policy Commission and CHIA, because in this room, we will have a fact-based, data-driven discussion, and I'm glad to be part of that with colleagues who are not needing to debate the facts, but more our interpretation of what those mean, what's causing them, and solutions. So I want to, thank both my colleagues at the HPC and CHIA for that, and also for all of our attendees. We also are having a panel focusing on the significant toll that has been taken on communities, patients, provider organizations, and healthcare workers across the region by the recent dissolution of the Steward entity. And we've seen both those changes, hospital closures, strains on many of the providers, if not all, in the Commonwealth. And we absolutely want to air out the realities of both the financial and inflationary pressures that healthcare providers are continuing to wrestle with, workforce challenges, as well as the threats to access and affordability challenges for residents and businesses, and how those have changed since we had our last cost trends hearing last year. As you'll understand, what's highlighted in HPC's latest cost trends report, our healthcare costs are continuing to grow across all categories of care. The dominant factor driving this growth was higher prices, including co-payments, deductibles, and out-of-pocket spending. Healthcare costs for Massachusetts families neared $29,000 annually in 2023. Facing this cost burden, many residents had found themselves in the difficult position of choosing between health care and other necessities. And between 2021 and 2023, our measurements showed that the number of privately insured Massachusetts residents who did not get needed health care due to cost increases went from 600,000 to 900,000. In response to these issues and the impact of the Steward, it may be the last time I say that word, Steward. I guess one of my colleagues was calling it the former owners. I'm going to convert to that. In response to these issues and the impact of that crisis on the Massachusetts healthcare system, the HPC has outlined policy recommendations to better protect our healthcare system, the workforce, and patients from predatory actors, strengthening market oversight and transparency, including transactions involving private equity, and to ensure greater market stability moving forward. Today's hearing convenes healthcare leaders spanning the Massachusetts healthcare system, from the new operators of the former Steward Hospitals and Physician Network to hospital systems, community health centers, health plans, and labor representatives. We hope the conversations today will help lead the way forward in discussing solutions for the next chapter of Massachusetts healthcare, one in which we can make progress on our mutual goal of affordable, equitable, accessible care for all of our residents. I want to sincerely thank all of the dedicated individuals and organizations that touch the healthcare system, those who are participating today, and those who want to work on these issues together moving forward. Thank you for your commitment to creating a roadmap that will make progress. I will now turn our agenda over to Dr. Alicia McGregor, my fellow commissioner, who's going to introduce our first guest speaker.
All right. Thank you, Commissioner DeVoe. Good morning, everyone.
Good morning.
All right. So it's truly a pleasure for me to introduce our next speaker, Attorney General Andrea Campbell. Attorney General Campbell has been a champion for healthcare in her role as the state's chief law enforcement officer. As many of you know, the Attorney General's office holds several important healthcare enforcement and oversight responsibilities, in addition to being an appointing authority to the Health Policy Commission. And so I'll take a pause and just take this opportunity to express my gratitude to the Attorney General for my recent reappointment on this commission, representing healthcare consumer advocacy. Thank you, Attorney General Campbell. Again, it's an honor to continue to serve. So a few highlights about Attorney General Campbell's incredible career. Prior to taking office, Attorney General Campbell served as general counsel at the Metropolitan Area Planning Commission, legal counsel to Governor Deval Patrick, and was the first Black woman to serve as president of the Boston City Council. I'm pleased to report that as Attorney General, she has made it a priority of her office to tackle issues related to healthcare access and inequities for the people of the Commonwealth. For example, in 2023, Attorney General Campbell established a reproductive justice unit in the AG's office focused on protecting access to reproductive and gender-affirming care, addressing racial and economic disparities in maternal health care, and working across state lines to respond to national attacks on reproductive rights. Her maternal health equity grant, yes, I mean, you got to put a double emphasis on that one. Indeed, indeed. Her maternal health equity program has provided $1.5 million to nonprofit organizations providing culturally competent maternal health support services to Massachusetts residents to date. The priorities and work of her office complements that of the HPC, and we appreciate our ongoing partnership and collaboration with the Attorney General and her team. So we're grateful to Attorney General Campbell for joining us at this year's Cost Trends hearing. We know that there's a lot on her schedule at this moment, and we look forward to hearing from her today. Thank you for being here with us.
Thank you, and I'm glad you got a round of applause. We elected officials tend to get all the rounds of applause, and we know we don't do this work by ourselves, so thank you, Dr. McGregor, and good morning, everyone. I am delighted to be here with each of you, of course, the people in this room who are all doing the work in their own right to address access to healthcare issues, health inequities, and just so much in the midst of a lot going on locally and, of course, a lot going on nationally. I'm also grateful to my appointees and my team. I will not name every team member because there's more in the back, and we just don't have time for that. But I am grateful to my team and grateful to my appointees for your willingness to serve and everything that you do. It is not lost on me that many of us in this room thought we would be here this morning exclusively focused on the work of the HPC, including the annual healthcare cost trends examination, discussing the drivers of healthcare costs and the challenges and opportunities for improving care and reducing costs across Commonwealth's healthcare system. Instead, I think our work this morning is twofold. First, it is supporting the work of this incredible HPC and reviewing the substantial disruptions to the state's healthcare market, including Steward's bankruptcy and the significant toll that bankruptcy has had on our communities, our patients, our provider organizations, and our healthcare workers all across the region. Even while many providers were still adjusting post-pandemic, wrestling with capacity constraints, workforce recruitment and retention challenges, and financial volatility. And further, even while we see an increasing number of Massachusetts residents struggling with healthcare affordability and medical debt. Second, I think our other task now is to prepare and ready ourselves for the months and years ahead. As if these market disruptions weren't enough, the results of this recent presidential election may have significant repercussions for our healthcare system, as well as our democracy and our rule of law. Since last night, I have been dealing with, including this morning, when I was just tracked down by press, with the announcement that a former Florida representative was nominated to be the United States Attorney General. This was and is an individual who is under investigation for allegations of sexual abuse, including of minors, an individual who is a Holocaust denier, an individual who supports a national ban on abortions with no exceptions, an individual that wants to revoke federal funding to nonprofit organizations that, for example, assist migrants who are already here in the United States. And the list goes on. And it's not even January yet. Across the country, state attorneys general will be on the front lines to protect the rule of law and our fundamental rights and freedoms, including access to high-quality health care, reproductive health care, gender-affirming care, behavioral health services, and closing maternal health disparities. And I want you to know I, along with my incredible team, stand ready to lead and to do everything in our power to protect our residents here in Massachusetts, our patients, our providers, and our children. While these announcements may seem like Goliath moments, like David, the Massachusetts AGO, with its nearly 700 team members in Boston, New Bedford, Worcester, and Springfield is small yet mighty, with powerful litigation, legislative, grant-making, and community engagement tools. Here in Massachusetts, we punch above our weight because of the people, the industries here, and the robust ecosystem we are blessed to have, including this incredible HPC. As your AG, and as someone who has never forgotten my poor and tough upbringing, and as a mother of 2 young boys, prepared to ensure that the next generation does indeed do better than the last, especially when it comes to health outcomes, I say, bring it on. I got into this work because I was frustrated with how much money and time government wastes not helping people, not actually having an impact. Our office will not participate in the blame game or point fingers or waste time or taxpayer resources. We will work hard every day to help people and to have an actual impact that people can feel. And we can only do it in partnership with each and every one of you and those in this room. So while you may be grateful that I am here, I am grateful that I am here with you because we cannot do this work by ourselves. I also know that each of you in the HPC get it. You understand deeply that our work is not about one man, rather structural inequities in access to affordable, high-quality healthcare, especially in our low-income communities and communities of color. You understand that greed, prioritized over patient care, will always lead to poor health outcomes. The Steward crisis upended our healthcare system. The instability and disruptions to care, fueled by Steward's own greed, have devastated patients, workers, and communities in the region. I want to acknowledge the pain of the communities, especially in Dorchester and Neshoba Valley, where sadly, as we know, Steward hospitals were closed this year. I share in that pain in that the Kearney Hospital is in my neighborhood and was one of the institutions I would often bring my 2 boys for emergency health care. Hospitals, health centers, and other providers have had to fill the gaps left by Steward's departure, and now, along with the new owners of the remaining hospitals, will continue to pick up the pieces. In the midst of local and national disruption, I maintain my joy and hope because of the workers, the nurses, the doctors, the custodial staff, the lab techs, the receptionists, everyone who keeps our hospitals working, who have showed up without fail to serve patients in the face of difficult conditions and great uncertainty. I thank them, and I remind our residents there are reasons for all of us to maintain a sense of optimism about the future, and they are one of those reasons. As Steward exits our state, we move into the next phase of our response, accountability and improved oversight. This crisis has shined a spotlight on the dangers of unchecked private equity ownership of healthcare providers. The Steward crisis revealed that greater transparency, market oversight, and accountability is needed to protect Massachusetts consumers and to ensure state agencies have the appropriate tools of oversight or responsibility during a transaction or a major decision point, not after the fact. We need better tools to stop private equity from stripping the value of our hospitals for a profit. For example, our healthcare transparency tools, like these hearings and our office's Healthcare Cost Trends Authority, should extend beyond healthcare providers and payers to owners and investors in healthcare. And the failure to report mandated healthcare data to entities like the HPC and CHIA should be met with steeper penalties. If regulators are expected to have a complete picture of the healthcare landscape, there is simply no reason that some entities can delay or avoid reporting. Our oversight system also needs to capture a broader set of actors and actions to adapt to market changes in healthcare financing. Transactions like investments by private equity firms and sale-leaseback agreements are clearly top of mind. My office and the HPC should have the tools to intervene when transactions will harm our healthcare system. Changes to our existing law enforcement tools will also bolster accountability for healthcare provider owners. For example, we should amend the False Claims Act to hold private equity owners accountable for false claims and other violations if they fail to address them, regardless of whether the owner caused the submission of that false claim. My team will continue to partner with the legislature, and I know many are here in this room, and push them to expand our state tools for healthcare market oversight, which is critical and absolutely necessary in any exercise of accountability. The AG's office cannot be the only office that does the accountability work. Each of us needs greater tools to also be a part of that work. The Steward situation has showed us the importance of supporting also our healthcare safety net, those healthcare providers that take care of our lowest income communities. At every step of the Steward saga, low-income communities and the hospitals that serve them have borne the brunt of this crisis. We need to take this opportunity to ensure that healthcare providers serving high percentages of mass health patients can stay financially strong, providing that care, so that they can keep their doors open for communities that rely on them the most. While the Steward failure and bankruptcy demands our attention, and of course merits focus during these hearings, we've also seen broader affordability issues impacting consumers and small and large employers across the Commonwealth. In 2021 to 2022, we saw the highest health care spending growth in the last 10 years, aside from COVID-related disruptions. The Division of Insurance reported this summer that the merged market premium rates increased on average by over 8% from 2024 to 2025. And just in the last few weeks, the Boston Globe has reported on contract negotiation breakdowns between payers and providers that will result in significant disruption in smaller provider networks for people shopping for low-cost health insurance coverage on the Health Connector. These are absolutely worrying trends and, of course, demand our full attention. My team also recently released a new report on affordability challenges impacting Massachusetts healthcare consumers. Despite our high levels of insurance coverage, we know many individuals and families in the Commonwealth still are struggling to pay for necessary health care. We see this struggle repeatedly as consumers seek assistance from our office's healthcare mediation programs to help with unaffordable medical bills. In our report, we look at healthcare affordability through the lens of commercial health insurance population to better understand which Massachusetts households may be struggling to pay for needed healthcare despite having and paying for health insurance. The majority of these folks contribute to and have their insurance through an employer. We find, for example, that in 2022, the average fully insured Massachusetts household in the lowest income communities spent nearly 13% of their household income on healthcare expenses, things like deductible responsibility and premium contribution. As a percentage of income, this is nearly 5 times more than others spent in wealthier communities. Healthcare costs, on top of rising costs of housing and food and other necessities, are squeezing family budgets for lower and even middle-income families. As a result, too many Massachusetts households end up incurring debt when they cannot pay a medical bill, subject to cost sharing under their insurance plan, including a deductible. We studied this by looking at medical debt held by patients with commercial insurance for hospital services. We found that communities that are already facing health disparities are disproportionately impacted by hospital medical debt, especially female, Black, and lower income patients having a higher likelihood of incurring medical debt. While hospitals do have policies that can provide discounts, of course, for lower-income patients, those policies vary greatly across hospitals, and these discounts often do not apply to amounts owed for deductibles and coinsurance. Unpaid medical bills also, of course, have a downstream effect on hospitals that serve these vulnerable communities. And we found that lower-cost hospitals serving lower-income populations lose higher amounts of commercial revenue to unpaid bills. These are changes, of course, that we need to make in Massachusetts to ensure our families can access better health care and at the same time support the hospitals that serve them. We recognize you need to do both. We need to measure and have a more systemic measurement and monitoring of our healthcare affordability from the perspective of patients, such as how much a household pays for healthcare in relation to household income. There should be a target affordability benchmark that helps identify communities that are overburdened by healthcare costs to allow for targeted responses. Second, there needs to be stronger protections for patients facing hospital bills with costs that are simply out of reach. We also need to think about ways to addressing rising premiums and deductibles, particularly for lower income populations. And we need to sustain and support the hospitals that serve lower income communities, including addressing unwarranted variation in prices that are paid to these hospitals. Supporting hospitals that serve our most vulnerable populations, as you all know, is an essential component of protecting affordable and equitable access to high-quality care. We put out a lot of reports in the AGO. My team does not like to waste time just doing reports for the sake of reports. We, of course, did one on ambulances last year and those costs. And so we are pushing, not just the HPC, of course, but our legislature and every stakeholder to really look deeply at the recommendations that we attach to our reports at the end and to work with us to implement them, because we alone do not have the direct authority or power to implement the very recommendations we think are needed in this moment in time. So as you do today's hearings, I want to thank all of you for the work you are doing. I know it is a trying time, to say the least. I want to thank everyone who is participating online, all those who are behind me who will participate in the panel discussions today. I also want to thank the governor and lieutenant governor for their leadership and their work. And I want to thank, again, my incredible team, the work you guys do every day. You are appreciated, you are valued, and we are ready for the work and the task ahead. And know that you have a partner in the AG's office, and we are here to work to get things done on behalf of the people who deserve it the most. Thank you all so very much for having me this morning.
Thank you so much, Attorney General. Do you have time for one or two questions?
Sure.
Or
Sure.
And commissioners, any questions for Attorney General?
Hi, Marty.
You referenced the new administration starting. Are there specific challenges or threats that you see for Massachusetts coming forward?
I first want to tell folks I, along with a few other AG's offices, were participating and working on contingency planning, hoping that we could put those contingency plans on a shelf. But we are entering 2.0 in terms of the work. In the healthcare context, we, of course, are absolutely worried about protecting access to the full spectrum of reproductive health care, gender-affirming care. We want to continue to do the work of addressing the maternal health disparities we see, not only, of course, in our Black communities and with Black women, but also in our poorest communities, including in rural communities here in Massachusetts. We absolutely want to continue to address the access issues, which existed, including in the context of reproductive health care before Dobbs, the cost issues. So I think much of the work that we were looking to accomplish and have, there is potential it can be unraveled, not only from the lack of transparency from those who are coming into the space and who don't necessarily believe in transparency, those who want to change significantly legislation at the federal level, or policy at the federal level that will hinder access to this critical care. Those who demonize certain populations of folks, including our LGBTQ plus community, our trans youth, and how that threatens access to gender-affirming care and other necessary care we know is so important. So we are concerned across a wide spectrum of issues, but in the context of healthcare, those are just some. And I am really concerned that unlike our office, the HPC, the individuals who are being selected as potential nominees, we don't know who HHS will be, but I'm sure it will be someone as scary as what we've just been seeing, someone who is loyal and is a loyalist versus someone who is qualified and who cares deeply about working across the aisle to get things done on behalf of our people. I am concerned, not only will they not do the work with an equity lens, they will not do it with a sense of collaboration and partnership. And the last I checked, in order to get things done in the healthcare space, we need everyone showing up, putting aside their ego to really have thoughtful, meaningful conversations. But we are prepared, as hard as it may be, to model what can get done at the state level to protect access to care. And I would be remiss if I didn't acknowledge the legislature. So I saw Senator Friedman, Chairman Long here as well, and many others who did the work to codify, for example, an access to an abortion, who made us the first state in the country to pass the SHIELD law, the first but also the strongest SHIELD law to protect our patients and providers. And we're going back to the table to make sure that is strong and other laws and regulations are strong in the face of what might come. But we were the leader, and we will continue to be, and we want to make sure we're part of that leadership as well. Thank you.
Thank you. Thank you so much, Attorney General. We are so appreciative for your service and that of your team and your strength and clarity in looking at the road ahead.
Thank you.
Is much appreciated.
Thank you, and thank you all, and enjoy the day. Thank you.
Now honored to welcome our next speaker, our Governor, Maura Healey. Yeah. Give that a minute. It's hard to get from the door to the table when you're the governor. Everyone wants to talk to you for a minute. Introduce David and then she'll walk in. Well, she may have been delayed for a moment. Director Seltz, do you want to take a minute to describe logistics for the day, and then we'll introduce the governor when she comes in?
Sure. Good morning, everyone. Good morning, commissioners. I'm David Seltz, the Executive Director of the Health Policy Commission. We are truly honored to welcome commissioners, panelists, and audience members today from across the Commonwealth and across the Massachusetts healthcare system to engage in these conversations. But really, these conversations extend far beyond this room. In advance of today's hearing, we also solicited testimony from 34 different organizations, health systems, hospitals, other providers, and health plans in the form of pre-filed written testimony. All of that pre-filed written testimony is available on our website. We asked many of the questions of these organizations that we are going to be asking of the panelists here today. We provided a summary of that written testimony here today in written form for you, and it's also available on our website. As Chair DeVoe said, along with welcoming our in-person attendees, we are live streaming this event on our website and our YouTube channel. And we are also engaging in a social media conversation on a platform that I will not name. I also really do want to recognize our colleagues and friends from the legislature, Speaker Mariano, Senate President Spilka, Chair Lawn and Chair Friedman, who are here with us today. Thank you for being with us always, every year, attending this great event, and thank you for your support of the Health Policy Commission. This morning and this AM, we're really going to be focusing on the aftermath of the dissolution and bankruptcy of the Steward healthcare system. This is a really unique and timely opportunity to reflect on the significant harm that has been incurred in this Commonwealth on communities, on healthcare workers, and on patients. This has been a long year, and like many of you, I did not expect to spend my summer learning about bankruptcy law. But here we are, and we have now, at this point, new operators who have stepped up to operate these hospitals and physician network. And we're going to be hearing from them on our first panel today about their plans and strategies for the future in operating these facilities, in caring for the patients in these communities, and in rebuilding trust with those patients and workers in these communities. On our second panel, we're going to hear from some of the organizations and workers who have been most directly impacted on these harms. And we're going to be asking these panelists to reflect on what are the lessons learned from this year, and what will it take to move our system from one that doesn't prioritize greed and wealth to one that prioritizes patients and puts patients at the center of care. I'm really looking forward to engaging in this conversation with my fellow commissioners, and I hope to hear more from the panelists when we begin those panel discussions.
Drawing it out, yeah.
Drawing it out. So let's see.
We have jokes next.
Yeah, exactly. A little soft shoe.
She's stuck in a scrum.
She's stuck in a scrum.
The press always getting in the way.
Yeah, I don't like to pause and keep everyone waiting, but we also know that the governor is very tightly scheduled, so I want to give her some flexibility in terms of, you know.
I can say a few more words. As we set up this morning's conversation, I also do really want to express my gratitude to Governor Healey, Secretary Walsh, and Secretary Matt Gorkowitz, who really helped navigate this unprecedented debacle of the bankruptcy and exit and the realignment of this healthcare system. And so, with that note of gratitude to the governor, I will turn it back over to you, Chair DeVoe, to introduce her.
Thank you so much. Welcome, Governor Healey.
Good morning.
I'm honored to have the opportunity to welcome you with the group. Short comments about our governor. Throughout her work in public service, both as Attorney General and Governor, Governor Healey has prioritized efforts to tackle escalating healthcare costs and fight to ensure patients across Massachusetts are receiving the best possible care. Specifically, as Governor Healey has made, at the beginning of this year, launching Advancing Health Equity in Massachusetts, an ambitious and collaborative initiative aimed at eliminating racial, economic, and regional disparities in health outcomes across the Commonwealth. In August of this year, Governor Healey signed an historic bill aimed at improving maternal health equity and birthing outcomes. She's always been a strong advocate for Massachusetts consumers, understanding the importance of both community engagement and policy action, and has certainly demonstrated this leadership during the bankruptcy and dissolution of Steward Healthcare. The leadership and financial support of Governor Healey's administration, including Secretary Walsh, Commissioner Goldstein, and the hardworking staff at EOHHS and DPH, alongside the hospital systems, helped prevent the full collapse of this system and creating continuity and stability for the future of the hospitals and physician network to the greatest extent possible. While this is just the beginning of a long road ahead of us, we know that Governor Healey and her administration will work diligently to protect access to care, reduce health disparities, and address the significant healthcare challenges facing patients, workers, and communities. I also want to say, Governor Healey, that the HPC is grateful for the productive and collaborative relationship that we've held with you and your team, and thank you for your continued partnership and participation at the cost trends hearing each year.
Great.
Welcome.
Thank you, Chair. Thank you very much, Madam Chair and Director Seltz and members of the Commission. It's wonderful to see you all. It's wonderful to have just said hello to our terrific Attorney General. I know that she and her team will continue to do, and Sandy, will continue to do the really important work, and we're all going to be working together. So good morning to everyone, special good morning to our administration's commissioners, our great Secretary of Health and Human Services, Kate Walsh, and our General Counsel for Administration and Finance, Martha Kwasnick. To electeds in the room, including Chair Friedman, Chair Lawn, we appreciate the ongoing partnership with the legislature here today, as well as the work of leaders across our healthcare ecosystem, members of the Health Equity Compact, critical partners in healthcare access for all of our residents. It's good to be with you all again for this important annual event at this moment for healthcare and for our country. Healthcare costs continue to be a significant source of stress on budgets and in the lives of too many of our residents. And the election that took place last week will no doubt impact our healthcare system. We're not quite sure yet of what the impact will be, but obviously we will need to continue to endeavor to work together in all ways possible. And my hope is that as we continue our work, Massachusetts will draw on our strengths, the value, the talent, the innovation, the collaboration that has made Massachusetts such a leader in healthcare. I'm proud that we're the state that created the first boards of health. We created and invented the Community Health Center. We're the state that enacted the nation's first universal health care law back in 2006. And today, we have the highest rate of coverage at over 98%. We're the global capital of medical innovation, where cures and therapies and treatments and vaccines are emerging every day from our hospitals, universities, and companies. And we have people across this state and in this room who devote their lives to making sure that every single person and community has access to affordable, equitable, world-class care. I also look at the challenges we met this year, and I appreciated the comments of the director and also the chair about the Steward situation. We got, at the end of the day, we got, working together, a historically bad operator out of Massachusetts. And we saved 6 hospitals that were at risk of closing. With that, we saved 13,000 jobs. We brought stability to the healthcare system throughout regions of the state. And I just want to express my deep appreciation for the talent, for the goodwill, for the work of so many in this room. I'll begin by acknowledging the work of Commissioner Robbie Goldstein, who now leads our Department of Public Health and did a terrific job with the Incident Command Center that was established. I am forever grateful to Kate Walsh for her willingness to join this administration. Could not have had a better person at the helm in this moment, and I'm grateful to you, Kate, for all that you and your team did. I'm grateful for our partnerships, you know. Thank you, Tim Foley, 1199, for the work, the conversations, the collaboration, to our colleagues at the M&A as well, to MAP, to Blue Cross, the League of Community Health Centers, local communities, reputable providers, partnering to ensure that care was going to continue and be available. It was and remains a tenuous situation. But I think everybody here deserves credit for doing something that no other state was able to do. Steward's operating throughout the country, remember. And we did something here working together that no other state was able to do. Our patients, our communities, care is going to be better on the other side of this. And that is with full acknowledgement of the very real challenges that our providers face and that are the subject of discussion here today. But I think it is important to note that. I also want to say to the HPC directly, thank you for the leadership in this time. We would not have been able to navigate our way through what was an incredibly complex and ever-evolving situation without access to the financial information and the data. And we really, really appreciate the invaluable role that you played in evaluating and thinking through financial and market implications. As you know, we've also established working groups to address the needs and concerns in communities that had been served by Neshoba Valley and Kearney Hospital. And that work continues, and I appreciate everybody's continued engagement with that work. I also recently appointed, a new commissioner of insurance, who is not a stranger to many in this room. Our commissioner of insurance, Michael Caljo, we appreciate his deep healthcare experience, and I know that will be beneficial to the work that we're doing together. I've also charged the Division of Insurance with taking a fresh look at its examination authority, or its ability, right, to regulate the industry, to ensure that insurers are actually solvent and doing what they need to be doing, and using all the tools that we have. And so I'm excited to see his and the team's work as we go forward. In the past year, we were able to partner with the legislature to make historic advances in access to health care, and that does bear noting. A lot got done this year in this space. We worked to turn the 2-year pilot expansion of the Connector Care Program into actual law. That's a big deal. It's the first expansion of state-funded affordability at the Connector since Chapter 58 was first enacted. The Affordable Plan now covers an additional 51,000 Massachusetts residents, including families of 4 earning up to $150,000 a year. Participants are saving $150 or more on their premiums every month, and that's real progress on affordability for working families. We also passed legislation to ensure that older adults with disabilities are receiving quality care delivered by qualified providers, whether at home or in assisted living or in long-term care. We also passed a maternal health care bill, something that I personally care so much about. that expands access to equitable care. And, what was done around midwives and doulas, birth centers, screening and treatment for postpartum depression that's really, really great. And we got that done this year. We created new programs to invest in a healthcare workforce. I know this is a challenge, no matter what context, but know that we have really leaned in as an administration to think about how we can incent and support a workforce. I'm excited too, because we're on the verge of enacting an economic development bill. That's going to be on my desk very shortly. And that will make and continue to make transformative investments with the aim of ensuring that we are supporting and growing and expanding our life sciences sector here in Massachusetts. And a goal of that, of course, is always directed at the end user and what's happening in terms of patient outcomes. As you know, part of that economic development bill that I filed not only leaned into life sciences, but also applied AI, so that we are better equipped and equipping ourselves to better identify the cures, the treatments, and the quicker path to success for patients. In Massachusetts, we believe deeply and collectively in a right to health care, a right to health care that meets the needs of every person and every community. We are not there yet, but that is the goal. That's where we want to be. For that reason, it's important that we continue to address the fact that healthcare costs are causing financial stress in the lives of our residents, in the lives of our businesses and employers. Families are looking at their budgets and wondering where the money's going to come from to pay for premium increases, out-of-pocket charges, or even a series of co-payments. Parents are struggling to find primary care doctors who can take new patients or schedule urgent appointments for their kids. Siblings are struggling to figure out how to take care of aging parents. Healthcare is and must be a priority for all of our residents. It's something that touches every single resident in our state. And the last thing that folks should be worrying about is whether they can afford care, and we're here to make progress. I want to propose today an area that I think deserves particular focus, and that is primary care. We know that primary care I'm just a JD, not an MD. You know that. I thought about that, but I was afraid of blood early on. All my family were nurses. But I had to do something else because you can't pass out, apparently. So I went a different path. But, what I've come to know and understand, the primacy of primary care and the investment that we need to make is so, so important. And I think that is something that our administration, under the leadership of Secretary Walsh, we really want to lean into. We can do more there. We know it is a proven and cost-effective way to help not only fix, but actually obviate and head off a lot of the challenges that we deal with today, including challenges around cost. The United States as a whole spends roughly half of what other developed countries spend on primary care. Half of what other developed countries spend on primary care. And our patient outcomes, our workforce shortages, our cost challenges, our equity gaps are all to some degree rooted in this shortfall. It's felt, of course, most acutely in low-income communities, communities of color, rural communities, and we see that here in our state. But the entire healthcare system suffers when we do not have widespread and ready access to affordable, accessible primary care. Lack of access to primary care leads to more patients showing up in emergency departments and other high-cost settings. Limited primary care means patients delay care, which of course leads to worsening outcomes and exacerbation of health inequities. So that is why our administration is really focused on and leaning into primary care. We launched an Advancing Health Equity in Massachusetts initiative, and we're doing that to better align healthcare investment with community priorities, including access to primary care. And I invite everyone in this room to embrace and join in that work. We know that when healthcare spending is more responsive to community needs, we get more from our healthcare dollar, and premiums can be more affordable. But we also need a broader response to this. And in consultation with, or at the direction of, Secretary Welsh, I'm no dummy. I've instructed Mass Health to look at our buying power, okay? To look at our buying power and to make sure that we're using that buying power to prioritize investments in primary care. We've got to do this. This may likely yield cost savings down the road and will help us rebuild the primary care workforce. I say this may likely, it will, it has to happen, and we got to work together to make that so. It's also, of course, one of the most meaningful ways to actually improve the health of our residents. And, you know, again, we've got to work to make sure that our dollars are lining up with our goals, our values. And I'm here today to ask that all stakeholders around the room and at the table join us and do the same in making this investment in primary care. I truly believe that Massachusetts is the state best positioned to do this because of our history, because we have a proven asset for expanding primary care. Just look at our 52 community health centers. 52 community health centers, 258 access points around the state. They're providing millions of visits every single year, millions of primary care visits every single year. And I'll note that every time our healthcare system is stressed and strained, whether it's, responding to COVID-19 or caring for patients that are displaced by hospital closures, our community health centers have been there and been there delivering. And we count on our CHCs to be there when we need them. But how much more could we do if we invested in them through adequate and equitable reimbursements from every payer, not just Mass Health. So I want to thank all of our CHCs for the work they do, especially the work done for some of our most vulnerable residents and communities. I want to thank Michael Curry for his leadership and partnership, including accepting the role of chairing one of our working groups in Boston. Look, what we do here matters, it matters to people in our state, and that is and should be our primary focus. I also think, because we're Massachusetts, we have an opportunity to show a better way forward, including when it comes to healthcare, making healthcare more accessible. And, I believe that it's our healthcare that's part of what makes our state the best place to live, to work, to raise a family. We were just ranked the best place to have a baby, best place to live if you're a woman. That says something about the quality of life. And, nothing is more near and dear than the health and well-being of our loved ones, right? So we've got a lot of good going for us, in addition to this incredible ecosystem that I brag about all the time, that is the envy of the world, that also needs nurturing, right, and care. But we've just got to continue to stay at it, to make progress on costs, because our leadership is more important than ever. I've also said to the team, I had a cabinet meeting the other day, there's a lot of unknowns ahead. I think, we've got to be doing all we can to meet the moment and prepare for any number of contingencies. I also think it's a moment, though, to be bold and innovative. If there are things that have not been working, this is not business as usual, because business as usual, here we are. So I'm encouraging everyone to embrace this moment and moments that may present as times of incredible hardship, crisis, challenge, as opportunities to think about and approach things differently. And that requires cultural change and transformation. And I know working with teams, that's sometimes hard to bring about, right? Because we've all got our prerogative and our way of doing things. But I just really encourage us as a state and everyone at the table and around the room to think about that, to embrace that, to not be daunted in this time, to not be daunted, because there are so many people who depend on the work of all of you in this room, and they're going to continue to depend on you in the time ahead. And I think they are lucky, most fortunate, that they are in a state where we have such quality leaders and quality assets, and some proven models. And I want to lean into our collective leadership and partnership and meet this moment. So thank you all again for the opportunity to come before you, and thank you for the work you do.
Thank you so much, Governor Healey. What a wonderful way to set a pH balance for our conversations and inspire us on both the reality of the challenges, but also the road ahead. And particularly your comments about primary care and the role of the community health centers and what will be a critical part of our ability to address your stated concern about the right to health care. So thank you. Do you have time for a question or two? Or
Oh,
do you need
certainly.
to- Yeah? Are there any questions do you have a question?
Yeah. Hello, Governor.
Morning.
Morning. I am daunted. I am overwhelmed with the things that happen in our community. I'm overwhelmed with, certainly the lack of primary care, and you talked about what happens in the health centers, right? We're losing the docs from the health centers. They're being poached by the people who can pay more for them. So they're working 10 times the amount. And we don't know how to solve that piece. We also worry about the amount of homeless that are in our community. Our numbers are increasing. Our new president coming forward says that he's going to get everybody off the streets. He doesn't want people out in the streets anymore, and he's going to find a place for them. If we don't find housing for folks, this is crucial for us. It increases the cost of healthcare if we don't have that. So it's a question, but also a feeling of what we're seeing. So I don't know what your thoughts are.
Yeah. Well, I mean, again, I want to underscore how much I appreciate all the work that's happening in community health centers. Look, I guess I'd say a few things. Healthcare, it doesn't exist in a vacuum. And, one thing that I learned going back to my early days in the AG's office was the importance of focusing on the social determinants of health. And, that's why we as an administration have leaned hard into food security, for example, right? Making sure that people in this state have access to food. Making housing a priority. I'm proud that in working with the legislature, we were able to pass a historic $5 billion housing bill, right? Because we need to bring more housing units online, a range of housing units. And I think, I say that because I am aware of, very, very acutely aware of increasing housing insecurity in this state. We hear it from municipal officials across the state. And, it's something we are laser focused on. It is also why I am laser focused on cutting through permitting, zoning. We're not going to get there unless we bring housing online. And there is a way to do it. And it's not one size fits all. But all 351 communities, have to realize we have a shared collective interest in bringing more housing online. We got to do that. We got to do that as quickly as possible. So, I guess I take a view of there any number of things we need to factor in, including using our buying power to better support and incent those in primary care to stay in primary care, particularly at locations that are going to help address some of the health disparities. but we also have to continue to do these other things, you know? I'm proud that when we cut taxes last year, Massachusetts is the state with the highest tax credit for children and dependents. You know, these are important things. And, you know, I understand. I understand, you know, it's daunting, and people are overwhelmed and people are overworked. And, you know, that's why we've just got to keep doing what we're doing. I mean, the fact that community college now is no cost, you know, that's going to matter. It turned out we had 700 adults in Massachusetts who were on the sidelines, you know, and now are going to be able to go, because it's not just no cost. It's also we have found ways to provide other support so they can actually stay in school and pay for gas and pay for housing and pay for childcare, right? So that we're training a workforce, you know, that will better meet the moment. And I'm particularly focused on primary care, also focused on behavioral health. You guys know the numbers. The number of adults right now in this country who are being treated for mental health issues, the number of young people right now. So, and the challenge, the difficulty of finding a provider for a loved one, and we're better off than a lot of states. So I think we just got to continue to focus, you know, on all these fronts, and we will absolutely get to a better place.
Thank you very much, Governor. And thank you for recruiting and appointing Secretary Walsh.
Doesn't she look happy?
Yes, I do. Yeah. And for your deep understanding of healthcare and for your vision moving forward. Thank you very much.
Well, thank you, and I want to thank Secretary Walsh and the entire team, because Kiami, you built an incredible team. People are working very, very hard, including folks who have been there for some time, and just appreciate that. So thank you, and have a great rest of the hearing.
Thank you. Terrific. A good start for us. So we will now turn to our first panel. If I could ask the panelists to come up to the table. And of course, everyone, you know, feel free to take the time to get coffee or water as you need it. I'll now turn to our Vice Chair, Marty Cohen, to kick off our first panel.
Good morning. I'm pleased to kick off our 2024 cost trends hearing with our first witness panel. This witness panel is titled, "What Comes Next? The Future of the Former Steward Hospitals and Physician Network." Just 6 months ago, Steward Health System filed for bankruptcy protection in federal court. That action raised questions about the future of Steward hospitals here in Massachusetts. The disruption it caused cannot be downplayed. Patient care was at risk, a dedicated healthcare workforce was unsure of their future, and communities were left wondering whether the community hospitals and physicians they so relied on for their medical care would be there for them. Sadly, the bankruptcy led to the closing of 2 Steward hospitals, leaving a void in Neshoba Valley and Dorchester. But as the theme of today's cost trends hearing suggests, we are moving from crisis to stability. The good news is that 6 Steward hospitals in Massachusetts were able to attract successful operators to continue and grow these systems. And I too want to thank and acknowledge and commend my fellow Commissioner, Secretary Walsh, and her team for all they have done to help this process along and ensure uninterrupted patient care. Joining us on this panel is the leadership of those organizations that have taken over these important assets. They are Dr. Abha Agrawal, the president and CEO of Lawrence General Hospital, which is now the operator of the 182 beds of the Holy Family Hospital sites in Haverhill and Methuen. Dr. Alistair Bell, the president and CEO of Boston Medical Center Health System, which is now the operator of 234 beds at St. Elizabeth's Medical Center in Brighton and the 192 beds at Good Samaritan Medical Center in Brockton. John Fernandez, the president and CEO of Brown Medical Center Health System and the new operator of the 187-bed St. Anne's Hospital in Fall River and 123-bed Morton Hospital in Taunton. And finally, Benson Sloan, the founder and CEO of Revere Medical, formerly Rural Health Group, the new operator of the former Stewardship Health Medical Group and Physician Network, comprising over 2,500 physicians. Welcome to each of you, and thank you for what you are doing and your willingness to testify today. As I said at the outset, this session is titled, What Comes Next? So let me go down the line and ask each of you to tell us the value add your organization brings to these newly acquired assets and what you see as their future in the health markets that you serve. Dr. Agarwal, we'll start with you.
Good morning. First of all, as a newcomer to the state of Massachusetts, I'm honored to be in a state that leads with health equity and where its Health Policy Commission holds such hearings. I'm also grateful to the Commonwealth for its support for this acquisition, without which it would not have been possible. I also acknowledge and thank the commitment and courage of our Board of Trustees, a safety net hospital with limited resources, to step up and believe that this is the right thing, not just for Lawrence, but for the Eastern Merrimack Valley. So why do it for us? As we envision our acquisition of Holy Family, our overriding concern was the devastating impact of Holy Family's closure on the entire Merrimack Valley and our overriding desire to preserve access to care in the valley so that no patient is harmed. For example, Lawrence General provides 65,000 emergency room visits a year, the same for the two campuses of Holy Family Hospital. We perform 1,400 deliveries per year. Holy Family performs 1,200 deliveries, and no single hospital would have had the capacity to absorb this care. Why us? Our stellar track record in quality and equity reinforced my belief that this is the right thing for the patients. For example, on September 17th, Lawrence General became the first standalone hospital in Massachusetts and the 12th in the country to receive the prestigious Health Equity certification from the Joint Commission. So our focus on health equity and our mission to serve the patient is clear. We also believe that our geographic proximity and complementary clinical service lines provide an opportunity for a cost-efficient method of organization of access to care in the region. For example, Lawrence General excels in trauma and emergency care, while Holy Family has service lines, for example, behavioral health and radiation oncology.
Dr. Agarwal, could you speak into the microphone, too?
Sure.
Thank you.
So then, what now? Now with this, we are excited about the opportunity to create an integrated, single community health system that puts patients in the center, that's guided by the light of health equity, and is committed to community to provide local, convenient, culturally, linguistically competent healthcare right in the neighborhood. Thank you.
Dr. Bell.
Good morning. Thanks for having me. I'm from Boston Medical Center Health System. So many of you will be very aware, I think, of Boston Medical Center. But briefly, BMC Health System is actually a much broader family of organizations. We have WellSense Health Plan, which covers 40% of the Mass Health lives in accountable care statewide. We have one of the largest accountable care organizations as part of that program, a network of 15 community health centers that we partner with very closely with in the Boston area, an academic medical group, a behavioral health center in Brockton. So when you think about BMC, yes, you think about the hospital in Boston, but we have a much broader footprint and impact on the care and payment of care for low-income communities in the state. So when we looked at this as really, if you like, the region's leading provider and payer of essential health services, we found ourselves sort of compelled to consider what was our role as in mitigating this looming public health crisis caused by Steward's bankruptcy. Ultimately, we determined our biggest impact could be made by assuming responsibility for Good Samaritan Medical Center in Brockton and St. Elizabeth's. The integration of both these hospitals builds on, in the case of Good Samaritan, our existing presence in that Brockton community, both from a behavioral health standpoint, but also from a payer standpoint. We have a lot of partnerships with other providers in that area. And St. Elizabeth's, we have a longstanding set of clinical relationships with, and it is a teaching hospital of Boston University, which is our principal academic affiliate. So we sort of look at these two hospitals as greatly expanding the ability for our mission to provide affordable, high quality, and culturally competent care to more patients and communities. We are looking forward to working with the very talented staff at these organizations to bring the best of how BMC thinks about its role into those organizations, to work with them, with those communities. And I maybe just lastly, I would say, we're not doing this alone. And so the leadership and staff of these medical centers have been very important. Commonwealth, the administration, the entire healthcare market actually has really come together to prevent this catastrophe. And I think that spirit of collaboration that has come together will be required in the coming years to help these be really thriving community assets going forward. So thank you.
Thank you. John, welcome back to Massachusetts.
Thank you. Great to be back. Felt like I never left almost. Before I get started, though, I just thought on answering the why question is, I think another important why is how we were able to do this, which was picking up on the governor's comment, working with Kate, Tim, with other union leaders, with all kinds of other facilities and people around the Commonwealth. And it was hard, but without working together closely, this would not have come to being. So thank you. Thank you to the state and also all the regulatory bodies that we just, having been through a few DONs in my life and a few regulatory processes, this was the fastest ever. We can talk more about that later. Second biggest thank you is actually to the staff at St. Anne's and Morton. I mean, they have welcomed us before we even closed. And working with that team, it's just a terrific group of doctors and nurses and staff, and that has been probably the most rewarding and reminded me of, why are you in healthcare? It's for patients and the great people that work in those places. So to me, sort of the dog catching the car here reinforced my long-lived life in healthcare, and it was really a real pleasure. So the why for us is 3 quick points. One was, at Brown Health, some of you might remember us as Lifespan. That's gone away. So we're now Brown University Health. But as Brown Health, we thought of this largely because where these hospitals were located, we already cared for about 30,000 patients in that community. So that was number one, patients first. How can we be helpful? And second was, how do we focus on creating a thriving healthcare system, not just one that's getting by? And so that was number two. And third was, we had to make sure it made financial sense, and it does. So those were our 3 things that we focused on the why part of it. And I'll turn it over to you, Benson. Welcome, by the way.
Yes, Benson, welcome to Massachusetts.
Thank you. John, you want to talk about dog catching the car? I think that could describe us. So Rural Healthcare Group, the company that was started several years ago, our mission is to improve the lives of people in underserved communities through high quality care, with a vision of increasing access and improving quality. Now we are Revere Medical through the acquisition of the Stewardship Physician Group and network, and that mission and that vision remains the same. And I think what's exciting for us is that mission and vision for primary care there is a lot that you can do with it. And the way we operate, have historically operated our clinics, and what makes us excited about the clinics here with the stewardship acquisition is that it's the same thing we've done in Tennessee and North Carolina, and we're now applying it here. And that's around people, technology, and process. Unfortunately, the clinics that Steward owned that we're taking over had been underinvested in, had not been managed in a way that is up to par with normal standards of primary care. But that's our opportunity, and that's what makes us excited, is because we believe we can achieve our mission of improving lives and increasing access and quality by increasing the staffing in these clinics. Many of them are understaffed, not only from a provider perspective, but a support perspective. Deploying technology into these clinics that is standard across primary care that we do today, and turning that functionality back on, we know will drive access and quality improvements as well. And then process, everybody within the clinic and within the organization has to have a process, has to operate intentionally. And we want to make sure that patients engage with our clinics in a way that is intentional, but also that we engage with patients once they leave the clinic, because care doesn't stop once they leave. And then the last sort of value add I would say is this organization was more a few pieces. It was departments that came together that we ended up taking on. So we are very excited to bring this group of people, 2,000 colleagues, into a company and give them a mission to get excited about, give them the vision, but really give them tools to enable them to do their jobs, empower them to do their jobs, and push that responsibility down where it hasn't existed in the past. And if you can really arm your colleagues with those tools and resources and have them aligned to a mission, that's pretty powerful. So, thank you.
Director Seltz used the word trust earlier in his opening comments. There is no question that the Steward bankruptcy has eroded the trust of patients in our health and in our healthcare system. I would like to ask each of you to tell me what strategies you are implementing or will implement to maintain access, improve quality, try to contain costs, and restore patient trust in these institutions. And Mr. Sloan, unlike the other witnesses on this panel, your organization is a for-profit with backing from private equity investors, mirroring a little bit of what we saw in the previous owners. So what assurances can you give us today that your organization is committed to our state's reporting and oversight requirements, and including maintaining access for those most in need, those who are on Mass Health and Medicare? I'll start with you, and we'll go back the other way.
Thank you for the question. I'll try to answer all of those, but remind me if there were a few that I left off. So building trust, and we've talked about this from the very beginning when we met with stewardship colleagues, providers, patients in the communities when we were doing our research. Trust takes time, and we don't expect that trust to be given. We expect it to be earned. And so that's, what we ask is to have some grace and give us time to allow us to earn that trust and ultimately respect. And that'll come from Revere Medical and our leadership and our colleagues and our providers doing what we say we're going to do. And that is maintain access, increase access, and improve quality. I think how we do that within the organization is what I mentioned earlier around enabling and empowering people and giving them a reason to be excited to work for a company. How we do that within the Commonwealth and frankly the other states that we operate in, because we're not just in Massachusetts from the stewardship acquisition, is engage. Today, engaging with the HPC, registering as an RPO, providing periodic updates to the HPC. So, we have acknowledged that we are different. We are an independent primary care organization. Sure, we are supported by private equity. I view that as a funding mechanism, as there are other funding mechanisms such as not-for-profit funding, public funding. And you can judge all of those three categories for how well they execute, and you can judge us. Private equity, we have the ability to invest capital, and I've already explained several ways which we will do that, but you can be the ultimate judge of how well we do that. And so, we're excited to, enter to Massachusetts. This is a state that has a lot of healthcare resources. Tennessee has some, but not as many stakeholders as you, but that should be a positive, right? We talked about earlier collaboration. Like, we need help. We need to be able to collaborate. Not only is collaborating with legislatures and NGOs, but our other stakeholders such as hospitals and specialist systems and payers. So we're here, and I think that's all I could say.
John?
Thanks. First of all, the access question, I think trust is earned, and we do that by showing up. Let me tell you a little story. Actually 2 days before we officially took over, I walked into Morton Hospital, and there were two women at the front desk, and they said, "Hey, are you the guy from Lifespan?" We were Lifespan then. And I said, "Yes," and they said, "Thank you for coming and rescuing us." And so I think we start sort of ahead of the game with the staff and those communities. We've been embraced. So that's the optimistic part of it, but there's a lot of work to do. The access we have in Rhode Island, I would argue the access we have here in Massachusetts is not good enough. Our number one goal at Brown Health is creating what I call a WOW experience. And that's not an acronym. You can make it up if you want. But it's when you leave our clinic, our emergency department, you go, wow, what a great experience I had. So we're going to apply that to our other hospitals that we just acquired. There are great staff there, but there's a lot of work to do. So I think trust will be built over time. Some of the things we're doing very specifically is we're putting our electronic medical record in those hospitals, starting as soon as we can, like now. We're making those investments in those hospitals so that they can, and the clinics that are there to, and also to recruit physicians. That community, a lot of people had left, especially in primary care, especially at Morton. How do we recruit the physicians and the nurses and staff and help those people? There's terrific leadership at those places, believe it or not, at the local sites. So we have a lot going for us, but a lot to do. Alistair?
Thanks, John. I think probably a similar sort of perspective, honestly, from where we stand. From the beginning, we worked with the teams of the hospital to try to establish plans to minimize disruption to patient care. I mean, even you guys may appreciate, I think what we all found ourselves in was doing, normally if you were doing a merger integration, that might play out with a plan over 9 to 12, maybe even months, maybe longer, and we're sort of catapulted into that over essentially what ended up being a 4 to 6 week period. And so it took a lot of prioritization and a lot of work with the teams there. I think from a quality access trust standpoint, I would say, quality of care, the thing to understand again is, and I think this gets a little lost in the coverage because it was we're covering Steward as a whole. The people that work in these organizations, they are not like Steward Healthcare. They're not. And so there's all the weight of the failures actually don't just sit with us, but they sit on the shoulders of providers that show up and play in their head, really probably for the rest of their career, episodes, situations that have happened where they haven't had supplies, they haven't had the necessary resources, whatever. And so, one of the things that actually we were ready for the challenge of bringing all the employees on board. I would say I was slightly surprised at just the sheer degree of moral injury, within the staff. and the need to build, and how they felt it, like very personally, and how they felt the global criticism of Steward on their shoulders. And I think it's very important for us now that we all have different operators in these hospitals to recognize that these are incredibly valuable people. The question isn't like, how did that happen? The question is, why are they still there? They stuck it out. Like, they had a choice to leave and go to other organizations. They didn't. Many of them actually describe moments where they were like, I thought about leaving, and then I realized I couldn't, because then the whole thing would fall apart. And so I think, from a quality care standpoint, job one for us was just like, simple stuff like, do you have the supplies? Do you have the resources to like do the work that we know that you're capable of doing, because they're excellent.
Payroll.
Yeah, how do we get you paid? Yeah. We had a few hairy moments with making payroll. I think the access ultimately goes to, I think, the path out of this. These organizations, we need to systematically rebuild the services. That involves essentially carrying the service in an underproductive way for a period of time to like basically work to build back volume in those services, preserve employment, and so on. And so that in and of itself is a major financial investment in all these hospitals. And I think trust ultimately is something that comes over time. It comes but also like re-engaging with the community in a way that you probably had this. My colleagues probably did the same thing of, when we showed up at the hospitals, actually people say, we never ever saw anyone. They were actually genuinely surprised to see someone, quote, from leadership, like at the hospitals. And so I think that there's a lot of trust that we have to do within those organizations to nurture them, to make the employees feel valued, to rebuild the morale within there. I'm optimistic because the people are energized and they're really sort of thrilled, but they're also kind of very burned out after several years of this. And I'm looking forward as well to, working to really getting to know the communities much better, because they each serve distinctly different communities, and understanding what those communities' hopes and desires are, if you like, for how these organizations evolve going forward. But it's a great question, and it's I think a multi-year sort of journey of like rebuilding the position of these organizations.
Dr. Agarwal.
Thank you. I echo much of what my colleague said. I think what was surprising to me was that the underinvestment was not only in big items, technology, equipment, maintenance, upgrade of facilities, but so many small, mundane, insignificant things. And when I make rounds and I talk to frontline staff, Alistair talked about moral injury, I feel a sense of resignation and neglect. Like, we are not even allowed to ask for things that we need to do our day-to-day job. So that level of broken trust, a feeling of neglect, and a sense of resignation has been surprising and daunting to me. I shared with Chair DeVoe a couple of examples. I'm just making rounds, I'm on the floor, and I asked a nurse sitting there, I'm so-and-so, what can I do for you? First, she was a bit taken aback, like nobody seems to come and ever ask this question, what can I do for you? And she said, hey, can you get the shades fixed? She was a little like taken aback, so that's all she could think of in the moment. And I said, shades behind you in the nursing station? And she said, no, just shades in the patient's rooms, and they can't get rest. It's not really about the investment in the dollars. It's about not caring and sort of a broken shades theory, if you will, like we had the broken windows theory in New York City. There's also broken trust among so many partners, physician groups, partners who supply. I have spoken to physician groups, I'm talking to them, bringing them on board, and they would say to me right to my face, so are we gonna get paid? I said, do you mean for before 10-1 that you did? He said, no, after 10-1. I said, of course, what kind of a question is that? We are going to enter into an agreement and you will get paid. And same from suppliers. So there has been perhaps this disinvestment and neglect has done more damage than what I would have thought, that simply we will put the equipment and repairs back and all would be good. So what I realize is, in order to build that trust, rebuild that trust, not only do we need capital that we talk about, the money capital, but what we need is to build a social capital. And that's what we are going to need, that social capital, to rebuild those bridges of trust with all stakeholders around us. Patients need to feel, I understood from the obstetricians there, that patients were not comfortable coming because they were not sure if they delivered there, if they are going to be safe. So how do we rebuild that sense of trust, sense of caring, sense of safety among our patients and the staff and all other community holders? So that's kind of our task ahead of us. I like simple things to rally my mind and my team's mind around. So, and of course, Boston, Massachusetts, well known for world, renowned academic medical centers. So what's the role of a community health system? And I talk about this a lot. What we would like to be is sort of big enough to serve you, small enough to know you, and close enough to love you. And that's what we are trying to do to build trust in the community.
Thank you. Let me open it up to my fellow commissioners for questioning. We're on? Oh, okay.
I want to thank all of you for joining us today. And Benson, thanks for flying up. Appreciate it. I think you made some very important comments. And maybe you could expand on one of the comments that you made. You correctly stated that whether you're a nonprofit or a profit-type organization, you have to raise capital, right? The difference is you're raising capital on a private equity side. And to help us feel more comfortable, from my limited experience in that arena, and you're raising capital, they're obviously looking at market penetration, they're looking at revenue, they're looking at the bottom line, and they're looking at an exit, right? Can you explain what may be different in the healthcare arena when you're raising capital and how it would fall in line with what other healthcare organizations on the nonprofit side would do? And I think if you can get into that a bit, just to help us understand how it may be similar. And for example, they're not looking at exits, right? Mm-hmm. I would assume your investors are looking at some sort of exit. How does all that come together? Can you help us feel more comfortable with that?
Yeah, great. So I'll try to break it down in a few ways. One, just to be clear, we're not.
I might just say they're not looking at exits yet.
You can breathe, Secretary.
Say, wait a minute, I've got that set.
You should have seen their faces.
It's right behind you.
That was the record that Kate exited and left.
Yeah, Ron, so to be clear, we're not raising capital right now to do this. We have already raised that capital to not only acquire the operating business of stewardship, but to have enough funds to further invest into it. And when I say invest into it, it's along the lines of what I described earlier around more people and technology. But it's in a way where we want to create a sustainable business. We want to grow Revere Medical so that it is serving this community and partnering with the other stakeholders of this community in a way that is in collaboration with the entire healthcare ecosystem, whether it's a for-profit entity, a not-for-profit entity, or a public entity. I'm not a private equity investor. I don't know how to do that. Well, I know healthcare, I know people, I know how to operate a business. And it is my goal and my team's goal to execute on our mission, achieve our vision of access and quality, so that we have built a sustainable business that can be here forever. Can I be here forever? Sure. Our sponsor might be gone. We might have a new sponsor, but that doesn't mean that we have all new people within the organization turning over. And so I think that's what's exciting for us, is we have the opportunity to build something, build it the right way, build it, for the future, and make a place where people want to work for a long time.
How do they achieve their investment goals?
How does a private equity investor achieve their investment goals? Well, technically they have to invest at a level so when they sell it, they make a return.
Barbara?
Thank you, and thank you, Ron, for the phrasing of the question. Mr. Sloan, I'm sure you can appreciate the fact that we are gun-shy about private equity.
Yes.
Let me ask, I think, part of Ron's question a bit more bluntly. What I would like to know, sir, is what is the relationship of your company with your private equity company? What is their expectation of you in return? And how do we think of you differently than we think of Steward right now in our history?
Sure.
I hope that's a very clear, blunt question.
Yep, fair. And so, yes, I can understand why you have a feeling of being gun-shy with private equity, and I'm sorry that you have that feeling. If you have a position on private equity, I don't want to change that. I can't change that. All I can do is explain to you who I am, and what we represent. And so, my relationship with Kinderhook is I'm an operator for them. And they are an investor for me to provide me and my team the capital to execute on, the mission and vision that I've already laid out. So I think it will be a journey for us to develop that relationship and trust, like I said. And all we can do is ask for time to have that opportunity.
Thank you.
Sure.
Thank you. All right. So my question is also...
Is this my rapid fire panel?
I think it is. I think it is right now.
All right.
So my question is also for Benson Sloan and Revere Medical. So I have a few questions. So you said a lot about continuity and your organization's objective to increase access. Now, as my colleagues just mentioned, the way that your ownership structure is set up, you're likely to make an exit relatively soon, unfortunately. And we're all a bit concerned and worried about what that might look like. But in the time that you have here, there's a lot of reasons why North Carolina and Tennessee are very different environments from Massachusetts. And if your plan is to increase access and you're dealing with primary care, and we know that there are several access issues in primary care that affect our most vulnerable residents, what steps are you taking to learn about Massachusetts, to learn about the people of Massachusetts, to learn about the specific barriers that people face in the different communities in Massachusetts, rural and urban? Is your organization knowledgeable about the social determinants of health? Do you know how the transportation system can potentially be an impediment to access? Have you all come up with a plan there to help some of our most marginalized groups maintain access? That's my first question. My second question is related to stability and ensuring some form of continuity in the very sort of disruptive environment that we're navigating now. So there's reason to believe that for the physician groups that you've purchased, that there've been some disruptions in the managed care contracts that they rely on. Does your organization plan to make good on money that's potentially owed to these physicians? And if so, how? So those are my two questions.
All right. Again, keep me on track here. So question one, healthcare is local. right? Healthcare in Massachusetts in the northern part of the state is very different than the southern part of the state. So, not trying to pretend like I'm an expert or we are an expert on the dynamics of the Massachusetts healthcare. We're rapidly becoming experts over the last several months. But I think what's exciting is, and as some of my colleagues have shared, there are a lot of really good people within the organizations that we all acquired. And because we are bringing over nearly all of those employees, they know the intricacies of these communities, and it's our job to, learn from them, hear from them what they need. And, again, it's our primary care is a growth story. So how do we continue to grow our clinics, grow our communities, grow our colleagues professionally? And so meeting all of our clinic partners, we have all done several market tours across the state to understand, the unique needs of all of the clinics. That was a lot of work, but that was also very enjoyable. It was also very hard. I think every meeting that we had was emotional. At the end of the meeting, our staff, at the time, our future staff were emotional because of the hardship they've been through and then the story that they heard. And it was like, finally, we have a partner. And so, I say that as we have a lot of really good people that will help us understand those intricacies and how we serve the unique populations. Right. Through the process, I engaged with folks in the command center where, hospitals were, shutting down and primary care was the only access point in those communities. And then possibly we're going to lose our primary care clinic because of the landlord situation. And, those phone calls were important because it was like, hey, the bus stop's here. If you're not able to renegotiate with the landlord to stay here and you move a mile down, you're still in the community, but a mile down is challenging for that population that lives there. So we have learned quickly that that's important. And I think we will be able to preserve that access as it is today. The second question, can you?
Was the managed care?
Managed care contracts and payment to providers. Gotcha.
Right.
So, part of the process for our acquisition was to ensure that day one post-close, we had status quo. And status quo was important because we wanted continuity of payer contracts so that we could preserve the ability to see all of those patients across all those lines of business with our providers. Through the bankruptcy process, which, as David said, was a learning experience for me as well this summer, still not an expert on it. Many of the vendors and providers who made pre-petition submissions have been paid because of our acquisition. We have taken on those liabilities post-close with payers. Therefore, however our providers are billing and whatever they have earned in those programs, we will make sure that they are paid. I think it's also a good thing to note that Steward had promised all of the providers a retention bonus of around $75,000 if they were to stay throughout the transaction. And interesting that they made the promise because they were bankrupt, so how could they pay it? We decided, hey, we need to make friends quickly. We'll pay that program. We'll honor that retention program for all the providers. We'll honor their deferred compensation program that was not going to be funded as well. And those bonuses have been paid out at close. It's funny because we got email responses back saying, what's the catch? Is there a clawback? Is it paid 50% at 6? No, here it is. Again, give us a chance. So I think maintaining access, we have a good path for doing that. Maintaining continuity of payer contracts, we've done that. I mentioned status quo. Status quo was to get us to day one. Status quo is not where we want to be, right? Status quo is why we got here. So now all the hard work is around moving forward and structuring and designing what better looks like. So we're excited. Next week we'll have the entire leadership team from stewardship down to Nashville and start those strategy sessions of what does good look like?
Tim?
Do you have a follow-up? Sorry.
No, go ahead.
You good? Okay. I'm going to diversify the questions now to bring other folks into the conversation. I'll give you a little bit of a break, but with a comment. I think you have seen that you are coming into a community, all of us, that have just been burned greatly by the investments of private equity into our healthcare system, and that we all have worked collectively to solve for that problem with new operators coming over to take control and ownership and continue continuity of care in those communities. But what you're saying to us has been said to us before. And it's our job here in the Health Policy Commission and others in the audience to hold you accountable to what you're saying, because we can't have this happen again at the scale that we have dealt with. And so I know you know that coming in here, and I think it says a lot that you are here and the commitments that you made. And our job and responsibility is to hold you accountable to that, because what you have said to us today, we have heard before, and we are still in this situation. So with that, I'm going to move on. Just one quick comment on the question. I know there's others I want to ask it. One, I think greatly appreciate all the comments and thoughts about the workforce and them sticking there throughout this crisis. I think it's important to recognize that the healthcare workforce that has stayed with then Steward and now in the new facilities, that this was not new to them. When it was in the press and public and there was conversations and we were at a crisis level, that the workers that went to those hospitals each and every day have been grappling with these issues for a lot longer than we've all been talking about them. And they stuck with it knowing that there was potentially light at the end of the tunnel that they've been screaming for a very long time. And so their commitment was to their communities, to their patients, and that they've been dealing with it for a lot longer than any of us have. And I guess what I heard in all the testimony, too, was the important role, and we thank the Secretary and the Governor for using their purchasing power, because I heard that earlier today, to ensure that these transactions were able to move forward. But we know in the reports that we've been reading here at the HPC that there's a timeline associated with that state support. And I just want to hear from folks about how you're thinking about the plan post-state support for your transactions. And I've said, reviewing these transactions here at the HPC, the concern is less for me about impact on cost or quality, but more about access. And how are we ensuring the access that folks currently have and the services that are being provided can be maintained without continued state support?
So I can start. I think I want to give two parts to the question.
Now I'm looking for the exits.
One is about what we are up to now, what we are focusing on, what we are doing, and maybe a little bit I touch on the primary care issue that has been talked about the governor as well. So of course, immediately after 10-1 and leading up to 10-1, immediate focus was stabilize clinical care, no patient gets harmed, make sure everybody has access to care, and teams have what they need to do this. Now we want to we are working on putting a very comprehensive integration framework as well as processes. And I believe integration happens at multiple levels. Intramural, within the organizations, we are looking at human level integration. Truly, people who stayed at Holy Family Hospitals are the true heroes in this story. And we want to bring them into our fold, from leaders to all the workforce staff, so that we all feel it's part of one family. Technology integration. We are excited about creating one patient record so that the information flows seamlessly across the continuum of care within the organization, and also gives us an opportunity for efficiency in delivery of care, reporting of care, better reporting of care, standard processes, standard dashboards, and also makes a backbone for innovation, putting AI tools for innovation for us, for efficiency as well as better care. I want to pause on that a little bit. Why am I bringing up technology and innovation here when the question was about cost and efficiency? I believe so many times larger organizations and academic medical centers get what good technology has to offer, and that creates inequities. That is not digital health equity. So we would like our patients and our teams to get the benefits of the same innovations, and we call it equity. How do we have equity in technology? So that's the great opportunity for us. We want integration at the clinical and clinical service line consolidation. What should be offered where so that we do not have a duplication of service lines unnecessarily, with which comes cost and inefficiencies. We want to do financial integration so that any backbone stuff, technology, HR, finance, we have one shared services model. Again, it's the most efficient one. And of course, the governance integration. Very simple rule of thumb. My team knows this and they will repeat it every day. We have to figure out where we need to do the 1 + 1 should equal less than 2 when it comes to cost structure. So how do we become intentional in rolling out everything in this new system? So that's kind of a little bit of where our head is presently. From the primary care perspective, I think that's a conundrum. I'm a primary care physician trained in internal medicine. I also have been practicing telemedicine primary care since 2015, before the onset of the COVID pandemic. And during the pandemic, I could stay awake for 20 hours. The line for telemedicine appointment was so long. So I fully understand primary care, access to care, role of telemedicine in the ecosystem as a practicing physician. I think it's a supply and demand issue in many, many ways. Of course, we just don't have enough primary care physicians. And demand is high, and demand should be higher if we truly want to provide care to patients at the least invasive site of care in the most cost-effective, most convenient care. So it's a supply problem, it's a demand problem, and demand should be higher, but we can't make it higher to meet the supply. I think one of the challenges is that we value physicians' time so differently in the house of medicine, as well as the way payments are made. I learned this from reading the cost trends report, that the 15 minutes of primary care physician time versus 15 minutes it takes to do cataract surgery. The latter is valued at 10 times the RVUs and therefore 10 times the reimbursement. If we do not change that misalignment, as a newly graduating medical student, why would I want to go into primary care? And the focus on mission will get us only that far unless we start to actually address this inequity. And therefore, the role, and in our integration, I definitely wanted to mention, we have a great community health center right in our neighborhood, less than a mile away, Greater Lawrence Family Health Center. So our integration and strategy for primary care absolutely includes integrating the Greater Lawrence Family Health Center and all it has to offer to create a great primary care strategy. So, and also finally, what can telemedicine do to address the supply shortage? So let me stop here.
Yeah, I know we have other questions, and I want to allow the rest of the panel to try to answer Tim's question. Alistair.
Thanks so much. I'm not sure if I'm now answering your question, but maybe I'll pick up with some comments that kind of spread across. I think is consistent with your question, Tim, and other questions around capital. So when you when you step back and Tim, you said we've been here before. How do organizations raise capital? So, if you go back to the beginning of the Steward story, that was a case of an undercapitalized system that was seeking capital to reinvest into a network of hospitals to kind of keep them going. And they sought capital from private equity. So then the question being is how do we actually as nonprofits then raise capital? And it's in two forms. One is either from your balance sheet, or you go and raise debt. Both of those are dependent on a sustainable financial model. So this is where Secretary Walsh, we get to block the exits. Now the state have stepped forward to varying degrees across these organizations, and in some instances, I actually provided substantial amounts of capital to essentially recapitalize them, to invest in physical plant, that has been massively disinvested in, to invest in transition costs, things like moving electronic medical records, to invest in keeping operations going while we rebuild services. But when you kind of look beyond that, it's a great question. You get into what is the underlying financial model of these organizations that are substantially government paid, serving patients that are substantially insured by government paid patients. And so you kind of get into, therefore, the sustainability of reimbursements, probably principally through the Mass Health Program. And so I think that we are going to have to actually be working on this in the next couple of years. We've had, and you will hear other panels no doubt today, talk essentially about a generational inflationary event that's happened in the last 2 or so years. That's affected workers. That's been passed through to employers. Well, our labor costs, I'm actually scared to ask how much they've actually gone up in over the last 18 months, but I'm going to guess it's in the mid, 10 to 20% range. It's been kind of staggering. And that's required to support people living their lives in the communities and actually having livable working wages and so on. But there needs to be a reset on the reimbursement side, writ large across the system. For safety net organizations, we do not actually have recourse to go to third-party payers to then pass it back, both from a market power standpoint and also by a mandate that is overseen by this policy commission to maintain and control healthcare cost growth over time. And so I think we're going to have to collectively look at that, the level of reimbursement, but not just that, the nature of how it is paid. And so I do think we need different payment models applied to very high government payer organizations that provide a different set of incentives around less kind of getting people turning through the organization, more around how we think about using technology, how we think about lower unit cost ways of delivering care at scale into communities that are more affordable for the Commonwealth, because it's all coming out of the same tax base that are providing education and others. But I think that this is something that we collectively as a system across providers, payers, employers, and government are really going to have to wrestle with. Otherwise, we will, in sort of a few years' time, be back with an undercapitalized safety net and no route, and somewhat in the same situation again. And so that's something that I think we should all be thinking about and working on and reimagining what our role is at this point in time.
John, a really quick answer, and then I want to turn it over to Manny. John?
Sure. I'll be quick. I'd say two quick things. One is that I think we would be kidding ourselves if we think I've been at this for 6 weeks, and to think that we have found all the little problems would be naive. So I'm not saying there'll be more asks, but we could find some things that we haven't found yet. So I think just as a commission and a state and a provider, we have to just recognize that. Number two is, I think Alistair's on to the root causes. Our payment system needs a fix. We have a crisis in healthcare in Rhode Island. We also have it here in Massachusetts. And these hospitals, we took a super crisis and entered into a crisis in healthcare and access and money that we need to resolve that was here before and is still here today.
I'm told we have 5 minutes, so Maddie, a quick question.
Quick question is, and so we know we have a healthcare problem and we talk about reimbursements, but a lot of this has been going on for a long time. And we've had inequities that have existed for a long time prior to all of this. What do you think? I think about the people in the community who suffer from all of this going on. What are you going to implement in your institutions to improve health inequities, to improve health equity overall in the community? And mind you that this has been going on for a while, whether money or not. So what would you do differently?
Is that for the panel?
Yeah.
Okay.
You can go first.
I'll go first. I'm excited to answer this one. Because this is what primary care is about, right? Primary care is about longitudinal care. It's not episodic care. Now, of course, we do provide episodic care, but when we talk about affordability issues in the Commonwealth, but it's a a U.S. problem. It is important that primary care has the right tools in place to be able to manage a patient, from cradle to grave, whether they're commercial, whether they're Medicaid, whether they're in fee-for-service, whether they're in risk, and doing it in a way where we're coordinating with hospitals, specialists, other stakeholders, payers, and reimbursement is a way to do that. Also, a way to do that is through value-based care. And so, a lot of what we have done as an organization is to put in place, clinical models and programs so that we are able to manage patients more longitudinally to take care of, all of their comorbidities and issues that they may have. So I think, that sort of philosophy is certainly how we subscribe to delivering care, and what we think will be beneficial to Commonwealth in the future.
Anyone else want to weigh in? No, and David, I know you had a question. Oh,
Alistair? No, I was just going to say I think you guys know the work of BMC is like fundamentally rooted in health equity. We have been on this hunt for a very long time and will be for a very long time, no doubt, because there are problems that have taken generations, and there's a system built up to actually almost embed them that we are sort of, on a year-to-year basis sort of fighting against. So yes, we take a very holistic view of our communities, of what they need to thrive. A lot of it is not actually within the four walls of like a hospital. It's actually going out and trying to meet patients where they are. It is also, though, about really interrogating the work that we're doing and looking at how we often unintentionally actually do things that lead to disparate outcomes. And so a lot of the answers for us actually reside in communities. And I think that as we look at these new facilities, part of that will be going into the community and actually looking at the challenges that they have, the nature of the social fabric, if you like, in those communities, and how we might best go and start there and figure out what our role is relative to those communities to help them thrive. Because I do think hospitals are, it's a bit of a cliche, sort of like can be anchor organizations that really sort of can provide a lot of leadership locally. And that's what we would seek to do in partnership with them.
Can I just also ask Mr. Fernandez to answer that?
Sure. So my short answer on this would be, when we think about equity, I would say we ought to start with pay equity. And I mean not worker pay equity, although that's an important thing also, but pay equity, our lowest income people, we get reimbursed the least for. So until we fix that problem, the inequities start with doctors don't take those patients, and we go from there. So if we don't fix the pay, if we don't follow the money, I think we're missing something.
We're given essentially the hardest problem, which is overcoming a set of societal structures that have led people to a very disparate set of healthcare outcomes, right, that are shocking and we want to correct. And then the payment for that is actually, a fraction of actually what is, is ultimately provided. And ultimately it's a much more complex product, if you like, that you're actually range of interventions that you're trying to actually deliver on, to really get at, outcomes. Just to echo that.
David?
Yes, thank you. My question's for John. John, you're not new to Massachusetts, but Brown Health is. And you said that Brown Health wouldn't be entering this market unless it made business sense. And the region that you're entering is a very strained region. It's a region that, we call it Region 5 here in Massachusetts, that has always been, had incredible capacity challenges. It's got incredible behavioral healthcare needs, substance use disorder needs, mental health needs, primary care access needs. And I noticed earlier this week, one of the organization's decisions was to apply for and invest in outpatient cancer services. So I'm curious, when you're making decisions about expanding services in this region, have you done an assessment of health needs in the community? And further, have you already done an assessment of what services are already being provided in this region by the facilities and providers in this area?
I'd say we've done some assessment. We're in this for the long haul. We've looked at these as, I think these communities, just to be very fair, the payer mix that I inherited in Providence is worse, if you will, low pay, high pay, than it is in the communities we entered. So we're used to a high government pay area. So we think that's why when we went into it, we thought we could make a go of this. And the thing that happened in Norwood that you're referencing, we saw it as a place to continue to provide care and keep the jobs in that community. And so that's why we did that. But we have not done complete market assessments. This all came on pretty quick, but I have a pretty good sense of the markets that we're in, and so that's where we're at. We'll do more community assessments and all that as we go.
Well, I want to thank our panel. I think on behalf of all of my colleagues, we want to wish you well. You have a hard task ahead of you, and we hope you're successful in your endeavors. So thank you for testifying.
Thank you.
Thank you.
Thank you, and we'll invite members of the second panel to join us at the table. And I'll mention for participants in the room and online that we will break at 12:15-ish for 45 minutes, and then reconvene at 1. But just in terms of pacing
My
yourself.
house is very trying. It just sucks every bit of moisture out of me. Thank you, thank you. Thanks for that question. I was thinking
Yeah, everyone's being really nice to
A
me.
good first step, as you said.
Find the exits, yeah.
Okay.
Now you're on this side.
Yeah.
You-
Yes, you're going to be at Harvard Chan on Tuesday, right? You're going to be at Chan on Tuesday. I think you're doing a Q&A.
I said, am I?
Yes. Look at your calendar.
You know, my schedule.
I know. I'm here to remind.
Into that, but want to keep us on track.
right.
So it's now my pleasure to introduce Commissioner McGregor, who's going to moderate and oversee the discussion of the panel.
All right.
And welcome panel members.
Okay, good morning again. So I have the distinct pleasure of welcoming the members of our second panel, which is titled Putting Patients First, Voices of Impacted Providers, Workers, and Communities. Now, the purpose of this panel is to hear from community leaders and experts directly affected by the bankruptcy and dissolution of Steward Healthcare. And we'll hear from them about their experiences and the impact on the affected healthcare workforce, communities, and patients. Panelists will have an opportunity to discuss their perspectives on building a more resilient, affordable, and equitable healthcare system. And speaking personally as a resident of Hyde Park, one of the Boston neighborhoods impacted by one of Steward's closures, the closure of Kearny, this crisis has hit close to home for myself and many of my neighbors. And so, like many of you, I'm excited to hear from some of the leaders with us today on the front lines. So let's take a moment to welcome them. Is this swearing in happening? Or no? It's all set. Okay, great. Great. And so at this moment, I'll introduce each of our panelists. So furthest to my left, we have Dr. Guy Fish, the CEO of Codman Square Health Center, with us today. Next, we have Susan Joss, the CEO of Brockton Neighborhood Health Center. And we have Caridad Medina, the Vice President of Steward Health Team for 1199 SEIU United Healthcare Workers East. And we have a mentor and collaborator of mine, Dr. Bisola Ojikutu, the Commissioner of Public Health and Executive Director of the Boston Public Health Commission. And finally, we have Julie Pinkham, who's the Executive Director of the Massachusetts Nurses Association. Thanks so much to each of you for being here today. So I'll start us off with the first question of this panel, which is, how have the recent Steward Hospital closures and other recent healthcare provider disruptions impacted the people you represent? So this includes the providers and workers and the communities your organizations serve. And what are the highest priority needs you've identified in the communities you serve at this time? So we'll start with Dr. Guy Fish, because we've already read some of your comments in the news media on this. So thanks so much for sharing with us.
Thank you, Dr. McGregor, and greetings to the Health Policy Commission and Secretary Walsh. At Codman Square, I've been there all of 4 months now. But it's been a wonderful learning curve, getting to know the community, getting to know the health center, and getting to know about the problems. Rather rude awakening the day or so, a week or so that I landed, hearing that Kearny was closing. That was the first surprise. As Sue can tell you, it's hard enough running a health center without having to face these kinds of challenges. But the aftermath of that closure, which was rather precipitous, right? Was felt at all levels of the organization and the patients and the community. We have had community members speak to us, patients speak to us who received their specialty care at Kearny Hospital and a primary care at Codman, saying that they're shocked. It felt like, in essence, a betrayal that it happened so quickly. We've had people say, I got my care there for 25 years. Where am I going to go? I'll have to go to Brighton to get my meds and see my specialist, because that resource in our community has been ripped out. When it comes to our staff and our providers, we feel it most acutely in the urgent care setting. We have been monitoring our weekly utilization in urgent care. Typically, we see about 400 patients a week there. Now we're at 500 patients a week. 20% increase, and it's lumpy. Our usual daily census was 75 patients, heavier on Monday, around 100, because we're closed on Sunday, and so there's a backlog of demand. But when you have the Kearny closure on top of that, Mondays are now like 110. But we also have people who show up, register, and walk out because of the wait. That's another 15. So we're really up to about 125. That's a 50 to 60% increase on a Monday. And Tuesdays are looking like Mondays now, whereas they used to be the average. There is stress that happens with my urgent care teams. I've been meeting with them and organizing them to bring forth ideas that they have about triaging and about resourcing. But it's really felt acutely. And when they hear the stories of these patients, their patients who are coming in with access issues, we heard about moral injury before, they're seeing it etched on the faces of their patients. So the other thing that we really haven't seen yet, these disruptions can have immediate impacts, but they also have long legs. And we know that from looking at the public health data that came out of Hurricane Maria in Puerto Rico, where people were saying, oh, it wasn't that bad, only 58 people died, right? But then you do the research and you find out what is the death rate that is above the norm, right? The incremental death rate. We're not there yet. We haven't seen that. We haven't seen the economic impact. With Kearney Hospital closing, there were thousands of employees who got sandwiches at the local shops and bodegas. That demand in the community, that knock-on economic impact, we haven't seen that yet. But when we do see it, it will result in there being people from these other shops that now have to close, some of them, being unemployed, being on public assistance, and coming to us with the delayed and deferred care. And we are seeing an increase in acuity as well, the people who are coming to our health center who have deferred care and are sicker. So that's an economic impact that we have yet to face. These are slow train wrecks.
All right. Thank you. Susan Joss.
Thank you, and thank you for including community health centers in this hearing. I would say, as a health centers as a group, we're a bit bruised and battered, and in Brockton, and you probably asked me to speak because we're the most bruised and battered right now. So the Steward bankruptcy is just a piece of what's been going on in Brockton. So I'll give you a little bit of that. So of course there was COVID, and we stood up big time in one of the most affected communities. And as we were just coming out of that, we were in fact in a planning session around bringing our patients back into care, some of whom hadn't had physicals, had been afraid to come to us because we were the COVID clinic and thought they might get infected. Literally that week, Brockton Hospital closed due to fire. And we were actually in a Joint Commission opening session when we started getting texts from the midwife who was laboring with a patient and smoke was filling the room. So that was closed for a year and a half. We were thrilled to have them back open. And our OB department was the most affected because we were at Brockton Hospital 24/7. Within days, had our whole operation moved over to Good Sam, which really honestly didn't have the capacity for our 600 deliveries a year. So that was a huge strain on them. They did their best. But then at the corporate level, you all know what was happening. We started to have, the stories you've heard about lack of supplies and lack of staffing. We actually had to put extra midwife coverage on duty because our patients, just from a safety perspective. So the other thing I think that happened when Brockton Hospital closed and Good Sam's ER got flooded. So Good Sam's, I believe, 42-bed ER was often at a census of 120-ish. So from our perspective at the health center, we were finding our patients going to the ER, waiting sometimes 6 or 8 hours, not being seen and coming back to us. So we started seeing much more acute patients that in some cases should have been admitted, but were afraid, wouldn't stay in the ER, were afraid to be admitted. We started developing relationships outside of Brockton to send patients. Most of our patients were afraid to do that. So At the same time, Compass Medical closed during all of this crisis. That was 70,000 patients. No sites directly in Brockton, but all the towns surrounding us. So the primary care crisis just escalated at that point. Then we started seeing new migrants. And for the first time ever, about a year ago this month, started an adult patient primary care wait list. We had never had one before. That wait list currently sits at about 1,200. On the pediatric side, we did not start a wait list. However, we know that in Brockton Public Schools, there have been about 1,200 new migrant children, mostly migrant children, coming into Brockton Public Schools, and we don't have the capacity to take them on. So we know that there are children in the school system not immunized, among many other things. So the capacity in Brockton is just so strained. We've had other things happen as well in the interim. There was a substance use treatment program that closed, and of course, our mobile van just moved to that site and was there a day a week, and that eventually resolved. But I think the governor's comments about the health centers always stepping in when something happens has strained us to our limit. And right now, so we thought our theme has been one crisis after another, and what else could happen? So last week it was a cyber incident, and our health center has been closed and is still closed today for the past 2 weeks. And that has given us some insight again into the interactions between community health centers and the hospitals, because where are our patients going these last 2 weeks? They're going to the ERs. So I think the theme there is we need to stabilize and strengthen the community health centers, because we can be so much more. And if we're just bouncing from crisis to crisis, so our patients who didn't get in for care, for primary care, and especially physicals during COVID, didn't get into them when the hospital was closed for fire, because now we're in crisis mode. Didn't get in as we lost capacity when Brockton Hospital reopened and lost some staff to them. And now we're closed, hopefully opening tomorrow. But so it's just one thing after another. And health centers, I think, need the resilience both financially to be able to really weather that and really be the safety net you need us to be.
Thank you. Yes. Ms. Medina.
Hi. Thank you for having me here, and thank you to the commission. Even prior to the closures, we had surveyed our members and our workers, and they responded with letting us know that there was poor worker morale, missing supplies, and short staffing. Imagine this, in fact, at St. Elizabeth's Hospital, or Medical Center, one of our surge techs had the very person who hands the instrument to a surgeon said to the president when we were in a meeting talking about the survey results that she would not allow or recommend a family member to have a procedure at their hospital because she found it or considered it to be unsafe. Because of these closures, more than 1,000 of our members lost positions. We worked really quickly to try to get them into the sister hospitals. There were 200 distinct job titles. The workers felt slighted. They wanted to understand, why this happened. We unfortunately didn't get to place all of those workers. There were only about 101 that took positions, so hundreds of members left. We're afraid that they left the healthcare system, period. We don't know where they went. These individuals were not only healthcare workers, but they also are patients. They utilized these facilities, and we now have to figure out what we're going to do. They share the same concerns as people here on this panel around health equity. Access needs to be timely, affordable, and accessible. So thank you.
All right. Thank you very much. Dr. Ojikutu.
Thank you, Dr. McGregor. First of all, it's wonderful to see a mentee excel and do amazing things. It's very humbling. Very impressed by your work. I'm honored to be here. So in Boston, we've obviously experienced the closure of Kearney Hospital. I think that we're continuing to grapple with the resulting impacts of that closure. It's important to really understand what was existing in the areas, the catchment areas that Kearney Hospital served, prior to closure in order to really understand the impacts. We're talking about a catchment area of Dorchester, Mattapan, Hyde Park, and areas outside of Boston, so including Quincy. And so I think Dr. Castile already mentioned that the reality is that significant inequities existed prior to Kearney's existence, while Kearney existed, and will most likely be deepened, and we're seeing some of that impact in these sort of early stages, but will be deepened. So we're talking about persistent, pervasive inequities, and this is just one piece of a larger puzzle. In the primary catchment area, and by primary catchment area, I'm just going to talk about the neighborhoods in Boston that were served inpatient discharges based on the CHIA report from 2022, Dorchester, Mattapan, and some of Hyde Park. You're talking about, people of color who've been made vulnerable, many of whom were non-U.S. born, lots of linguistic diversity, lots of folks who have preventable cancers. We know that in the area, we have a higher rate of preventable cancer mortality, preventable mortality from cardiometabolic disease. And also, one of the things that people haven't spent much time paying attention to is the fact that we have seen a trend in increased overdose mortality in those neighborhoods. So if you combine those three, so preventable cancers, cardiometabolic disease, and overdose mortality, we're actually looking at life expectancy that's 15 to 20 years lower in census tracts, particularly in Dorchester and Mattapan, than in other areas in Boston. Some of this is from our Health of Boston report, and certainly you can take a closer look at that. But I'm emphasizing that this is longstanding impacts that aren't just related to health service delivery, and certainly aren't just related to the closure of Kearney Hospital. But focusing in on that closure, certainly Kearney provided inpatient behavioral health services. We know this, and we know that this is very important. And we also know that there's significant unmet mental health needs also based on our Health of Boston reports that we need to address. And we also know that emergency services are increasingly needed in the area, about 30,000 emergency department visits. I'll say that as a healthcare provider, so I'm an infectious disease physician at Mass General Hospital, I know that, some of my patients went to Kearney Hospital just because they didn't want to wait at some of our larger health centers. It's certainly what happened, and with the closure, certainly that's missing. What we've seen, I think Dr. Fish has spoken about in terms of the impact on community health centers. It's obviously not just Codman, but Dot House and Mattapan Community Health Center, with increased wait times for primary care physicians, certainly increased urgent care visits, all of which has created backlogs, and it's stressing a system that was already stressed. So I'm really honored to be the co-chair of the working group that's really looking at these issues and trying to design a way forward and make recommendations to the governor and to the mayor about how we should proceed. I guess I would just end by saying that I know I said a lot of negative things, a lot of things to be worried about, but I'm really thinking about this as an opportunity to look at the healthcare ecosystem in Boston as a whole and figure out how we can do things better and how we can do them differently. Certainly, it isn't just about what happens within the walls of healthcare, as we all should know. But it is important, and we need to figure out how to deliver health services better to folks who have been made vulnerable. Thank you.
Thank you so much. Julie Pinkham.
Good morning, everybody. Nice to be here. Thank you. Try to answer this in the most succinct way because the Steward experience isn't a current one. It's one that's been going on for 15 years. So I would be remiss if I didn't at least mention the experience of Quincy Hospital closing, having gone through that when there was a guarantee of those services being available for, I think it was 10 years under the original agreement. That never happened. So we've lived through some debacles with Steward along the way. And then, of course, there was the Norwood flood So when we talk about the Brockton area, first we lost Norwood Hospital, right? Then we had a fire, and that's like apparently the only way we do capital improvement of hospitals in the community is by flood and fire, because now we'll have some new institutions there eventually. But along the way, there's just been major debacles. So in Norwood, I mentioned that by way of example because we moved, both 1199 M&A and all the other workers moved out of that hospital and were reallocated to all the other Steward facilities through agreements made with the union to lease the employees of Norwood and then return to their prior institution, which obviously never happened. They were then subsequently reabsorbed into other institutions. But I think this group of people is probably the most nimble group of people I have ever met in my life. And that's saying a lot because there's some pretty nimble people in healthcare out there. But they've been through a lot. You've heard the stories of them buying products themselves to cover patient care, and they did. They used a variety of methods to deal with the issues that they faced on a daily basis, including embarrassing in the press, marching, you name it. They've tried it all over a decade to try to get the services delivered to the patients that they want to take care of so badly. So when we faced this, I think there's two things that were felt immediately: a sense of relief, obviously for those institutions that were acquired, that were now going to be nonprofit. And I don't think for a minute I take away, with no disrespect to the earlier panel, private equity and for-profit in healthcare, sorry, it just doesn't exist well together. It's oil and water. Nothing good eventually will ever come from it. You will always lose something. There's a dollar lost, and that dollar could have been spent better in better ways elsewhere. So I think we found that really a painful way 15 years ago, and I think we'd be remiss if we allowed ourselves to, in the disbelief that that's not going to be a similar outcome going forward. So I would say they're glad they're nonprofit. They see some belief in that. But I also say that there's some grief there, obviously, because two institutions were lost, and those are people that lived in those communities. I think you've heard from people. For the nurses and the health professionals, they can go anywhere. I mean, it's not like at this point in history, they're pretty, able to move. They chose to stay in their community hospitals and to be with their communities. And these are people that use these hospitals. So to lose them was a very, very big loss. And I think we're still feeling that. We're still reeling from that and trying to see whether or not there's a future there still for healthcare in those communities like County and Neshoba. So I think there's the grieving, I think there's the relief, and the last point I would say is I think there's not going to be a lot of latitude from the workforce. They've had platitudes for 15 years. They're at the ground level. We make health policy, we do things, but the people that see them are the people that are delivering the direct care. They feel it on a day-to-day basis. So I think we have to listen very closely to the people on the front lines, what they're seeing, what they're feeling, and what they believe is absolutely necessary to improve the situation. If we do not listen to them with the same credibility that we give data, which takes longer and is equally important, but I do think the anecdotal day-to-day experience is valuable right now for the people that were willing to stay and deliver care, because there were no assets to sell to anybody if the workforce didn't stay. So we owe it to them to listen to them very, very closely.
Wow. Thank you all for just the detailed and just deeply impactful testimony here. Before I turn it over to my colleagues for additional questions, I just want to comment on just the overall findings of the cost reports reinforce the fact that we spend so much on healthcare as a state, and yet it's clear that our healthcare system is so vulnerable to bankruptcy, to natural disasters, to cyber attacks, and that the workforce and patients really bear the brunt of that. So in terms of a follow-up question, if I may, I want to keep it on the theme of workforce and ask, what are the necessary steps to revitalize, strengthen, and support the healthcare workforce in the future, given that the bankruptcy and dissolution of Steward Healthcare has has impacted a significant number of workers, as you've explained, and the fact that the Commonwealth has struggled over the years with workforce disruptions and shortages. So I would welcome any of the panelists to answer that question.
I guess I can start because we do have some positive stories on this side. So I would say, first of all, for community health centers, we don't pay market rate wages, and we lose staff all the time to other levels of healthcare, especially the hospitals, because the differences can be 20 to 30%. So I think stabilizing and retaining our staff would be a high priority. But to focus on some things that have worked, so the state's loan repayment program has been fabulous, and we have, I think, 12 staff currently on that loan repayment program, and it's a 4-year retention there, so really urging that to continue. I think even more specifically, we've had a few grants around workforce development that enabled us to identify the positions that we couldn't hire. And in our case, that was social workers, medical assistants, and dental assistants. And we brought that training program in-house with those grants, and we now no longer have any shortage in those 3 positions. So I think that's a program that works. It keeps staff in the health centers. Most of the staff that we brought through that program were our own staff who may have been secretaries and, various, we had a housekeeper. The social work students are obviously coming from the schools, but the others, are really homegrown. And so we're able to keep them, retain them, give them job growth. We have just launched a psychiatric nurse practitioner residency program. And I know that, that is also keeping and attracting staff who want that training. We're working on our primary care one right now. So I'd say those programs work.
All right, great.
Thank you. It was wonderful hearing the governor this morning speak to the primacy of primary care. Fantastic. But there are things that we can do to, as Dr. Ojikutu said, change the ecosystem to get to a different result. All right. The first thing was mentioned earlier, which is pay parity. Because right now, commercial insurers are being essentially subsidized by government dollars when they pay less to community health centers for the same services than Medicaid Mass Health does. So there is a bill that's been put out to ask for pay equity, pay parity with commercial rate insurer rates, and that needs to be advanced pretty immediately. The second is that I just spent the last couple of days talking to my my front staff, my PSRs, patient service representatives. They're the people who greet you when you walk in the door and figure out, that Dr. Smith is or is not on schedule and ask you to wait and give you the paperwork that you need to fill out. And they gave me an earful about how, particularly in our communities that have a significant proportion of people from different ethnic backgrounds, if there is not the availability of people who speak the language of the patients who are showing up, it slows everything down. Our throughput goes just terrible. We do believe in technology. We have brought on board a language interpreter services, the web-based, the whole 9 yards. I love technology, but it's not a panacea. And it's still, even with that technology, the handoffs and the drop-offs are fairly frustrating and almost unbearable. The solution is to bring in more physicians and providers and others who actually speak languages like Haitian Creole in our Dorchester community. There is another proposal on the table through the Health Equity Compact, of which I'm a proud member, to get a physician pathway program together. We have physicians who are graduated and have practiced in other places in the world who come here and are just completely shut out of the system due to our medieval guild system, of which I'm a part, but we need to change that and allow these individuals with the means, mechanisms, and technology that we have to demonstrate their capacity and competency, and then move into practice. And then third, I would say that, as John Fernandez said earlier, follow the money, right? We need to put our money where our intent is. The Massachusetts is one of several states that never brought back Medicaid GME dollars, which is a 50-50 match. It's a win-win for everybody. But if we did, I would ask that we focus on primary care and providing funding to residents who are committed to entering into primary care fields and staying in primary care fields, and not provide those dollars to overglut the market, which is already in an overglut position, and driving in a supply distortion to the market, too many specialists.
Thank you. So it's critical to start by listening to the workers. The worker voice is really important. We think that it should be the guide to reform. Workers must be included throughout the implementation of any reforms and to ensure the best outcome. Like I said earlier, we talked about the workers flagging concerns years ago. And obviously workers deserve better pay, good working conditions, including the lowest paid workers. We have to remember those EVS workers that through the pandemic ensured that the hospitals were clean enough for doctors and nurses to be able to come and practice. Also the direct care workers who are the ones that bathe and get the patients up to walk around to ensure that they are eating. Secondly, Massachusetts needs a more robust state health plan, a plan that ensures we have workforce. We need to provide all necessary care across the Commonwealth. And that brings me to number 3. We need more state support for incumbent worker training that provides career ladder opportunities. We need a renewed focus on retention and job quality and not just the recruitment of new staff. In other words, we need to train the new hires, but we also need to make sure that we keep the experienced workers. Thank you.
So if I might add a few points to the comments that I agree with that have already been stated. First of all, I thoroughly appreciate our Boston healthcare workforce, of which I'm a member. But I would also say that oftentimes we stratify by healthcare versus public health as though they're separate things, and we have to realize that health is really the goal. Therefore, all of them need to be acknowledged and honored and amplified. And when we're talking about the public health workforce, we're talking about the folks who work in our shelters, our street outreach teams. Many of our community health workers are in the public health sector as well as in healthcare. And it's all a fluid system. So let's keep that in mind when we think about what we mean by our health service workforce. Secondly, we've talked a lot about primary care, and I trained as a primary care physician before becoming an infectious disease specialist, and obviously, we need more primary care providers. I haven't heard as much about our behavioral health workforce, and we thoroughly need to focus our attention there. One of the things that we're doing in Boston, and I know work is happening across the state, but one of the things we're doing in Boston is we've developed a partnership with UMass Boston to train nearly 200 new behavioral workforce providers, service providers, many of whom will work with youth, but others who will work with adults. And I think the key with that, because there are lots of programs, I know, but the key with that is that they are required to stay and work in Boston, because that's the other problem, is that we train and then people go elsewhere. Many of my friends in various different specialties have left. Thirdly, I want to mention EMS and emergency medical services. Okay, this is a major concern. First, obviously, because we're here to talk about Steward and Kearney, obviously I mentioned the needs there, but across our state, we are lacking in that area. We need more folks who become EMTs and paramedics. They are a crucial point of connectivity between our communities and our health service providers. So we've reestablished our cadet program to bring in new folks who are Boston residents into the ranks of Boston EMS and really try to build a pathway. I want to build on what Dr. Fish mentioned, the Health Equity Compacts Act to advance health equity, because I've talked this far sort of almost, these are I guess system changes that need to be made, but sort of programs. I really think we need to be thinking about structural change. What is it we can do in terms of enacting policies that codify some of what we're talking about and really make it things that's going to be sustainable going forward in our state. And one of the aspects of the Act to Advance Health Equity is strengthening the healthcare workforce. And part of that bill is really looking at how do we keep people and provide them with the right professional development so they stay in these fields. Because, you have lower level, people who come into a health service delivery jobs, and then they don't stay because either they're not paid well enough or nobody's offering them a chance, a ladder, somewhere to grow, somewhere to really truly build a career. So certificate programming, really thinking about lower wage positions and how you build them up through the ranks. So those are the kinds of things that I would like us to focus in on. I think the point here is that we can't just sit and sort of wait for a highly trained, resilient workforce to evolve. We really must intentionally find the funding for programming, and then also enact policies and really think about sustainability if we want to support recruitment and retention of a diverse workforce going forward in terms of our health ecosystem.
I'll try to be quick. I'll break it into two different groupings. One is sort of generally speaking from a health policy economics perspective. Can't really talk about the workforce if nobody has jobs, right? So if we keep closing services or hospitals, it's sort of a moot point. So other than really wanting single payer, which some maybe before I die, that will happen, I don't know. But in the meantime, I would say since the 90s, we were trying to do managed competition. I think that was an abysmal failure. We put all the scorpions in the bottle. We just have a lot less scorpions. And I'm not quite sure what the bottle's left even at this point. But rate setting, and at the end of the day, I think we have to go back to rate setting from our perspective. We need to put the folks in a room and we need to equalize the structure and we need to give value to the fact that certain patients require more care. And if we're going to value people, then we have to put our money where our mouth is. And instead of letting the market and, cost shift constantly to have that be the eventual outcome, I think we just do it diligently in advance with planning and hopefully with some carrots, not just sticks. Carrots that would actually incentivize institutions to take care of their plants. We saw in Brockton that the reason why it went down is because they had redundancies in their electrical room. We should probably make sure that if we're going to build new services that are lucrative, we make sure that the institutions are viable to withstand anything that happens to them as well. So I think we have to build in those guardrails, so I'm all for rate setting. I also think that if you remember North Adams when it closed, like in 72 hours, which shouldn't have happened either. I can remember the then Attorney General Martha Coakley indicating that she wished there was something that she could do, but there really was nothing because she had no ability to do anything. In essence, as she said to me, what will I run it with? And I said, good point, unless there's some mechanism of even receivership or something where the state really can. You can't just say something is essential and then not be able to back it up. Right? And that means us as a group in this Commonwealth have to say if it's that important, then we need to value it in whatever mechanism that we have to make sure that the money is there that allows the state to do that, even if it's only on a transitory basis until we find the right players that make sense in the system. But I think we have to do that. So receivership. I also would say in that regard, there's some big players out there siphoning off money at this point over the years. We talk about pharma. I don't see how we have a conversation about money without bringing pharma into the fold in some capacity. But there's others, the medical device companies, and I also think at this point we haven't really openly talked about it, but if you remember, we pushed the electronic medical record, and I think that was for all the right reasons. But if we look at the cost associated with having done that on an ongoing basis now, we've siphoned away dollars, I think, that would have been able to be spent in other ways that we can't now. So those players all have to be brought into the fold and part of the solutions as well. now switching directly to the workforce. Diversity is something I think in general, from our profession anyways, as you can look at me and many of my colleagues, we lack a sense of diversity, I think, in our profession. We'll be honest about that. I was sort of disillusioned. I was really excited at the time that there was a lot more push in the community colleges, which I think really was an opportunity for a lot more of the workforce that looks like our patients and the communities that they're working to go in to enter our profession. And I don't think it was with malice, but nonetheless, there came a time where the institutions in the city of Boston, predominantly and elsewhere, were only hiring registered nurses if they had a bachelor's degree. And I was like deflated, because we set folks up to enter a profession and then we cut them off at the knees. So I think we have to be mindful, if we're going to invest in programs to bring people to the workforce, that the people that provide the jobs have to equally support those decisions and not then subsequently make decisions that undermine the effort in general. So I do think a lot of the certification programs, the community colleges, I think we did a program even in the, we found that, for example, in the operating room, the average age of a registered nurse in the operating room is generally 5 to 7 years older than everybody else. So that we saw as being an enormous problem because, as you all know, to do it in the operating room, you need at least a year's experience just to do basic surgery in any operating room. I thought, oh my God, we are going to be in deep trouble here along with some other specialty areas. So we went about, tried to see if there was a way that we could work with some of the institutions. And I'd say that this is an issue that we need to deal with, the reticence of players to work together, this kind of turf war or just paranoia, I don't know what it is, but getting in a room all together just to have a conversation was difficult enough. Eventually, it turned out that they didn't sort of want to work with us. I'll put that in the most diplomatic way that I can. They didn't want to work with the M&A. So we decided that, we still needed to do this. So we came up with a program in with the state, with the Workforce Development Group, and they were great. And we developed an OR training program using sim labs and gave them all the didactic, and then went about having a conversation with the folks that we work with at an institutional level, whether or not there wouldn't be value in having us do this program and maybe train up some OR nurses. And that allowed the nurses in the institution who would have never been able to get a job as an OR nurse. How do you become an OR nurse? If you're working on med surg or the ICU, you can't pop down into the OR. It doesn't work that way, right? And who's going to give you a year's worth of experience? So most of the institutions rob from each other and give people 10 and 15,000 bonuses to steal each other's workforce. So we're like, let's not do that. Let's encourage people from the floors of the ICUs to gravitate towards this specialty and then allow other nurses to gravitate to that specialty and keep them all within the institutions where they're familiar with the policies in the community. And I would say that we learned a lot in doing it. I will say in programs that you do, particularly, I think we would ascribe this to behavioral health as well. The first round on retention wasn't as successful as we would like. We learned on the second round what was important to bring in. ORs can be a bit toxic, to be honest. They're a special area, right? So there's a lot of interesting personalities and players in that environment. So we brought everybody into the fold for the conversation right away and said, this is a joint program. Its success or failure relies upon all of us. If you don't help it succeed, then you will not have a person in the OR. Right? So it was everybody's program at that point. And the other thing that we did that was really important was we had people come and shadow for an extended period of time. Because just because people think they might want to do something doesn't mean when they start to get their feet into it, they like it. And I think in each of these specialty areas, which is really where we have to focus the money and the energy, we should give people ample opportunity to shadow and see whether or not they really would want to do it. Otherwise, we're going to try to train up people and they may just leave anyway. So that was longer-winded than I thought. Sorry.
Thank you very much. All right, so at this point, I'll turn it over to the other commissioners who might have some questions. All right. Commissioner Castile, and then I'll turn it over.
So as most of you may know, I am from Worcester, and I have to bring up the issues because, and I know that Steward, that whole collapse was an incredible thing. But I also wanted to say that we've had the same in the sense. We lost Leominster, Neshoba's in our area, Ayers is in our area, Hayward, and we're suffering in the same way. I think that one of the things, I guess, for me is you have a task force that you're working together. And what I'd like to see is how do we do that together? We did a piece of that in Worcester, where we brought the free clinics, we brought the health centers, we brought the hospital to talk about, because the one who was hurting the most, amazing, everybody was hurting, but the free clinics, because they were getting all the people. If they were trying to go in the ER and the wait is 3 hours or 4 hours or whatever, they would end up going to the free clinics. And everybody started to help one another. And so a lot of times we talk about resources and we don't have resources, and I get that. But I also don't see collaboration. I always talk about that COVID was the best time I ever had, not because of what happened in COVID, but the fact that it's the only time that we all sat around and we talked about data, we talked about what was happening in the community, and we all worked together, from community to people who were in healthcare, who were in public health, all worked together. And I guess I'm trying to bring that into our whole system, that we need to sit and talk about how we share services, or how do we learn from one another? What are you doing that maybe we're not? You know, UMass has hospital care at home. Who else is doing that? How can they share that expertise so we can figure out ways to deal with those issues? So I don't know if it's a comment, but you can add your 2 cents.
I'd like to speak to that for a second, and it gets to one of my major stump talk points, which is that we would need to be careful in our language about having a healthcare system. We don't have a system. We have an industry, all right? The difference is that a system connotes some degree of planning and connectivity, and there's learning and self-learning. We have an industry in which the participants basically maximize self-interest, okay? And to your point, during COVID, that was when it changed for a brief shining moment, right? But there's good news, right? There are other places outside of 128 and outside of Massachusetts who have been working on things called cross-sector partnerships. And when you think about cross-sector partnerships, getting the insurance company that doesn't really want to pay for transportation, but the health center that knows this patient needs it because they're on the 5th floor of a walk-up, right? If you get them to understand and align on the goals and the objectives, you actually get cross-sector partnering, which lowers the cost because now this woman is cared for, not popping into the ED 5 times a year, right? So there are ways and mechanisms to do that. In addition to it sounding like a lofty goal, you have to actually get to the economics of that. And there's literature out there that speaks to how you get past either the wrong pocket problem or the free rider problem to show what the economic incentives are for all of the participants for that particular issue and get them to either pay in or share from some of the proceeds to get the work done. So I would suggest that we really invest in looking at cross-sector partnerships that are out there in other geographies outside of Massachusetts perhaps, and figure out how we can get those parties to the table just like we did in COVID, but with an economic underlaying as well.
I totally agree with your point. That was very well stated. You know, I would just add to that by referring back to the working group idea, Dr. Castillo. So, you know, during COVID, we had a common enemy. There was a common foe, you know, and everybody could buy into the fact that we have to address this common foe. Now, and before COVID, there's no unifying North Star. You know, it's about our patients, not our neighborhoods per se, you know, not our communities per se, though that language is often used. That's not what it is. And I think recognizing that is very important. The interesting thing about the way that I hope we're looking at this situation that we're currently in is that maybe this is a way to rally around change. You know, if you bring this working group together, and I know Tim is a part of the working group, and Guy, Dr. Fish, is a part of the working group, we've brought together in Dorchester, for the Dorchester working group, and I just call it Dorchester because that's where Kearney was located, but it's across many different neighborhoods. It's really an impressive group of individuals. You know, you have the major hospital leaders, you have the electeds, you have the community health centers, you have community leadership, you have the unions all at the table, and we're all there to talk about unmet needs, and it's under the auspices of post-Carney, but the reality is these are the unmet needs. They've never been met. So let's talk about them, and let's think about what the recommendations should be to address them. And those recommendations are going to go beyond, specifics related to the land use and what's going on there. It's beyond that. It's really talking about how do we do things differently going forward and collaborate better, really thinking about where the funding streams are going to come from to improve care delivery for populations who have been made vulnerable. So I think that's what we're sort of looking for, trying to catalyze that change in the setting of these working groups.
Thank you.
Can I speak? Okay. I just wanted to speak a little bit about Neshoba Valley and one of the unique challenges to that area, and that is the geographic disbursement. Many of the hospitals we're talking about here are in urban areas, and there's a concentration. So residents in the catchment area that were previously served by Neshoba are experiencing reduced EMS response times and a strain on the EMS resources. Most of these are one ambulance towns that are in fairly dispersed area. The turnaround time for ambulances increased 2 to 3-fold. Patients with heart attacks and trauma, which were normally treated at Neshoba, now require longer transport times. The speed and accuracy of emergency response can literally mean the difference between life and death for these patients. There are ER overflows at hospitals from Leominster to Lowell, to Emerson, to Marlborough, and beyond, even into Nashua, where some of these patients are now being transported. And once they get there, the patients have a much longer time they have to wait to be seen. So I just want to say we can't abandon any healthcare needs, but I want to be a little bit of a voice for Neshoba because I feel like they're a little bit overlooked in this whole process. They experience many of the same issues, workforce issues, loss of local care, but they do have this one unique challenge that we need to solve for. And back to Governor Healey's remarks at the beginning, we need to be bold and innovative. We need to think about standalone emergency room structures in various parts of our state to meet those immediate needs where time and access are of the essence.
Mm-hmm. Right. Do any of the panelists want to respond to that, to those comments?
I knew I was going to go. We're actually on the working group, and there's a wonderful lady that you might have met, Audra, who actually testified in Congress as well and was an ED nurse at Neshoba. And I think my comment would be, I think that we need to not rule out small hospitals. Do you know what I mean? Sometimes we keep following the same playbook, and I think what's happening is, when in the 90s, when we first talked about market competition, a lot of the old articles would say we're going to increase access, increase quality through competition, and decrease price, none of which happened. And at the end of the day, I think the belief was that the institutions and the academic centers were going to send the less acute patients out to the communities, and that would be cost savings. I don't think I think it played out somewhat in the end. I don't think it's playing out at all. And I think along the way, because of this, in order to have efficiencies, we're now making like housing factories of certain services. Maternal child health is like, well, you get to go to that hospital and you can just schlep your butt all the way from wherever you came from. And so we're seeing a lot more babies being delivered in ambulances on the side of the road. Some in apparently Ubers is a more recent one I heard. So yeah, it's sort of extreme when you think about the state that we're in to believe that any of this is happening. And I think along the way we've lost sight of the fact that maybe if we think within this group and in general in policy, that the role of small hospital is still a much needed and very good one, but maybe not in the same way that it was. All right. And I think that's the part. Right now, it feels like we're throwing the baby out with the bathwater. We're just closing the small hospitals and closing the community hospitals. And I don't think it's making the situation better. It's driving everybody into the academic centers, which are more costly. We are now taping tape on the floors of the EDs and calling them by street names in order to identify where the patients are because there's so many in the halls. That's really not the best delivery of care. So I would love, frankly, Neshoba does serve a rural area. It's a long way. I do think, yes, an emergency department is important. There has to be some bells and whistles that goes with that. But I'm always interested when we talk in a fractured way about the community health services and the hospitals as different fractured entities. And I'd be really interested in the conversations that we're having is how do the community health services see the role of the hospitals in the community in terms of what do they need from them? Because I think that's really where the relationship needs to be built, because they cannot do certain services, and what they need when they need to send those patients. So what is that role, rather than sending those patients into urban centers where they're going to sit and wait for extended periods of time, often for a much higher price care. So I just think let's maybe take a relook at the small hospitals and what they should look like in this new environment.
All right. Okay. I think, do we have time for one last comment? Okay, so we're pretty much at time. We're a bit over time. But just to close, I think the accounts shared on this panel definitely, I think, drove home really what's at stake when for-profit actors are able to enter our healthcare system with too few regulatory guardrails. And the ripple effects it has and the deeply inequitable impacts it has on Black communities, communities of color, rural communities, and otherwise marginalized communities. And so I think as we move forward in our discussion today, I've heard a lot of people bring up the need for a sort of state healthcare resource planning mechanism, or a state health plan, which is written into sort of both of the market oversight bills, which we hope will pass soon. So just encouraging everyone to sort of continue that conversation as the day progresses. So thank you so much to this panel, and we will very soon break for lunch.
Yeah, thank you so much. Thank you. And we will now take a 45-ish minute break for lunch. We'll reconvene at 1 o'clock. There are lunch available here for those who would like to stay in the room, but also obviously feel free to leave Suffolk and get lunch nearby. Right, visit a local business, and we'll reconvene at 1 o'clock.
Oh, I agree.
you all for reconvening and welcome to our third panel. We're going to start this session. The third panel, as you know, is industry leaders on the threats and opportunities facing the Commonwealth's healthcare system. And the purpose of this panel is to hear from the healthcare leaders about their perspectives on the current state of Massachusetts healthcare, including all of the challenges that we've been talking about so far today across the market, and most importantly, to talk with us about their view of the path forward, both in terms of their own actions as the leaders of the largest organizations in Massachusetts, and also about their view on what we, HPC, and government can do. So to start us off, I'm going to ask our Executive Director for the HPC, David Seltz, to do a brief presentation of data that will inform the discussion.
Great. Thank you, Madam Chair, panelists, and members of the audience. Before we begin this afternoon's session, we want to ensure that we ground this discussion in facts and research. So I'm going to quickly present a few data slides on drivers of spending in Massachusetts, a scan of data insights from across the care continuum, and end with a focus on affordability of healthcare in Massachusetts. First, I want to begin with what we know about spending trends and drivers. We know that overall healthcare spending is accelerating in Massachusetts and exceeded the healthcare cost growth benchmark in the most recent year. In particular, commercial spending growth in Massachusetts was higher than the U.S. average, higher than inflation, and higher than wage growth. On this slide, we're showing the two categories with the highest growth rates, pharmaceutical spending and hospital spending. And as shown on the bottom half of the slide, within these categories, it is price growth, not utilization growth, that is the primary drivers of this spending growth. Next, understanding that in our healthcare system, we have interconnected problems across our care continuum. The following slides highlight some important statistics in different settings of care. We're going to begin with primary care. As we heard from the governor earlier this morning, primary care is an essential part of a well-functioning, efficient, patient-centered healthcare system and is worth investing in. However, current market trends are going in the opposite direction. There is a declining proportion of the healthcare dollar going to primary care compared to all other medical services in Massachusetts, and now stands at just 7.7% of all commercial spending. This lack of investment in primary care is leading to ongoing access challenges. As we note on the left-hand side or the right-hand side of this slide, in a recent study, Boston had the second longest wait times for a primary care visit among major metropolitan cities. These delays may result in patients foregoing necessary care, leading to an exacerbation of preventable illness. It also may lead patients to seek care at a hospital emergency departments, even though they could have been safely treated in a community setting. The statistics on this slide reflect an opportunity for greater investment and prioritization of primary care, as well as the need to address the primary care workforce pipeline. This is a topic that the HPC is going to be focusing more on in early 2025. Next, let's move to the hospital setting. This slide highlights some key data points on the high use of hospital services and other high-cost services and settings of care in Massachusetts relative to other states in the country. While the Commonwealth Fund ranks Massachusetts #1 for our overall health system performance, it also ranks Massachusetts 44th on the measure of avoidable hospital costs and use. Other measures confirm the high use of hospital care in Massachusetts. We have the third highest Medicare readmission rate and the second highest preventable admission rate among all states. The statistics on this slide reflect an opportunity for care delivery and payment innovations to safely provide care in less intensive and costly settings. We're going to stay on the hospital setting for one more slide because we know that many hospitals are wrestling with difficulties moving patients into the most appropriate setting of care once they arrive in the ED or are admitted. This slide highlights two of those challenges: ED boarding and difficulty discharging certain patients to the appropriate post-acute setting. On the top, we highlight that 48% of patients presenting in an ED with a mental health condition resulted in a stay over 12 hours. This is a much higher rate than pre-pandemic. On the bottom of this slide, we highlight new data insight that on any given day, there are many long-stay patients in hospitals across the state. We found that nearly 10% of patients have been in the hospital for over 30 days. Even further, there are some patients that have been in the hospital for more than 3 months. These rates are double what they were in 2017. In both cases, ED boarding and these long-stay patients often represent a tragic failure of our system to be able to safely transfer and connect patients to the most appropriate care setting that is often not an acute care hospital, and whether that should be a community mental health provider, a psychiatric hospital, a post-acute rehab hospital, or a skilled nursing facility. The statistics on this slide reflect an opportunity to identify and expand solutions to reduce these rates, which will require collaborative effort across care delivery settings, health plans, and government. The challenge in finding and placing patients in the most appropriate setting is also reflective of changes in the healthcare workforce since the pandemic. On this slide, we're showing one example of that in the change in employment levels for home health and nursing facility sectors in Massachusetts and the United States, comparing the 2024 levels to the pre-pandemic baseline. As you can see on the left, while the employment in home health in Massachusetts remains 12% below the pre-pandemic baseline, the rest of the country has not only recovered, but is now at a much higher level than before. On the right, you can see that employment in nursing facilities in Massachusetts has not recovered nearly to the same level as the rest of the country. And while not shown here, shortages in behavioral healthcare workforce are also significant and interrelated to system throughput barriers, such as mental health ED boarding. These statistics represent an opportunity to focus on strengthening and expanding our healthcare workforce across the care continuum. And the HPC is going to be focusing efforts on expanding and strengthening the behavioral healthcare workforce in 2025 through the Behavioral Healthcare Workforce Center. Finally, there are two dynamics to be addressed as context for this panel discussion. First is the unstable and volatile financial position of many of our hospitals and health systems. As has been widely reported, in the last quarter of financial data from CHIA, the median hospital's operating margin was negative 0.9%, meaning that more hospitals had negative operating margins than positive. However, medians and averages can often mask significant variation underneath these figures, so it's always important to look deeper. Here we observe that there is significant variation among hospitals and health systems on financial performance, which does make for a more complicated analysis of root causes and the identification of solutions. Understanding the variation is also important when looking at other metrics of financial performance. For example, we note here that while the total net assets of hospital health systems has increased by 56% since the start of the pandemic, 86% of that growth has accrued to just the top 3 systems, contributing to widening disparities among net assets. This slide just arrays the operating and total margins for Massachusetts hospitals from 2023 and the first 3 quarters of 2024, and is just illustrative of the variation I just mentioned, with many positive margins and negative margins. The final dynamic, and the one that I hope the panelists will keep in mind as we discuss all of this, is that the high cost of healthcare in Massachusetts is already out of reach for too many residents and businesses. Massachusetts has the second highest family insurance premiums in the country, and the average cost of healthcare for a family now exceeds the cost of housing in most parts of the state. So it's no wonder that when asked, Massachusetts residents said that the cost of healthcare was a significant concern and is their top concern in healthcare. and almost 1 million Massachusetts residents said that they went without needed care due to cost. And remember what I said earlier about averages? Well, when we dig deeper in those numbers, we find that these affordability challenges are disproportionately experienced by populations and residents of color and lower income, contributing to widening disparities. These are significant challenges, and as our governor challenged us this morning, we need to have bold and innovative solutions. So I'll turn it back over to you, Chair DeVoe, to lead this panel's discussion.
Thank you. Let me start by introducing our panelists. We have Eileen Owen, who is the Executive Chair of the Board of Directors for Point 32 Health, Dr. Eric Dixon, who's the President and CEO of UMass Memorial Health, Sarah Islin, who is the President and CEO of Blue Cross Blue Shield of Massachusetts, and Dr. Ann Klebansky, who is the President and CEO of Mass General Brigham. Welcome. I'd like to start by asking the first question of our panel, which is really in three parts. First, what is your assessment of the status of your organization, of the Massachusetts healthcare industry, and some outlook on solutions and possible ways to address these challenges? So challenges for your organization, the broader industry, if you have those reflections, and then how do we go forward, both in terms of your own actions and the actions of the HPC or the government. So can I start with you, Sarah?
Thank you very much, and thank you for the opportunity to be here today. I am profoundly grateful to live in a state that had the foresight to create this commission and to establish a healthcare cost benchmark and to hold these hearings every year. And I'm even more profoundly grateful to be living in a state that values equitable access to healthcare regardless of who is in power in Washington, D.C. When I sat in this chair last year, I was, along with you, sounding the alarm about the growth in healthcare costs. At that time, I said the trend that we were seeing at Blue Cross Blue Shield in Massachusetts was 8%. I sit here now a year later looking at an even higher healthcare cost trend. The trend that we are seeing right now is 10%. It is the highest growth rate we have seen in at least a decade. And much as I wish that this was a blip, I don't believe it is. I believe this is really our new high water mark as we look forward. And everything that Director Seltz just talked about in terms of the drivers being provider prices and drugs are exactly what we're seeing in our own claims. And so I sit here even more profoundly concerned about the stability of our healthcare system, about the affordability of healthcare in this state than I was last year at this time. And I'm not just saying that as the CEO of a health plan, though when you all see our financials that we expect to report early in the year about just how we did in 2024, you're all, if you were going to ask me what keeps me up at night, you'll know the answer to that. It is a pretty challenging time. But it also just worries me as a resident of this state. It worries me as a business leader and an employer. It worries me as a friend and as a mother. Because this is a competitive issue for our state. We know that people are leaving high cost of living states when they have choices about other places to go. It is a business issue because employers are struggling to afford these costs on behalf of their employees. And it is a deeply, deeply human issue. It is hard to worry about anything else if you're worried about accessing care at the vulnerable moments of your life when you need it. And that's especially true in communities, vulnerable communities and communities of color. And we know the number one reason is because of healthcare costs that people are struggling with access. And so as Director Seltz just went through, I felt pretty great in the early years of our cost containment law. Back in 2011, Massachusetts had the somewhat dubious distinction of having the highest healthcare premiums in the country. And in the early years of your work, of the work of this commission, we actually saw significant progress and we dropped to number 12 in the country. And as we just heard, we are now back up, whether it's family premiums or individual premiums, we are now back up at number 2. So there is a lot of work that we need to do. And I know that everyone on this panel shares these values of healthcare access. And it is going to take all of us working together to make progress. And it's a balancing act. I know that providers all over the state are struggling in ways, big ways and in smaller ways. But this is a real challenge because employer costs are provider revenue. And if employers can't absorb these costs, the tools that they've often turned to is shifting more expectations to their employees in terms of paying more for healthcare. So I think we're in a really tricky position at the moment, and I'm really looking forward to this conversation about where we go forward. It is our belief that the only way forward is for a stronger role and a deeper partnership with government. To get back to having a healthcare cost benchmark that we all collectively take seriously, that has serious consequences that we welcome for ourselves too. I think we should all be held accountable for making more and faster progress, working together on affordability. So thank you for the opportunity to be here today to have that conversation about how we all work together to ensure we've got a healthcare system that meets everyone's needs in the decades to come.
Thank you. Dr. Klubansky, can you comment?
Thank you for the opportunity to be here today. So I'm going to start by saying that what we are experiencing as a healthcare system really reflects the entire state in different ways. So if I look across the entire healthcare system from the provider point of view, we are all extremely fragile. I have to pick the one word, I'll say fragile. And this is a state, and I've been here most of my life, which is renowned throughout the country for its leadership in health innovation, in the best medical care. This is one of the things we stand for. So when I sit here and say we are in a very fragile position, I just think it's important to recognize the broad ramifications of that for people in the Commonwealth and also for how we are looked at as a national leader in healthcare. So all of our hospital systems, in varying degrees, are undergoing major challenges and disruptions. It's all gotten worse since COVID. There are sicker patients coming in. And we've already heard about the long lengths of stay, people who sit here for a long time. And that's a complex configuration. It's having people coming into the ED. Across MGB, we are at capacity, this disaster capacity, all the time. And for those of you who are, and I'm very grateful to those of you who came to our ED and walked around and saw it, until you walk those halls and see patients on stretchers who have been admitted with no place to go, under bright lights, with the screaming, with the noise, with the turmoil, with the incredible burnout in those places, you don't really understand how fragile it really is. And this is true all over the state. So we have a huge increase in inflation, huge increase. 60% of our costs, that's people. And what we're seeing is higher inflation, higher pressure, lack of access, and everyone's falling behind. So you haven't seen the fourth quarter results yet. They're going to come out, next month. But we are just on the brink. And, I am projecting next year across Mass General Brigham probably $250 million in operating loss. So these are huge numbers. And that's us. We're the biggest system in the state. But I look around, you're going to hear from Eric. I've heard from my other CEOs around the state and around the country. Everyone is suffering, but we are disproportionately suffering. So I just want to get into a couple of things that really relate to that. Capacity challenges we've talked about, disaster capacity 95% of the time. We are, and you've mentioned this, we are near the top of the country in capacity challenges. So everyone around the country is worried about capacity. We're near the top of the country. And you look at the data, we're near the bottom of the country in ambulatory build-out. So unfortunately, as a state, we are not providing care close to home. We are not. So I'm looking at Mass General and the Brigham. Those are our two academic medical centers. They are built, really, for that highest level tertiary quaternary care. Thousands of patients get transferred in. Not anymore. There's almost 2,000 patients who desperately wanted to come into those academic medical centers for treatment they couldn't get in community hospitals. We can't take them anymore. Why? 60% of the care at those higher level, let's call them academic medical centers, secondary care. Secondary care. That care doesn't belong at Mass General and the Brigham. It belongs in community hospitals. In fact, a lot of that care belongs in the community. Look at the surgery that we're doing in a lot of those, at both of those hospitals. Don't belong in those hospitals. A lot of it doesn't even belong in community hospitals. It belongs in freestanding ambulatory surgery centers, which you will see all over the country. So the opportunity to get rid of some of this incredible capacity, these long waits of time in the ED, a lot of it is thinking about a distributed care model. And, you know, to your point, having more primary care doctors, absolutely critical, absolutely critical. Thrilled that the state is endorsing that. I'm so glad there was a discussion about that, 100% supportive of it and grateful for it. But it will not solve, it won't solve the capacity problems because we need to be delivering care closer to home. So we've done a lot in terms of trying to deal with this. We have incredibly efficient ways of bringing in transfers. We do whatever we can to move people out. But the post-acute setting is hard to find, and that's one of the reasons we've invested so heavily in home hospital. You know, we're the largest home hospital in the country right now. It's lower cost care. It's not only closer to home, it's in the home. Those are all really, really important things, and I know Eric has a home hospital program as well that I'm sure he's going to be talking about. But I would just summarize it by saying a lot of this is a Band-Aid around the fundamental problem that I'm seeing for our system, which is we are delivering the wrong kinds of care in these settings that are really designed for tertiary and quaternary care. And until we have more community hospital capacity, and most importantly, until we're able to bring care out into the communities and have a process that really understands that is lower cost care, that everyone will benefit for, that's going to be a problem. The last thing I'll say, because I know we're going to have a lot more discussion about many of these things in detail, is you have to look at the total cost of care. So thinking about commercial, very important. But look at Medicare. Look at Mass Health. What does that look like? And if you look around the Commonwealth, you can often get a good sense of how individual hospitals and systems are doing based on that. So unless we rethink that payment model, we're always going to be looking at only one segment of the entire situation. So I know I have a lot more things about this to say, and we're going to have a lot more discussion, so I'll turn it over. I'll turn it back to you.
Thank you. Terrific. Dr. Dixon?
Thank you so much for the opportunity to speak today and to be here. We all want the same thing. You know, we want better access to health care for our people of the Commonwealth. We want lower costs. We want higher quality. And I was so glad you started with the Commonwealth Fund report that ranked us #1 in the country. That includes affordability and access in terms of building it into the overall ranking. We won't be #1 for long if we don't figure out how to improve access and reduce costs. And I've practiced medicine in some form here in this state for the better part of 4 decades. And I've watched what's happened. Many hospitals that I've worked on in the past are gone. And I've watched what's happened across this state as a lifelong Massachusetts resident, and we are headed in the wrong direction. There's no question about it. Healthcare costs too much in this state, delivers too little to the people that are paying for it, especially if the color of their skin is non-white. And I think every one of us agree on that, and that's the problem we all want to work together to solve. So I was so happy that you started by talking about the data, Director Seltz. And as two physician scientists are at the table here, and I'm very proud that my fellow faculty member at UMass and one of Ann's researchers shared the Nobel Prize in medicine this year, and that's something we should all be proud of in this state. Sometimes scientists look at the same data and come to two different conclusions and do the wrong next experiment. And I think what we all want to do is look at the data, interpret it correctly, and then put in place the right countermeasures that are going to solve the problems. And that's where I think we've wasted a lot of time over the last 10 years in healthcare at a federal level and maybe even at a state level. You know, the promise of ACOs significantly dropping the overall cost of care in this country has never come through. We had a successful ACO on Medicare this year, as did MGB, and we're going to have a successful Medicaid ACO with 0.32 this year as well, we hope. And so we're all working in that space, but that's not going to drop the cost of care by 25%, 2 or 3% at best, and then you got to pay for the ACO. So what are the things that we have to do to bring the cost of care down, improve access, and empty out our hospitals, which are completely full right now? First and foremost, we have to focus on primary care. Why don't we have enough primary care in Massachusetts? I am a faculty member at a medical school that was created to bring primary care to Massachusetts, and it's pretty simple. We lose $200,000 a year every time I hire a primary care doc. And so I have to get a place for that person to practice. I need to put an IT system in, and I need to hire staff to support him or her, and then that person starts practicing, and we lose $200,000 a year. It's really hard to make it up in terms of losses and to invest in primary care. And when you know you're going to lose more money, and the average operating margin for a system in the state of Massachusetts is minus 1.7%, 5 years running, and that came from Director Peters' group. And I know we show hospital data, but we all run systems. We don't run hospitals. And so if you look at the system data, which includes losses on medical groups, you'll see that the numbers are worse. And as somebody that formerly chaired the board for America's Essential Hospital that represents the safety net hospitals across the state and across the nation, the numbers that look the worst are your safety nets, are your high Medicaid providers, and that's the case everywhere in this country. So we have to fix primary care, and we have to increase primary care payments, in my opinion, or we're never going to get the primary care access we need so that we can take care of patients at the earliest point possible and keep them out of the emergency department. And that's coming from an emergency physician, because there's so many things I see that 2 days earlier, it was a $25 prescription, and now it's a $25,000 admission to the hospital because the severity of the illness has progressed. But people couldn't get into the primary care, and that's why they waited, and that's why they ultimately came in to see me. So better payment for primary care. We are way behind in this state in terms of administrative simplification. Many other states have passed laws in terms of the scope of pre-authorizations. And if you watch what a primary care doctor is doing, it's very little primary care. The number one reason for burnout for a primary care doctor is administrative burden put on them. And that's why we're losing more primary cares. So we need better payments for primary care doctors. We need Medicaid slots for residencies. We started a primary care track at UMass Chan, completely unfunded. So now we're producing primary care docs at a loss through the residency so they can come work for us, and we can lose another $200,000 a year. That's why you don't have primary care doctors in this state. And administrative simplification so that we can let the primary care doctors practice primary care. That's a big part of this. We need to increase the Medicaid rates, because if you don't do that, your safety nets are going to fail first. Right. And then they're going to end up at the higher cost providers. That might be our academic medical centers or the two that Ann oversees. But we have to lift the bottom here up. And maybe that's a floor in terms of commercial rates, taking into consideration of what your payer mix is and your overall rate, not just your commercial rate. But certainly it should start with the Medicaid rates, which are unfortunately inadequate for to be anywhere close to covering the cost of the lowest cost hospital. The third thing is we have to focus on innovation. And I sit in my office now and see patients in their home through a paramedic that delivers, that can do a physical exam, give me all the vital signs, put them on a remote patient monitor. I can see the cardiac monitor, do remote labs, point of care testing for laboratories, put in an IV when we could get IV fluid, give them IV fluid, deliver medications, including antimicrobials and antiemetics, things for nausea and vomiting, things for infections, and not transport the patient to the emergency department. And the paramedics are out in the street anyways. Just go back and check on the patient in 4 hours, and if they're not doing better, then you can bring them to the ER. And what my CFO would say is the only reason we do that at UMass Memorial is because our CEO is an ER doc. And that's part of it, but we have to look for innovative ways to try to take care of patients that are going to be not just transport to the ER every time. And so you are at the center of healthcare innovation. 2 best hospital at home programs in the country are represented at this table. The only 2 programs in the country that I know of that are looking at post-acute care, post-hospital care, being delivered in the home instead of in a skilled nursing facility is MGB and UMass Memorial. And so the challenge with the innovation is it just all loses money until we get the payment system to catch up. And I was so happy to be working with Sarah's team that they're going to now pay for those mobile integrated health visits after a hospitalization, such that, and we're going to look scientifically to see, does it reduce readmissions? And so, what I would say is primary care are the top 3 things. And there are ways we can get more primary care here. Residency slots, better payments so we don't lose so much money. It doesn't cost a lot in the grand scheme of things. Leverage the federal dollars that you can get to support that by increasing Medicaid rates and getting those Medicaid residency slots. Make sure we focus on bringing up the safety nets first, especially the critical regional essential hospitals that if they go down, there's nothing else in the region. And then, help us innovate, because we know how to innovate, especially here in Massachusetts. And we have mechanisms to deliver higher quality care for less money if we can just kind of get unchanged and find, partners to work with. Obviously, I mentioned what we're doing with Blue Cross Blue Shield, and we've done some innovative things with Point 32 as well. Bringing hospitals in and healthcare systems in that have had an average operating margin of minus 1.7% for 5 years, losing money, and it's going to be worse in 24 based on everything I've heard.
Right.
And saying that that's the problem, we get a lower rate at the hospital, you will destabilize. You will destabilize this healthcare system. The system, it's already destabilized. You're going to make things worse, not better. Because if you look at the data, hospital rates in Massachusetts are amongst the lowest in the country and what we're paid. The problem is, what Director Selt showed, people are in the hospital too long and too many hospitalizations relative to other states. Yep. It's not the rate, it's the utilization. And most of that has to do with not an inability to get them out of the hospital. So again, we all want the same thing. We're very excited to be working with you to come up with solutions together and, set us loose, and we'll innovate and find ways to solve these problems.
Thank you. Eileen Allen, your assessment and outlook?
Thank you. First of all, that was, I'm relatively new here. I've been involved with the board of Tufts and Point 32 Health since 2016, but I recently took on my current role where I'm getting deeper into the issues. But I will say, starting with what Director Seltz showed with the data, and all 3 of these folks have pretty much completely summed up what the issues are and the challenges are that we're facing. To not be redundant, I will echo that we're seeing the same level of trends across the board that Sarah spoke of. And I think I've been around even longer than you, so I could tell you it's unprecedented. It's been decades before we've seen these kind of healthcare trends. And they're continuing into 25 based on all the data that we have. So the pressures are continuing. There is a lot of pressure for continued unit cost increases from providers for all the reasons that they just explained to you, inflation, other. But from our perspective, it's hard to continue to pay more, right? Because we're continuing to drive the spiral of the lack of affordability of healthcare to our to the members of our Commonwealth. So, and the cost shifting, and it's a spiral that's going on. So, agree, that's a good, succinct analysis of the situation. And then in terms of what are our tools and what are our strategies to move forward, I would echo what Sarah said about setting a benchmark that has some teeth in it, that we can all work towards, a goal, an audacious goal that we can say, let's really try and control the cost side of the house at that level. And then the ability to try and reimagine our model, to move more care back into the communities, as Anne spoke about, and to get people help where they need it in the home. And our ability to be innovative about those things will ultimately, I think, is the only way that we're going to fix this. The question is, how do we contain this in the short term while we can do this hard work of innovation and reimagining how we're delivering healthcare to a vast majority of our residents?
Yeah, just maybe 2 comments. I think, first of all, I just have to keep coming back to the deluge of patients and the capacity at all of our hospitals, especially the academic medical centers, to be at this kind of capacity is dangerous for quality and safety, for everyone. We see increasing violence in the workforce toward our people, whether it's in the ED or anywhere else. But I want to get to some of the key things of what can be done. And I want to just clearly link that to care in the communities. And also a point that was made about experiments. You might think of it as an experiment many years ago to say, if we are going to preserve community hospitals, we need to prevent these higher cost systems from going out there into the community. That's kind of a hypothesis. I think what we've learned is none of that's worked, because community hospitals all over the country and in this state are under siege. And yet at the same time, the larger healthcare systems are increasingly fragile and less stable, and access couldn't be worse. Capacity is at its highest, outpatient is at the lowest. So I think that really does give us an opportunity to think about how do we deliver lower cost care closer to home, or in our case, even in the home, or even more broadly. If we can't do that, we are going to have these higher cost academic medical centers, which relative to the rest of the country are actually pretty low cost. These are going to be taking care of, again, 60% of patients are secondary care. That's an embarrassment for us. And not being able to bring in patients who really need tertiary and quaternary care. So unless there's a rethinking, which we're happy to do together, of what is the process? How do we get that ambulatory surgery out into the community at lower cost that doesn't need to be done at our academic medical centers, and it often doesn't even need to be done at community hospitals. So I really do want to emphasize that. When we think about why patients come into the ED, and Erica's spoken about this, and I'm a subspecialist by training. That's what I've done for many, many years. I was seeing the other part of it. There are often management that is being done by subspecialists, but you can't get those patients in either. So they wind up coming to the ED. It's always winding up coming to the ED. So we need to be thoughtful, not only about primary care, but how we set things up closer to home, because we are not going to be able to lower the cost of care if we don't need to sacrifice that. We need to have those centers do what they're meant to do and really democratize care and think about it in a very different way. So I just really want to emphasize that point, because that is something that we actually can do together. And just one comment about the benchmark. I do think it's just important to set something that's reasonable, and maybe it's over 3 years. I don't know. It's a discussion. But given where inflation has gone, given that 60% of our costs are labor and they are skyrocketing, no matter how many efficiencies we try to do as a healthcare system, and there are a lot of them, bringing our academic departments together, really looking at how we can have a much leaner administrative structure, setting up home hospital, having all transfers come in through a single access center. We're doing what all the healthcare systems are doing, working really hard to be efficient. That's great. That's important. My point is it's just not enough. So I just want to introduce a reality to that because I think that's important, and that's an important discussion for all of us.
Yeah, Sarah.
So as I just reflect on this conversation, one of the things that I think is implicit in what we're all saying is a call for a need for more intentional health planning. And doing that over a time horizon, I've heard people talk about it in a sort of 3 to 5 year time horizon. I actually think we need to be looking out over the next decade about how we anticipate the needs of residents of the state to evolve and change demographically, geographically, so that all of these decisions that we're really making in a data-driven way about what do we need and identifying what those gaps are. We've heard a lot of comments about primary care, but so that we know exactly what problems we're trying to solve. And I think some of that answer is also going to be about inviting some other providers into the state who may not be here now, who might be able to provide some of these services at a lower price point than what we're seeing in this market right now. I do think we need to find ways to increase some healthy competition in some of these spaces. It's something we're doing at Blue Cross by inviting in new virtual first primary care providers who were not in this market before and putting them in network and building products around them that are coming in at a significantly lower price point than what's available in this market right now, at least 10%, and with capacity that's reserved for our members to respond to some of the challenges and wait time challenges that we've just seen data around. I think there's also a need to just pick up on the point, there are opportunities around administrative simplification and the savings that potentially represents that we have to do in deep partnership and collaboration, and where I also think there's a real opportunity for the state. I'm thinking about the commission that happened in the Baker administration looking at data sharing and data interoperability. I'm hoping we can kind of dust that off. I know it was in the governor's economic development plan for the state. But having that kind of real-time ability to share clinical data between payers and providers is actually what we need to be able to do things like automate prior authorization at scale and to do that efficiently. So those are just a few things. We've got a higher penetration of value-based contracts in this market than anywhere else I've worked. And I think those of you know I came back to Massachusetts 2 years ago. We're actually the flip-flop of other states where there's a lot of value-based care in Medicare Advantage, but not in commercial. Here, it's actually 80% of our payments are in value-based arrangements. But we've got to get the economics inside of those value-based arrangements down to the level of clinical decision-making, and we can only do that in deep partnership with each other. So I welcome continuing to work together. We've got a pilot going on right now around doing some automation for admissions with MGB, and I agree there's a lot more we can be doing.
Thank you. Off to a very helpful start. Other questions from commissioners? Ron?
Thank you. Thank you for joining us today. We appreciate it. And listening to each of you, quite frankly, it's sort of depressing when we look at the situation we're in. And I was just thinking, if I project out 20 years, what do I see? And I'd like your opinion on this. Unless we have significant change and innovation, I see, well, let's start with this. The president-elect wants to eliminate the Inflation Reduction Act, which is going to have an impact on cost, right? And he's also a big supporter of Medicare Advantage, which you mentioned, which you have some 53% of the population today on Medicare Advantage. And if A and B are gone, it'll be 100%, right? And there are issues with that, as we all know. But if I look even further, what I see is the state of Massachusetts will have 2 health providers, 2 systems. And those systems, that organization will also have the payer built into the organization. And that's scary to me. Unless we see some change, I think that's the direction we're going in. And we've been going in that direction for a while. And I'd like your opinions on that.
Can Can I jump in? I mean, I think we should be concerned. I think that's what you're hearing from all of us. I mean, and to pick up on your point on fragility, it is a fragile system, whether you're sitting in a payer seat or a provider seat right now. And one thing that we haven't talked about yet, although Director Seltz teed it up, is the cost of prescription drugs. So I'll just give you an example from within our four walls. Of our 10% trend, 2 points of it, 20% right now, are the weight loss drugs alone. Nothing else, just GLP-1s. So I think that's another kind of solution that we need to be talking about. Are there innovative and creative ways that we should be talking about approaching the manufacturers of those drugs and buying them together so that we can protect what we all value, which is access to care? But the prices that are coming through, and I think that's frankly a canary in a coal mine, because as I look at what's in the drug pipeline, and this is a state that whether it's research that's being done in our academic medical centers or whether it's our biotech and pharma businesses that are based in this state, there's a lot in the pipeline coming that I don't think we're having a deep enough conversation. This is a national problem, it's a global problem about how we finance and afford all of these remarkable scientific advances that are coming our way. And so I think this conversation that we're having is exactly the conversation we need to have, and we need the catalyzing, focusing force of a cost benchmark to get us to do this hard work together and to stay focused on what we can reasonably afford.
You mentioned prescription drugs. If you look at this year, the average in the U.S., prescription drugs went up around 37%.
Yeah.
Next year, we're expecting it to go up nationally around 11%. Right? What's interesting is if you take the top plans, they're going up almost 50%, and coverage is decreasing. So these are all problems, but still, it's a minority of the cost, the total cost. You know?
It's actually 30% of total cost now, drugs.
The introduction of the GLP-1s have introduced hundreds of millions of dollars worth of cost into our system over the last couple of years. 2 or 3 years ago, 80% of the people taking those drugs were diabetics or were diagnosed. Now it's half, right? And we just have to understand the implications of the decisions that we make. If we choose to cover it, we got to pay for it, right? And your other options are to try and negotiate with the manufacturers or restrict access. That's kind of all you can do.
Thank you. Dr. McGregor?
Thank you. So I have a couple of questions, and my first question is for Dr. Klebanski. You proposed a number of ideas around the need to redirect patients to lower acuity settings, particularly patients who arrive in the ED but need a different type of care. And I couldn't help but think about really some of the large racial inequities in which patients are being served where in the greater Boston area. Now, BMC Health just left, but I wanted to really commend BMC Health for its racial inclusivity. So the Lown Institute puts together a racial inclusivity index, which really measures how well the patient population in a hospital reflects the population of the surrounding area. And BMC was number 1 on that measure. But unfortunately, Mass General and Brigham and Women's ranked at 607 and I think 428 respectively, which are worrisome rankings, I think. And as you propose redirecting patients to different locations in different communities, I wonder how such a proposal could play out without worsening your racial inclusivity ranking. And I also bring that up in the context of the need for a health equity benchmark. So a number of you mentioned the need to strengthen our cost growth benchmark, our affordability benchmark, but we've also been discussing a health equity benchmark as a potential strategy to ensure that providers and payers are considering equity in their work. And so, so that's my question for you,
Yeah.
Dr. Klebanski. I
No.
have one more, but I think we're short on time,
No,
so
I
I'll leave it there.
No, I'm appreciative of the question, and I'm going to leave aside the Lown benchmarks and just maybe talk about what it is we're doing. So I would say that as a healthcare system, it's a number of years ago now, we made a commitment to what is a broad platform, which we've called United Against Racism, and it has a number of pillars. And one of it is really to address inequities in healthcare for our own patients and for communities that we serve. It's a really broad program. Part of it is to look at things related to how we work with the communities we serve. And I would start by saying it's not so much diverting people, it's how do we serve people in the communities around us that we serve. So it's a bit of a difference. So the first thing is in actually looking at some of these inequities, and I think one of the really one of the good things that we've done is we've taken what's probably 20 different community programs across the system and put them all together under Dr. Elsie Tavares, who is really responsible for an entire program of looking at community health. So if I start with, what you're thinking about in terms of a healthcare system, there are things related to EPIC, whether it comes to how you factor in kidney function or how you factor in a number of things that really does serve to deepen inequities in health. So there's a lot of programs and a lot of work that's being done around that. And then we've talked a lot about languages, how many languages there are. How do you reach people in different languages? And we learned so much about that during the pandemic. And that's how do you make our electronic medical record accessible in a number of different languages. But if I really get to the core things about community, I would say that if we have done a very thorough community needs assessment. Who are the people in the communities that we serve? What are their needs as they've talked to us about it? These are in partnership. And what we've done is we've come together and identified some real issues that we can deal with, track, invest in, and think through collaboratively. They are hypertension, very important. So that's a metric. How do you look at cardiometabolic health in different groups? Increasing deaths of women of color during pregnancy. So there's a whole doula program related to how we are working on that. We have some wonderful collaborations. One is with Chelsea, La Collaborativa there. There are so many different programs that involve food, that involve vaccines, that involve so many different things in collaboration. But I think one of the main things to highlight is it's not shifting care around, it's bringing care to the communities. And one way that we've done that is through the community van program. So we now have about 20 vans that are going out to different communities that we serve. And we have a lot of services that are being provided by these vans. There's screening, because cancer screening has been identified as an issue. Again, I'll mention hypertension, cardiovascular disease. All of these things require screening and treatment. They require language, cultural competency. So there are teams that are going out in these vans bringing care to the communities. The other thing that we've done is a number of bridge clinics to really serve patients with substance use disorders. And there are about 4 of them now. There's one at Mass General, there's one at the Brigham, there's one in a health center in Haverhill. We've done a number of things where we are bringing care and access to health in the community. So there are many, many programs I could talk about. We all need to do better, all of us. But looking at these inequities, and I would just get back to this again, looking at it with real data. What are we measuring? What are the outcomes in terms of hypertension, premature death, and how do we track that over time? That is exactly what we're doing, working in partnership with many, with Boston Medical Center, with others in the city and beyond. So I'll stop in the interest of time. I think you've highlighted a very, very important point. There are just a lot of different ways to look at it and what care is being delivered where, particularly at home to people in their own communities.
Thank you.
Did you have a follow-up?
I could add a follow-up if there's time.
Well,
I don't know if there's time.
Are there other questions? Did you have a question, Dr. Castillo?
I just wanted to mention again, just I guess as I'm hearing you, again, these inequities that we talk about in healthcare have been going on for such a long time. It didn't just start now. And we're talking about different programs of how we may treat people, but in the past, what have some of the data shown you about doing that? Because I think a lot of times, we talk about mobile care for people, and we all get care in brick and mortar buildings and have our primary care instead of a mobile van. We do mobile vans, and they're good for certain things, but they're not that for primary care. And you talked about ambulatory care. Where do we do that in the community? I guess, why haven't we moved to do it?
Well, I can't speak for the whole state, and maybe Eric could speak for part of the state, and I can. I think we haven't. I think we haven't looked at it in the way we're looking at it now. I think we have a very different perspective on it now, and I think when it comes to providing care, I'll say two things. Number one, I think we've been pretty landlocked in our approach, and we've been landlocked for a lot of reasons. And one is it has been very difficult to move beyond our bricks and mortar facility. That's just been really hard in terms of where we're allowed to provide care and how is that going to work. And a lot of this is, I think it degenerates into a sort of a market competition that has not been particularly healthy for any of us. I think we're looking at things in a very different way now. I think one of the things we've learned during the pandemic is that healthcare systems can come together and think a lot more broadly, and that has certainly been the case. I want to secondly talk about innovation. The ability to provide care virtually has completely turned around behavioral health care. I mean, that is just a beautiful example of how technology has really made a difference. If you look at virtual care, that's been around for many, many, many years, and nobody wanted much to do with it. Then came the pandemic, and then there were hundreds and hundreds of thousands of visits just like that. Where are we with that? There's still some primary care. There's almost 90% or more of behavioral health care is all done by virtual visits. That's what's happening now, and it's been fantastic because you can engage people, you can help prevent hospitalizations, and yet the EDs are still full of patients. We have probably more than 500 to 600 beds that we staff in behavioral health when a lot of other providers are pulling away from it. And it's pretty much mostly in the community and at McLean. It's probably 20% of the beds. So we're doing all of that when people are pulling away from it, but yet we have virtual care. So those are the needs. So I think it's a couple of things. It's understanding the needs and how they're changing. It's the importance of primary care and access. It's understanding and leveraging the technology that we have and figuring out a way that we can make it work financially. I think that's just a very different world right now.
And I was just going to say, economics have a very focusing effect. And so one of the things that we're actually doing with both Eric and Anne is we have incorporated at Blue Cross into our value-based contract agreements health equity measures. And they now represent 20% of the value of the payments that these providers can earn for performance. And we've seen some great progress that I'm hoping we'll be able to announce together in the months that come. And it's just a reminder that the way our strongest and most powerful lever, I believe, starts with having a strong signal from the Health Policy Commission about what we think as a community is a reasonable expectation for how much we should allow healthcare costs to grow. And underneath that, aligning the economics to reward folks who are really making progress on the things that we collectively as a community think are most important. And health equity and reducing disparities is very high on that list, as is addressing some of the other challenges that we've talked about in the state and the community.
Yes. Commissioner Blakeney.
Thank you. Dr. Dixon, back to your comments about primary care. You said a couple of times that it cost you about $200,000 to support a primary care physician. And so I have a question about that, and then I have some additional challenges in terms about thinking differently, because that's what we're encouraging us all to do. First of all, could you help me understand a little bit better what is entailed in that $200,000 cost? That's question number one. And then question number two is, how do we start to think differently in terms of engaging a group of providers to provide primary care, which might decrease that cost?
So it really comes down to space, EHR, which is very expensive. It can be $150,000 just to install the EHR in new space for a primary care doc. 2 staff members to support that person, especially given the administrative burden that's put on them. And then the salary of the primary care doc, which is going up significantly as we compete more and more for them. And then, so if you look at the total cost there, that can easily be $500,000 to $600,000 in our market. And at best, we're going to generate $400,000 for a very busy primary care doctor in terms of revenue. So there's the $200,000 loss. We can sometimes make some of it up on risk-based contracts that they're seeing. We are exploring ways to do this differently. I think we've learned a lot from behavioral health. The no-show rate has gone down 5-fold since we moved to primary virtual visits for behavioral health patients who really have a hard time getting up and getting to the clinic. And we just last year started our virtual primary care program that allows us to see patients without the space. We still need the EHR, but we can leverage it in other places, and without the support staff. So we're hopeful that the combination of in-person and virtual primary care, coupled with the mobile workforce that we have with the paramedicine programs that we've built out for our hospital at home and for our mobile integrated health programs, we can get that number down significantly. The old model was, I'll hire primary care doctors, they'll send me labs. We sold our lab a long time ago, so that's now Quest. We needed the cash to be able to sustain ourselves. Imaging, the margin of that is down significantly, and admissions and referrals. And we're completely full and we lose money on every admission. So the old school downstream that I'll get from the primary care doesn't work anymore. And so primary care has to find a way to survive on its own, or on its own in fee-for-service plus risk. Those are the 2 ways that you can do it. And and if you take care of a high Medicaid population, or it's impossible, right? Because we're 26, 27% Medicaid between our behavioral health companies. That's part of the loss of $200,000. If it was all commercial, then it'd probably be closer to break even.
Okay, so how long would you say a new primary care doc setting that person up, getting everything in place that you just described, how long would they have to work in that environment for you to get a return on your investment just for the startup?
We would never get a return on the investment.
You would not. And
Yeah.
why is that?
Because we just lose money every year, and my most productive primary care doctors, I still lose money on that practice. So the return on investment is that my community is better served, and my people that I serve are healthier. But it's a mission-based return, not a margin-based return. And as money gets tighter and tighter, you see what healthcare systems start to cut: primary care and behavioral health, because those are the 2 biggest money-losing service lines for any big healthcare system. And so that what I worry about is when you see, especially the safety nets, but almost all hospitals, healthcare systems now losing money, the first thing they're going to cut is primary care and behavioral health. And that's just going to make things worse, not better, unless we find a payment system for primary care that makes it, in itself gives you some return on investment, in addition to the mission-based return, a margin-based return.
My last question, because I just want to flush this out. What specialty would do better for you? What's the best specialty in that scenario to start a new practitioner up?
Anybody with a scalpel, or nowadays a catheter that deploys a device. So electrophysiology, cardiologists that do pacemakers or angioplasties or TAVRs, aortic valve replacements, orthopedic surgeons. And that's why we're all competing for them and market share in that space, so we can sustain our organizations. This gets me in trouble with my surgeons. If you put me in charge for a day, I'm going to shift what you pay for procedural things and proceduralists to the primary care and the cognitive specialists, the movement disorder specialists at a national, but unfortunately that's hard to do at a state level. You have to do that at the national level. But simply moving what you're paying for on the fee-for-service will do a lot more, or how much you're paying for will do a lot more than trying to hold a primary care doc accountable for their pharmacy spend or imaging spend, which is what we are doing in some of the ACOs. We have a great ACO. I love it. We've taken a couple of percent, 3% off the overall cost, but that's about maxing it out. We need to pay more for primary care, and if that means paying a little bit less for the proceduralist, so be it.
I would just say also that, remember, the administrative burden for primary care is very, very high. It's true for all providers, but it is especially hard for primary care. So I just can't emphasize that enough. And we're all working on it. So, you know, we have virtual urgent care now, so you can get into the electronic medical record and get an appointment for an urgent care visit. That's good. That takes a little bit of the heat off. But the pre-authorizations, the endless notes, the endless work, it causes immense burnout. So you can set up a primary care doctor, they may well leave. We lose a lot of primary care doctors to concierge medicine practices. So there is a lot of burnout, and I think, again, you know, just in terms of innovation, and we're doing what others are doing, we're using a lot of ambient technology in terms of AI-assisted note-taking, so that's getting rid of some of the administrative burden. But it's really just trying to get after an extraordinarily over-administratively burdened group of doctors with massive panels and a lot of chronically ill patients. And some of the healthier patients will go out, if they can afford it, into concierge practices. So there's a sicker and sicker group with chronic illness who come to us. So that is a problem. Erica's outlined the financial issues, but on a person level, it's just very hard for those physicians. We have a lot of advanced nurse practitioners and others helping, but as a group, it's just very hard.
Thank you.
Thank you. I want to move on to our last question in the interest of time, but Sarah, did you have an observation on this question?
Yeah, just very brief. I mean, just reflecting on a lot of the economics that we've just heard described by Eric and Ann have to do with looking at fee-for-service reimbursement compared to costs. And so to me, in some ways, this is kind of an advertisement for our continuing to need to make progress on value-based care, because value-based care is essentially paying on a population basis and freeing up providers to say, you decide how you allocate payment inside your system. Now, I realize that's really hard to do because different physicians in your system have different salary expectations. So all of this is about reallocation, but that is what value-based care was designed to do, is to remove all of those incentives and historical constraints that came with fee-for-service to fund doing things in a different way. And so that's part of why I think we need to get deeper in working together so that we can figure out how do we do that and realign those incentives inside of value-based care arrangements.
We've been doing it for 15 years and it hasn't worked. We're going to just keep on going another 15 years?
Well,
and no other country in the world does it that way.
But I guess, Eric, I don't think we have a better,
that hasn't worked.
but I don't think we have I haven't heard an alternative idea. And what I'm proposing is to
Shift
say,
the fee schedule.
But back to where we started this meeting around what we can afford, shifting the fee schedule can't be about paying more because we cannot afford it. And so to me, the solution has to be, how do we lean in together to figure out how do you realign the financial incentives inside of what we're paying now? And I welcome the opportunity to do that with anyone in the state who wants to collaborate on that.
For our last question for this panel, Director Seltz.
Thank you. Thank you to the panelists for this great conversation. And I do hope that we can come together and try to identify some of these solutions. First, just a moment of clarification, and Dr. Kubanski, I know you know this because our teams have worked so well together on the performance improvement plan, but the healthcare cost growth benchmark, it really is a measure of total medical expense for attributed patients. So it's not really related to your administrative costs, or your department efficiencies, or your labor costs. So that just want to make that clarification. Absolutely. And we do look at trends over multiple years. So just want to make that clear. And Dr. Dixon, you reference, I just have to make this data point. I'm so sorry. You referenced this study that says that Massachusetts has lower commercial pricing than other states in the country. It's a RAND study, and we've actually talked to the authors of that study, and the data that they use for Massachusetts represents less than 5% of the claims in Massachusetts. And we just have some questions about the reliability of that analysis. That same analysis a few years ago said that Massachusetts had number one, the most expensive, highest rates in the country. So we had the most expensive, and now we're among the lowest. I think we should question whether that's a reliable data set. It does not include the APCD. The data that we use is a very robust data set. So just a little skepticism on that particular data point. I do have a final question. The word fragile has been thrown around a lot. And, I did show on my last slide that there is a lot of fragility in our communities among our residents and our small businesses around the cost of healthcare. And I'll just mention it again, nearly 1 million people in this state did not get the care that they needed due to the cost of care. And we have increasing rates of medical debt, and that's in Massachusetts, one of the highest income states, if not the highest income state in the country. We recently had, part of the participants are on this panel, providers and health plans unable to get to agreement on contract negotiations for connector subsidized plans. These plans, help a certain segment of our population, which kind of falls between Medicaid and the commercial market. That's going to cause a disruption for a lot of people to be able to have to find new coverage and new doctors. So I guess my question with the two biggest health plans on this panel and two of the biggest systems, when you are sitting at the negotiating table, are you modeling out what the downstream impacts are going to be on premium growth, on people and businesses, and what the implications of that are going to be? Is that something that's part of the negotiating discussion?
It's what we wake up thinking about every single day. I mean, you laid it out at the very beginning. As we look at what's driving premium growth, the biggest single factor is unit price. And so the strongest lever we have as a health plan is in those negotiations keeping our customers, employers, small employers, large employers, and then ultimately their employees. Or folks who are buying insurance directly on their own. We wake up every day thinking about that and thinking about the impact on people's wallets. And it's why you're seeing more of these negotiations spill out into public view. And Eileen said it earlier, this really does, in my healthcare career, I've been at this for 30 years, I've not seen this kind of negotiating environment before. I'll give you one example. We had one provider in this last round, and we're constantly negotiating. Started the negotiation with a request for a 50% increase over 3 years, and it came with a termination letter, which is effectively a take it or leave it. That was their opening move in the negotiation. And I know providers are struggling, but it gets back to your point. What do we keep top of mind? We keep affordability. We keep the competitiveness of Massachusetts in mind. We keep the downstream impact of what does this mean for healthcare access? What does this mean for health equity? And we're at a moment where there are no easy choices. We've kind of gone after all of the low-hanging fruit. And so whether it's decisions around medical policy and coverage of things like weight loss drugs, whether it's around the negotiations, I just think we're entering a tough time in which more of this is going to spill out in public eye, and that concerns us because that drives worry amongst consumers too.
Yeah, well, obviously, as one of the plans you're referencing in that discussion, we've certainly had a lot of difficult discussions. And to Sarah's point, we wake up thinking about what the impact to our members is, what the constriction of access will do to them, and how at Point 32 Health has had a longstanding commitment to serving all segments of the marketplace, Medicaid, Medicare, commercial, as well as the connector. And the economics on this direct product in particular just do not make sense for some of our provider partners, which is why they've chosen to exit that particular product. But we're thinking about access, and we're thinking about what the next steps are in that case. But as a community, we have to decide if we're all nonprofits, right? We're all trying to do the right thing. We're trying to get to access and affordability, but we have to work together on these different segments of the population because reimbursements and economics are different. So it's been a very tough season, as Sarah mentioned, and the requests we're getting, which are driven by the rates of inflation that the hospital systems are seeing. It's not that we don't understand it, but we do understand that we can't pay it because it's just not affordable for our members. So we're going to keep fighting the good fight, but always in good faith and with the intention of trying to reach agreements with anyone in the most reasonable way we can.
Thank you. Thank you so much to our panel, and I'm going to just take a minute to play back some of what we've heard and in closing remarks. One, we opened the session by saying that the data shows that we in Massachusetts are different than the rest of the country. So we all look at the data coming back from the COVID epidemic and the bounce back. Our staffing challenges and our current situation is different than the rest of the country. So it brings us to trying to understand the comments of our panelists in that context. This isn't something that is being shared equally. Second, we hear loud and clear from the leaders of the two organizations that regionally are the largest providers in our state that in terms of the solutions that they're looking at, ambulatory care, including care at home, and the ability to build primary care emerge as, the constant theme around both enabling and supporting that care in terms of experimenting with innovation and in terms of payment, and strong general agreement that primary care is going to be a major part of our addressing the care challenges in Massachusetts. I think in terms of the provider leader input around what health plans can do, administrative simplification, both as a cost issue and a cause of burnout, continues to be this perplexing problem. We all agree that there, and I've spent approximately 1,000 years thinking about this, there's got to be a way to eliminate this as a source of frustration and of cost. And so I think we take that away from the discussion, and also that health plans and the thoughtful role that our two largest plans are paying around both potential payment innovation, but also shifting the current pie towards primary care in whatever way is practical and feasible, and recognizing that despite significant efforts by the plan to innovate around payment, those innovations aren't overcoming the underlying drivers that are so strong. And then last, what we're hearing in terms of what HPC/government can do, I heard 4 areas. One, that the benchmark and the the surrounding activity around a benchmark continues to be important for us to talk about and think about. Data and revisiting data sharing and interoperability as a way of improving efficiency is important. Health planning and looking at whether expanding health planning and assessing what is needed in terms of resources and projecting that out for whatever period, whatever practical period we agree to. Sarah Islin proposed a decade. And then the discussion of the health equity benchmark and how do we have a common way of looking at whether we're making progress, understanding that some of the current measures, may or may not be useful for the leaders in our state. So we'll certainly reflect on this. If I'm missing anything, let me know, but appreciate the very thoughtful approach that you've taken to preparing for this and also to addressing our questions and testimony. Thank you.
Thank you.
Great. We'd now like to welcome the members of our final panel. Welcome.
Yeah, the little button. It's serious. Now I have free water. Thank you so much. Exactly. So is your life going? I get up.
Swear them in. Okay. Welcome, panel 4.
They were good. I've been wanting to bring them in. Hopefully there'll be a chance. Yes, maybe you lose money. Yes, I could.
Did we swear them in? I'm not sure. Good, thank you so much. Welcome to panel 4. And I want to turn this over to Commissioner Foley, who will moderate this panel.
Thank you. We're almost there, everybody. It's our last and final panel. We have some public testimony as well, but really important group of leaders representing spectrums from across the healthcare field, in the healthcare system or industry, as we were told earlier today. And I'm really honored to be moderating this important panel at this moment at the end of the day when our heads are all spinning. And for me, and I think it was said earlier, just it's a depressing conversation in a lot of respects of all the significant challenges that we're all facing, and quite honestly, think they're probably going to get a little bit worse. And I couldn't think of a better group of folks to engage in a conversation now, not just solely on what some of the policy solutions are or identifying some of the challenges and what those policy solutions could be, but really where can we try to reach some consensus amongst the folks on this panel here to move Massachusetts forward, to really address all the challenges that I don't need to repeat to this group. I think we all know what those are, and they've been highlighted throughout the day. We started with, I thought, a really great presentation by the Attorney General as well as the Governor with hopeful messages about how we're all going to work together to rise to the challenge in the moment that we face together. And then we hear all the data and all the issues and all the obstacles that get in the way of us doing that together. And so the goal and purpose really for this panel is to try to engage you all in a conversation of identifying what are the key issues, what are some of the solutions to those issues, and where can we try to build consensus to move our healthcare system forward. And we're going to do that in 60 minutes. All right? Does that work? Okay. So I'll start with the first question to get things going. And again, I'm not going to repeat.
Tim, introduce the panel first.
Oh. Slow down. Yeah. I had a lot of prep time for this. First, we have Michael Curry, the leader of the Mass League of Community Health Centers, Laura Pellegrini from the Massachusetts Association of Health Plans, Amy Rosenthal for Healthcare for All, and Steve Walsh from the Mass Health and Hospital Association. So again, an esteemed panel that's going to solve all of our problems in the next 60 minutes. In all seriousness, clearly, I think you all understand the challenges that do lie ahead. And again, we want to focus on the major issues that you see, policy solutions, and where we can try to build some consensus. So reflecting on the challenges that we've heard over the course of today and the days prior to this and the things that you focus on and work on every single day, what specific action is needed to move the healthcare system from the status quo to a new trajectory? And so we'll start wherever you want to start, and then I'm going to turn it over to my fellow commissioners to ask follow-up questions. We'll have the dialogue. So, Mike, you want to start?
I knew you were going to start with me anyway.
I was looking right at you.
Thank you, Tim.
Michael, can you just grab that microphone?
Yeah. Chair DeVoe, Commissioners, Executive Director Seltz, and staff, thank you for this opportunity to testify again before the healthcare cost trends hearing. Just a few minutes ago, I was on a panel with my good friend Senator Liz Miranda discussing the implications of the recent election on our communities and the workforce challenges both in Roxbury and beyond. We both expressed feelings of disappointment and fear, less about any candidate, but more about the direction of our nation. She said, and I quote, "But thank God we live in Massachusetts," close quote. With this governor, with this attorney general, with this legislature, and with this commission, and with so many others you've had come before you today to testify, and that's including business and organized labor and advocacy. I think that's a great place for me to start. So I want to start on that message you talked about, Deb, of being positive. We know that Massachusetts isn't perfect. If I could go back to my college days in Minneapolis, St. Paul, I'd say we're the best of the worst. We do a lot of things well compared to other places, but we could do so much better. So I want to, in answering your question, Tim, I think we know what we should be doing. And I was not here today. Earlier, I was at that panel at RCC, Roxbury Community College, and my ears must have been ringing because I heard my name was mentioned. But as was said, primary care, primary care, primary care. That the reality is we do not invest in primary care. I think the Health Policy Commission's reports, thank you, David and team, have been really reporting this out for some time now. We know what saves dollars. Now, sometimes those aren't immediate dollars. They're long-term dollars. We see those upfront investments that save over time. What we've not done is put our money where our mouth is. So probably out of everyone who would come and testify to you, they'll talk about primary care. But if you're commercial health plans, we need to see it in your choices. We need to make sure that you're reimbursing primary care at an appropriate level so that we can see the patients that are commercial patients. We know the shift, David, that happened during the after pandemic with people coming off of Medicaid and going into commercial plans. Commercial right now pays much less than Medicaid. Now, I want to say thank you to former Governor Baker, to former Secretary Sutters, and to our governor and Secretary Walsh now. They understood that, so they prioritize investing in Medicaid and investing in community health centers. We need to actually see that manifested throughout the healthcare system. We do not today. That spend that we have in the Commonwealth for primary care is ridiculous. It's disappointing. So the reality is if you don't invest in primary care, what do we see? We see health inequities increase. We see that, when I think about that, the thing that many of us have heard said, that I literally took the orange line from RCC here, and you could live 23 years longer, should disgust all of us. I think that investment in primary care is the critical part. Again, you've heard that throughout the day. I think ultimately thinking about diversity and equity and holding fast to those things. Part of, if I had an opening statement, what I would have said today is that in Massachusetts, as we are the best of the worst, right now we're facing a budget crisis. We're facing a continued migrant crisis. We are now looking at closures, and I am a co-chair of the Carney Task Force and the work that they're doing in Neshoba. And right now is where many other states will retrench and fall back and defund and step away from programs, particularly with what happened in DC. I'm hopeful in Massachusetts that we continue setting the mark for the rest of the nation. That we know that on the other side of this, when folks come out the other side and figure out what is Massachusetts doing, they model what we do here. And I would argue one of the ways we need to do that is investing in primary care and addressing this long taint of our healthcare system, which is inequity in health. The fact that people are dealing with disease for longer in their life, dying sooner. I will just share a real personal message and then I'll pass it on. Saturday, I got a call that a good friend of mine was being rushed to the hospital. And good friend, years, I've known him since I was in my late teens. I didn't get to the hospital because I was traveling. By the time I got back, he had been moved from Good Sam to St. E's. By the time I got to St. E's this week, he went from just being ill on Saturday, Sunday, to getting the diagnosis that he had liver cancer and did not have but days to live. What was more disturbing, maybe as disturbing as the fact that he has but days to live, was about the fact that he never had insurance until he got to the hospital, that he never went to a doctor, so he never got that cancer diagnosed sooner. He never had a primary care provider. I would hope in this vision of Massachusetts, the governor and others have sort of laid it out, that would be unacceptable to us, that we'd find the ways to crack the code on why people don't get coverage and why they don't have affordable coverage and why they don't have care. I actually think the vision of where we're going is going to require all of us to figure this out together. And I'm optimistic with folks that I've known for many years that we can do that.
Thank you. Laura? Let's go down the line.
Thanks for having me today. For the past 11 years, I have been very impressed with the work of the Health Policy Commission. I really think it's imperative that we have a data-driven discussion, and that there are a lot of misunderstandings, I think, in the community, and I think the Health Policy Commission can really right-size those misimpressions and to really get us the data and the facts of the drivers or healthcare costs. So I'm really thrilled with the work you've done, and I hope that can lead us in a new direction. I would be remiss if I did not start with cost containment. I think you heard from the executives from the health plans around the pressures they're facing. We have over 30 state reports, many generated from your organization, about the drivers of healthcare spending. And to be clear to anyone who wonders, premiums are a direct reflection of what we're spending in healthcare, whether it be on the provider side, pharmaceuticals, if we give a particular segment increases or mandated increases, that is all reflected in premium. Health plans do not have printing presses in their basements. All of those costs are reflected in your premium. So we need to be really, really thoughtful about what we're doing. So I think cost containment, there are a number of suggestions that the HPC has certainly laid out. I think later on we'll probably be talking about that. I won't get into that right now. The second thing I would say is the investment in primary care. We have spent over 2 years working with a group on primary care investment. So we've been at the table with them trying to shape legislation. I think one of the sticking points is how do we pay for it? I would say it needs to be paid for within the health plan contracts, where a certain percentage needs to be set aside for primary care. And I think the sticking point of that is how do we monitor that? And so I think it's probably a joint effort between the Division of Insurance, the Attorney General, and the Health Policy Commission to be sure that those investments are made. And so what does it mean? It doesn't mean new money into the system. It means we need to take money from other things. And we probably need to take money from specialists. My dream, if you sit in my space, I have to tell you, a lot of people call me, they need help navigating the system. My dream is that we embed behavioral health into primary care. We talk about health equity, we talk about mental health parity. Our system separates behavioral health from physical health, and I think we need to join that together because a lot of times those things are very interrelated. So we're very committed to that. Statewide planning, I've talked about that. I've been in my job 14 years. I think that was what I was talking about 14 years ago. We absolutely need to do that. I'm hoping it's not too late. We've had so many different projects that have come before the Department of Public Health. I think that, some are great. I'm not sure that all add value. The Health Policy Commission has to have a strong role in that. And we really do need to assess the needs of our community and figure out how we want to move forward. Folks talked about a strong cost benchmark. As, again, somebody who's been doing this for years, people took the cost benchmark very seriously those first couple of years. I think then people kind of realized, oh, it doesn't really have any teeth. We need to give it teeth. And I think, to quote Sarah Islin, I think both the health plans and the providers need to be accountable. The hospitals also need to be a part of this. More transparency around private equity, administrative simplification. We are ready, willing, and able to have those conversations. I I think moving to electronic prior authorization is going to be really important. And I think, again, Sarah, is something I've been talking about. I sat on the Digital Health Council. I think we need to collapse the siloed nature of medical records and really open that up so that no matter where a patient goes, their medical record follows them. So if we're thinking we're spending too much on hospital outpatient services and folks want to compete, that are other types of entities, I think people are afraid to do that because they're afraid it won't end up in their medical record. So we want a comprehensive medical record that can move with the patient from hospital, outpatient setting to outpatient setting, that is a complete picture of what's going on with them. I think that would take down medical errors and it would take down some cost into the system. And again, on prior auth, I think we're constantly thinking about that. And I know the plans have, in many instances, taken off prior authorization. But interestingly, as some of our state programs are really facing unprecedented growth, they're actually telling us to do more medical management, not less. And so I've sort of said to them, well, I was telling my plans, kind of take some off. But I think we can have that conversation. And I think, again, leveraging technology is key. So I think those are some of the things I'm thinking about. But I would say the cost pressures are very real, and I know you're probably going to want to talk about high deductible health plans, what's going on there. That is a reflection of our inability to deal with the cost question. So,
Thank you. Amy?
Hi, everyone. Nice to see you at the end of a brain-filled day. I actually want to thank Chair DeVoe for starting off today by really talking about the impact that this is having, the costs are having on people. And, that is the lens in which Healthcare for All sees everything all day, every day. It's what we hear in the 23,000 phone calls we took last year in 5 different languages, listening to these stories day in and day out. The reality is that we are dealing with so many crises really all at once. And I know we've talked about many of them today, but to think about it as to how we're thinking about it as it relates to individuals. It's a crisis of both care and access to care. And this is particularly for our lower income populations, people of color, a lot of the populations that Healthcare for All primarily focuses on. This has been exacerbated by Steward and thinking about what this has done to particularly the Neshoba Valley and the Kearney catchment areas. And now we have this added threat of the Trump administration and what those ramifications are going to be, not just in the dollars that we're worried about for the state, but in thinking about some of the programs and how those are going to impact people. And so what's really upon us right now is the need to both play offense and defense, to think long-term and to think about the immediate needs. And I know that's a lot for us because over the years, we have not been able to necessarily do all of those things at once, but at this point, we really have no other choice, and we will need to do that. We get calls all the time about the long waits that people are feeling to try to get in for an appointment, the issues around language access, the ability to just even call and make an appointment. And then we're also getting folks who get an appointment, but then the confirmation call comes in a different language, in a language that they don't speak. They can't confirm the call, and then they show up for their appointment and they can't. The appointment's been canceled. These are the types of day in and day out things that people are struggling with. And I think this is going to take all of us working together in a way that was reminiscent of what happened in the Commonwealth around Chapter 58 when we did health reform, in a way that requires everyone to come to the table. And it's so much easier to do that around access and so much harder to do it around cost. And I think the work that you all have done has set that stage and continues to, but I think we need to continue to do more. I want to offer a couple of concrete policy suggestions, some of which I know we've talked about. I won't rehash, but the primary care and behavioral health access by far is so important. Hopefully we'll talk more about state health planning, because I really do believe that that's so important. And then I think that each stakeholder group really needs to be thinking about what they can be doing to contribute to this. So for example, if health insurance premiums have risen more than 15% between 2019 and 2022. We've heard they're going to go up over 8% in the merge market next year. So this is why we need to establish an affordability standard for health insurers in the Division of Insurance Rate Review process. Second, hospital outpatient department spending has the second highest growth. Prices have increased about 34% between 2018 and 2022, and the price variation is enormous, with the most expensive hospital being 2.5 times more expensive than the least expensive one. So that's why we need to enable HPC performance reviews to be based on more flexible factors than just total cost of care. And CHIA should be able to make and consider other measures like prices, baseline spending, and population served. And lastly, the category of spending with the highest growth from 2018 to 2022 was prescription drug spending. So I think it really needs to be a top priority for the Commonwealth to think about addressing prescription drug prices by bringing prescription drug manufacturers and pharmacy benefit managers into the cost growth benchmark process and to hold them accountable for drug prices that don't align with their proposed value. There's a lot more that I can say, but I'm actually going to stop there.
Thank you. Steve?
Thank you, Commissioner Foley, and thanks for a great discussion today, and always good to be with Amy, Laura, and Michael, who I know are working so hard on the issues that we care about, and Executive Directors Seltz and Peters, who do this on a daily basis. Them and their teams are doing everything they can. It's been a long day for the commissioners today and hearing a lot about what's happening, yet we're not at the average wait time in an emergency department. So if you've been sitting here all day listening, you'd still be waiting to get care in one of our local hospitals. So there may be a cost problem. We've heard a lot about it, but it's a system problem. We have a system problem. And I appreciate the pressures that the payers have talked about and the providers have talked about. The reality is every single hospital in the Commonwealth has lost money at least one of the last 5 years. 80% of the hospitals lost money in one of the last 2 years, and 2/3 of them lost money this year. So whether or not payers can pay more doesn't really matter. Hospitals are crumbling, teetering on the edge. So the question is, what can we do? Well, thing number one is we have to accept this as our reality. We don't like to do that because we don't understand it until we're in it. And then when we're in it, or one of our loved ones is in it, we understand what's happening in the walls of the hospital when we're trying to get an appointment. And it's a huge issue for our patients. So yes, cost is impacting care, but the system is impacting care. And then it becomes incumbent upon us to fix the system. Now, how do we do that? What's been talked about over the course of the day is primary care investment, accountable care and value-based care, workforce development, administrative simplification, Medicare reform, behavioral health parity, and a statewide health plan. Do you know what all of those things have in common? David does. Every single one of them is in Chapter 224. So implement Chapter 224. That's the one thing you can do. We're focused on one part of one section of an incredibly complex bill that had the idea of changing and reforming our system. And we spend a lot of time, energy, and money and regulation talking about a cost growth benchmark. With work for a couple of years, and now is going the other direction, as is the national average. And whether or not we argue about which study says what, whether it's the RAND study or the Commonwealth Fund study, which also has us #1 in the country for access, quality, and affordability, that doesn't mean that we have good access, great quality, or affordable. It just means we're better than the others, to Michael's point. So even if we disagree on the studies, we still have a problem that we can solve by doing all the things that the system would require so that we can then easily meet the cost growth benchmark. You can't start with the benchmark and work backwards. You have to reform and evolve the entire system. And then we will be pleasantly surprised that we now have a system that works better for patients, gives us higher quality, and becomes affordable. And then we talk about what Michael talks about so eloquently, folks that are coming into our neighborhoods that are setting up limited service clinics or ambulatory surgery centers that are unaffiliated with our local providers. Look at the zip codes they're going to, because they're cherry picking the few commercial patients that Laura and Sarah have left, and they're making money off them. And who does that further hurt? Our poorer communities, our community hospitals, and our academic medical centers. And we talk about price variation a lot, and I'm sure there'll be a question upon it later. And there is price variation in the Commonwealth. But if we look at that variation, what do we want to take away first in the area that we have shift costs to? The burn unit? The pediatric facility for complex kids? The trauma center? The stroke level 1 center? Which of these things are we going to take away that are not reimbursed for, that ultimately we shift some of our other costs of the system to pay for in our best in the world academic medical centers? So these are really hard questions. But the low-hanging fruit was in front of us 12 years ago. And we didn't do the hard work, and here we are today. So let's refocus our effort on a bill that was very aspirational at the time and maybe not ready in some of those other areas. And let's set this cost growth benchmark aside for just a moment and build a better system that makes the benchmark very achievable.
Thanks, Steve. Questions from commissioners? Marty?
So I want to pick up on something that Amy said, which is basically the affordability question. Last year, over 1 million residents in Massachusetts did not seek care that they needed because of cost. We've heard a lot of talking points. I just want to go right down the panel. Give me one immediate policy solution that will help address this affordability question. Michael.
One solution to addressing the affordability problem. So it's a tough one because there's so many more that we should be thinking about. I think one is we know access matters, and one of the things I said when I was in that room of mostly black and brown faces a few minutes ago is I said we knew before the Affordable Care Act over 40 million people didn't have insurance, and when you don't have insurance, you make really tough choices about whether you get care for that pain in your side or that headache or your teeth or your eyes or your substance use disorder. And that choice usually leads to you living a sicker life and a shorter life. I think one is we just need to invest in where we know it matters. And again, I'll say that we got to make a decision. It's the redistribution we're talking about. It's the identification of additional funds. We got to make sure coverage is affordable and access is possible. And we don't tend to do the two things very well. So I can have a coverage, I can have a card. Do I have a location close to me? Do I have a provider that believes my pain and will treat me? Will it take me right now 3 months to get an appointment at a health, 3 months if you're an existing patient, 3 months if you're a new patient to a health center on average, and up to 6 weeks if you're a new patient, existing patient. That's because the system is stressed right now. So I think ultimately investments is where we need to be thinking about. I'll say it again, investments in primary care means investments in community health centers. We keep people healthy. We're treating the least of these, those folks that are desperately dying and sick. But the money doesn't reflect that. The resources don't reflect that. And that's, again, partly on the commercial side, increasingly on the Medicaid side. But we don't put our money where our mouth is.
So there are a lot of areas, and I want to say, first of all, Massachusetts, the secretary's not here, so good. I do think Massachusetts is falling behind on containing healthcare costs. Other states are doing really innovative things, and they're having success. If you want to come to the MAP conference tomorrow, you can hear from Oregon, Rhode Island, and Maryland about what they're doing. I would say one area that maybe we could all agree to, I'm not sure, is around the pharmaceutical industry. So they are missing today from these panels, and yet they're a major driver of healthcare spending for the health plans, and you heard some of that today. So at the very least, that they're participating in these hearings, that they're providing data to the Attorney General and to the Health Policy Commission. But I've become a believer now, and Maryland's doing this, so we'll hear about it tomorrow, and we really need to look at these prescription drug boards who are going to, Maryland's, we'll talk about this tomorrow again, look at the highest cost drugs and try to assess the value and why the drugs are priced the way they're priced. And so I think that actually is the next step. So I think we need to do the first step, but I actually would hope we could do all of this together. I think that is something maybe a broad group of stakeholders could agree to, and it's going to take that. I understand the problems we have in the state. We're trying to create, different economic sectors where we can lead, and I think the biotech sector is one of those sectors that we're really focused on. But we just gave them a ton of money in the economic development bill. Maybe we need something for that, and that's some accountability.
Thanks. Amy?
So I was actually going to say that. So to that point, so I'll kind of like add on. So I think that helps with the system costs, and we Healthcare for All is, as everyone here knows, has been very focused on system costs related to prescription drugs. I would add in from a health equity standpoint that there is also the no copay proposal that has moved through both chambers that is designed to provide support to people with chronic conditions that disproportionately impact communities of color and low-income communities. Specifically, it caps copays for certain brand name drugs and eliminates copays for certain generic drugs related to diabetes, asthma, and heart conditions. So that, I think, complements the system cost with the consumer. I will just also, though, throw in something that has come up today, and we heard from the Attorney General's office, is about medical debt, too. And I do think that thinking about medical debt, because we know who is most impacted by medical debt, it's people of color, particularly Black residents. The statistics there are really significant. And I think that there's a number of policies that we can be putting in place to think about medical debt.
Thank you. Steve?
Thank you. I'll be a +1 for all of my colleagues, which gives you 3. Michael's right. Invest in community health centers, invest in community hospitals. Michael always says, pay now or pay more later. Laura's right. Get everybody under the same tent. You don't have the ability. So even if the payers and providers are here challenging each other and conflicting or collaborating on areas of agreement, you don't have everybody at the HPC. So Laura's exactly right. Everybody has to be coming before you to answer the same questions and do the hard questions. And Amy's right. Regardless of the cost of life-changing therapies, they shouldn't just go to those neighborhoods that can afford them.
Other questions from the commissioners?
Question. More a question to try and get a little bit more insights on what's causing sort of the greater out-of-pocket expenses that lower income individuals face in Massachusetts. So referring to the Attorney General's Office Cost Trends Report, one of the findings was that out-of-pocket costs appear to be higher in absolute numbers, not just as a share of household income, for families living in lowest income zip codes across the state. And I'm wondering if any of you know what's really going on here. This is for commercially insured individuals. So what's going on? Are they more likely to be enrolled in high deductible plans? Are there unexpected copays? Do you hear, Amy, from any of your constituents regarding this, or Ms. Pellegrini, if you could chime in there?
I can tell you what we're hearing, and I think we certainly see a move towards high deductible health plans because people can't afford the options in front of them. I think the state has done a number of good things to try to help to try to address it. I think the pilot program to expand Connector Care up to 500% of the federal poverty level has been so critical. We have heard directly from people, tears from people on the phone who call our helpline where they weren't able to get subsidized support before or coverage and now are able to. And this is something that people notice right away. The affordability issues are just so very real, and I think we hear it from multiple places. So we hear it on our helpline, for sure, but Healthcare for All has been really privileged over the past 4 years to be working with about 40 to 50 local community-based organizations through our work on mass health redetermination, through our work around COVID vaccinations, and now through our work around Steward, which I'm hoping to have the chance to talk to you about. And hint, hint. It's not just the callers who call us in crisis who need help right then and there on the helpline. It's also when we sit down and have conversations with community-based groups. And these are people, these are faith-based leaders, these are community-based organizations who are having these conversations day in and day out. Healthcare for All has been really lucky to work with 23 organizations this year who have trained 108 new certified application counselors. So now these are folks in the community who work for community-based organizations who are helping people enroll in health insurance. We've been able to do this in partnership with the UHHS, and it's been enormously successful. But the stories that come from those are all about the fact that people still just cannot afford the care that, in the out-of-pocket costs, the deductibles, the premiums, it just continues to be overwhelming for so many families.
Thank you.
Thanks.
Thanks. So I'll tell you, as a small employer, I am faced with a very tight budget. I need to pay my employees competitively. I don't want them to leave me. I want to fund their 401k, and I want to provide them with good health insurance. When I look at all of that and I see the increase in health insurance, and I want to be able to give them a raise and fund the 401k fully, I look at health insurance and I buy down benefits. So I put more burden on them with cost sharing for a lower premium. And I think that is what's going on across our state. I don't know if I have these figures exactly right, but I think in 2014, about 14% of our population was in a high deductible health plan, and today it's about 40%. I think that is a systematic failure of us failing to address the cost issue. I mean, we know what ails us. I was, again, thrilled when we created the Health Policy Commission. These were things, David Seltz, many years ago, 15 years ago, we were talking about these issues, but we didn't have the data to back it up. Today we do. We have over 30 state reports that have told us the same thing time after time, and yet there's an unwillingness and an unableness to really address it. And then we sort of wring our hands and we wonder why we're in this situation. Health plans cannot fix the affordability challenge alone. Our premiums reflect what we're paying providers, what we're paying the pharmaceutical industry. Amy talked about the affordability standard. Rhode Island has that, but they also have a cap on hospitals. And that's how it's all worked, and then they're funding primary care. I'm not sure the political will is here to do something like that. So we've kind of created something that's probably our own fault, right? Because of our unwillingness to work together to try to address these issues. But that is what's going on with the high deductible health plans. And I think in these poorer communities, maybe the employers are not contributing enough. There are also products on the connector that have pretty high deductibles. And again, being in the position I'm in, I help people all the time try to navigate what to buy on the connector. And here's what goes on. If you're sick, you want a rich product, right? With coverage from day one and not a lot of cost sharing. If you think you're infallible and healthy, you want the cheapest product you can find. So that's kind of what's going on.
Thank you.
Maybe just a quick add-on to that. So as a small nonprofit, relatively small nonprofit, this is the challenge we have every year, is that we see 10% increases in our premiums, in our contribution. And there, I'd raise this issue, the interconnectivity of all these issues. So imagine in a situation where I just sat on a panel with Jim Clockey and the Mass Nonprofit Network about 2 days ago. We were talking about the challenge of nonprofits. So you already disproportionately have Black and brown folks who work in nonprofits. Those were the jobs that were available to us. Now, getting a little bit of historical here, we call those, Donald Trump would call those black jobs. These were the jobs that we were relegated to. Not that we didn't belong in C-suites and medical schools, but we were relegated to the jobs that didn't pay well, that didn't have great benefits, didn't have retirement plans. Now we're seeing the manifestation of that, or the consequences of that, is that now when the cost shifting happens, when you're facing as an employer these increasing costs in health insurance, now you're passing those costs on to your employees who are already not wealthy, who are already unbanked, unhoused, dealing with the consequences of these societal issues, and then have to make tough choices, right? Do I go to the emergency room and I can't do the deductible? Do I buy that drug and I can't pay the copay? And those are really tough choices, but I know that in communities that I grew up in, they're making those choices all the time. And they work in jobs, typically, that does not cover the cost of the care that they need. And that's the challenge for nonprofits, and I would argue, I think the data shows this, too many of us disproportionately work in those jobs, and therefore faced with these escalating costs.
Thank you very much.
Just add that one of the other failings of the system, to the exact point that Amy and Laura and Mike say, is that then the provider, your doctor, your hospital, is put in the position of being the bill collector. It's not the way the system should have been set up. So we create this, someone some years ago decided that you'd pay a premium and then there would be some point of care cost. And then the medical debt goes up because frankly, hospitals aren't very good at it. They want to just take care of people. And then people have this huge medical debt that now states are looking to figure out, and Healthcare for All is doing some extraordinary work around this. And it is predominantly hitting communities of color because you're trying to buy into Amy's point at a lower cost so that you can get health insurance. And so once again, we're back to a broken system that was set up by people long before us that just doesn't work for the care delivery system that we all want and aspire to be.
Right, thank you.
David?
Thank you, panelists. I did want to return to the theme of the morning, which was the impact of the dissolution and bankruptcy of Steward Healthcare. We heard a lot this morning about, the really human impact, the system impact, the community impact, the moral harm impact. We've put forward at the Health Policy Commission a number of recommendations that we think will close some of the, honestly, just gaps in transparency that private equity and other financial institutions have taken advantage of that allow them to skirt some of the same oversight laws that all other provider organizations currently have to abide by, including enforcement of financial statements. What policy recommendations do you have in terms of thinking about the lessons learned from the Steward debacle around protecting the Massachusetts system from predatory actors moving forward?
So I'm gonna I'll answer that question and then I'm gonna pivot a little bit on it. I think that there have been a lot of good suggestions through the HPC recommendations, through the bills that we've been seeing in the legislature. I'll just mention a couple of points that we've pulled out about expanding the types of transactions that are subject to material change notices and the cost of market impact reviews with enforceable conditions, requiring private equity firms to post a bond with the Department of Public Health when they file a material change notice, prohibiting licensing hospitals that lease the land on which their main campus is located from a healthcare real estate investment trust. Those are just a few of the ones that we pulled out. But I think the kind of policy that I want to get to is about when there's systems and when there's issues with the system and there's crises that unfold, I think we as a Commonwealth need to have a policy in place that we speak with, involve, and engage from the start the communities that are being impacted. We've been saying at Healthcare for All that health equity is not doing something to the community. It is involving the community in a genuine way from the beginning of that process. And I think that this is actually a policy we need to be having in place in how we move forward anytime anything like this arises. And the communication has to be in two directions. So it has to be the stakeholders that are involved, whether it's the state or whether it's groups like any of ours, sharing information. In the case of Steward, helping people understand how to get a copy of their medical record, helping them understand whether their primary care doctor is still in network and whether they need to reach out to their insurance company and how to get help. Does their family have an emergency plan? Not when they're going to call 911, but if they have an emergency that they need to get somewhere, do they know where they're going to go when their hospital closes down? These are all really important messages in this case, but I think it's also about the way in which we do the work. And so thanks to support from local foundations, unions, corporate donors, and the state, Healthcare for All's had the real privilege of being able to be at the doors in Neshoba Valley and Kearney catchment areas for the past 4 weeks. We've talked to 10,000 people in the past 4 weeks in those communities about what it is that's impacting them and what they're hearing. And we are giving them information and we are receiving information. And it's really fascinating. So things like the top concern in the Neshoba area, 56% of people say that no ED nearby is by far their number one issue. In the Kearney area, 18% of people are saying the economic impacts caused by the closure are their top issue. 15% say that no ED nearby is, and 14% are talking about the loss of the inpatient facilities. And so this is really important information that we need as a Commonwealth when we're thinking about the impacts. As we wind down the canvassing, we are now working with the work groups that we've heard about a couple times today to run visioning sessions. We'll run about a dozen of these, where we'll talk with community members over a longer period of time to understand what the suggestions they have about what their community needs in terms of healthcare, in terms of access, in terms of services. And I just think that I'm so proud of us that we got to the place where we're doing this type of engagement work, but I think this has to become the standard of how we handle situations in our healthcare, because this is how we make sure that the voices of the people that are impacted by these closures or by changes in insurance plans, we need to make sure that people are at the table and having those conversations. So thank you for asking that question.
Thanks, David. You know, I don't know about lessons learned yet because we're not yet at intermission of this play. I think there's some positives that we could focus on for a few minutes. Our partners in organized labor, I've said this before, Tim Foley and Julie Pickett with the M&A, they kept those workers going back every day, caring for the people that we love and care about, without any idea of what the future would look like. We have a secretary that understands people, understands communities that need services, and stepped in as a leader to make sure that they landed with trusted partners. But it is really hard to legislate against illegal, immoral, or ultimately unethical behavior. And maybe you just make it a condition of licensure that you have to follow the rules. But for years, you've been trying to get one particular company to follow the rules, and they have chosen not to. So an overreaction that ends up ultimately impacting all the others in the market that are following the rules and are struggling and are fragile, to use the word that was used here, and you repeated back, isn't the answer. The other thing we've heard over the course of the day is that there isn't enough money in government, and there isn't enough money in our public payers and our private payers locally that are nonprofits to support the system that we have. So we're going to need private investment in healthcare. So we have to be thoughtful. Now, that doesn't have to be a portfolio company that is only looking for to squeeze a profit out of it on the backs of poor people in communities. But we ought to figure out if there's a way to create some guardrails that doesn't ultimately stop us from investing in places that are going to need private money in order to make things work for our communities going forward. So I don't know that we know yet. It's a really complicated problem, and it's a philosophical one too, about where do we want to go from here and how do we invest. But there are some really good people in this Commonwealth that stepped up, including some of the work of Healthcare for All, to engage the neighborhood. Better late than never. I mean, we were in the middle of this thing and trying to understand what those communities need. And in a moment's notice, just as if we were back in COVID, the collaboration between our health centers, our payers, our providers, and our Commonwealth was there once again. And that is when we are at our best.
So I think these are some of your recommendations, but I think we would strongly support them, and maybe there's some unanimous agreement here, I don't know, but non-compliance for with hospital reporting and tying that maybe to licensure. As a lawyer, it disgusts me that Steward used the court system to slow down transparency. And had you been able to get the necessary documents, we could be in a very different place today. So I think much stronger provisions around that. More transparency, obviously, if private equity is going to invest in the healthcare system, I think we need to be transparent about that. I think Amy discussed, and I think, Steve, I saw something you had around land use and not transferring. I think where patients are cared for, that property to private equity or a real estate investment trust, that should not happen. I know there are some relationships now where it's happened, and so maybe those are grandfathered, but certainly going forward, I think that's a huge issue. And then something that hasn't been discussed, I received a lot of calls probably 2 years prior to the Steward thing really becoming public from vendors who weren't getting paid and from people who worked in hospitals who said there were not supplies, or they thought something was wrong, or the physical plant was in disarray, and what should I do? And I used to tell them to call the AG's office, but I just gave them the main number. I don't know if there is a place in state government where those complaints could go, but if we had something either at Department of Public Health or the AG's office, we maybe would start to see a pattern, and there could have been action sooner. I have a fear that those calls went to multiple people and no one really put it all together. So those are just some suggestions.
You know, when it was announced that I was co-chairing the working group for Kearney Hospital, I was walking down the street, and as I'm sure so many others who do this work, people will stop you and give you their opinion. And this woman stopped me, and she said, I saw that it was in the Dorchester Reporter that you're co-chairing this working group. Just make sure whatever you put there is comparable to what they have in Newton. And I think about that as I've been to Kearney Hospital many times, and of course, I even received some care at Kearney Hospital. I think about that I was in St. E's this week and had a nurse walk me to where I was going to visit my friend. And she said to me, she said, "We're happy that BMC's here." It's because the elevators didn't work. Mm-hmm. And we have been dealing with the disrepair in this building for a long time until BMC got here. So I want to remember something Deval Patrick said to me once. We were standing in the lobby of a health center, and we had just received funding through ARA, American Recovery and Reinvestment Act. He said, where we treated these patients at often reflected what we thought of these patients. Kearney Hospital, right? St. E's, go down the list. We did not invest in those communities and in those hospitals. So I say that to say this. As a state, we should have and should be doing contingency planning for the dissolution or for future closures of any key institutions, any anchor healthcare institutions. This planning should be robust and transparent and center around the remaining providers, the impacted patients, communities at large, and providers in the workforce. The plan should proactively answer where the patients will go, address continuity of care, and have systems in place for workforce transition. Again, credit to the HPC. The Commonwealth should prioritize planning, investments, and other policy efforts to enhance access to primary care and behavioral health. It's been documented. All of this has to be accompanied with resources for the providers remaining in the shadows of those hospitals and other healthcare providers. We know, as I get these calls, and you've heard from folks today from the health centers, they're seeing these patients come in who have been destabilized by the fact that there's a closure in their community. They don't have additional resources to treat those patients. They don't have additional funds. They still have to treat the patients they already have and then try to respond to the patients that are now walking the door, and some of whom may not be in the right place to get the right care. State health plan, we've mentioned it before. Many others have mentioned it, the need for a state health plan. Credit to the legislature for the work that they're doing to come up with a plan, the House and Senate market reform legislation that we needed to move this in conference. Broaden which transaction triggers the material change notice process by HPC. Support legislation that requires private equity firms to post a bond with DPH. Folks have talked about that as well. And authorizes DPH to collect that bond upon filing bankruptcy to ensure the continued provision of healthcare services to patients. So we've talked about it. We have a plan. It's just we haven't done it yet. So I think I want to go back to that comment, though, that whatever we do in Massachusetts, we've centered most of the care and most of the health insurance we have in the state around nonprofits for a reason. That we know the incentives are different, that when people center the profit over the patient, that's a problem. So whatever we do, we need to then hold those coming into this state accountable to make sure that they center the patient as well.
Thank you. Any final questions from any of the commissioners? No? Okay. Well, I want to thank you all for your time and your important advocacy and the work that you do every single day to try to improve upon the healthcare delivery system in Massachusetts, and we'll continue to work together to find common solutions because we know that we're in a very difficult place with our healthcare economy and that we have to work together. We're going to solve those problems. One of the main themes I heard, I'm not going to try to list all the areas of consensus because I think there are some when you dig deep a little bit, but we're all going to have to come together if we're going to solve these joint challenges together as a healthcare community. So thank you very much for your testimony today.
Okay. Okay, great. Great. Thank you so much to panel 4. We'll now move to the last segment in the hearing today, which is that we do have 2 individuals who are going to provide us with public testimony, Dr. Amy Shea and Eileen McEnany, if you want to come up. Great. And I'd like to move to the public testimony, so I appreciate for those of you who are catching up to catch up outside. Yeah, exactly. Take it into the hall. Thank you. Great. Yeah, she's here, right there in the front row. Great, thank you. And if I could ask that those who want to catch up move into the hallway so that we can move to the public testimony?
Definitely need a gavel.
Right, right. Knock, knock. I've got Marty. Great. Thank you. And thank you so much, Dr. Shea, for attending today and for providing testimony. We'll now turn the floor over to you.
Thank you. Good afternoon. My name is Amy Shea, and I'm the president and CEO of the Health Foundation of Central Massachusetts. I'm also the board chair of the Health Equity Compact. I commend the HPC for its thoughtful policy recommendations this year and in previous years. Though today's hearing is drawing to a close, our work does not end here. Legislators, advocates, and stakeholders must urge action on the HPC's policy recommendations in the months to come. Recommendations that sit on shelves will do little to address the challenges that are destabilizing our healthcare system and contributing to worse health outcomes. The longer we continue to allow the growth in healthcare costs to outpace the growth benchmark, the greater the opportunity cost. Unchecked growth in healthcare spending will leave less to invest in social determinants of health like housing and transportation, which have a far greater impact on population health than healthcare interventions themselves. It will leave less for individuals, families, and businesses to invest in the things that will enable them to stay and thrive in the Commonwealth. Because social determinants of health offer a far greater return on investment, I encourage the HPC to model the potential impacts of redirecting healthcare spending exceeding the benchmark towards investments in social determinants of health. One would expect the results to mirror the better health outcomes we see in peer countries that invest far more in social determinants of health and far less in healthcare. Determining where to control costs and where to invest dollars will require careful consideration, and an important step will be statewide health planning, which is the HPC's third policy recommendation. This planning must account for social determinants of health that directly impact healthcare access, such as transportation, and address regional inequities, especially in rural regions which have faced chronic underinvestment. We must also center community voices. Last year's hearing began with a panel on community voices, which grounded the discussions that followed. Noticeably absent today are voices from the Neshoba Valley region. Yet, I can still recall many of them from the hours-long DPH hearing in August when residents expressed their deep anger, frustration, and pain at the closure of their cherished community hospital, especially in light of the state helping to orchestrate and finance the transfer of other Steward hospitals. Many use the term death by 1,000 cuts to characterize the trend of healthcare service cuts and closures experienced in the region. Typically, when we pay more for something, we expect greater quality or quantity. In the case of healthcare, however, we are paying more for it yet receiving less, and this is felt acutely by those in the Neshoba Valley region who have tangible evidence of diminishing healthcare services. This has also been felt in other parts of the Health Foundation service area, including the Ware region following the closure of Mary Lane Hospital, where all that remains is the empty concrete shell of what used to be a hospital and medical offices. There are limited healthcare providers in the region, and many are not accepting new patients or mass health. There are no pediatricians, OBGYNs, or family physicians in town. In a state that prides itself on leading in so many aspects of healthcare, we must enable all residents to have a fair and just opportunity to achieve their highest level of health, regardless of where they live. If we continue with the status quo, and if we do not listen to the voices that are urgently calling for change, we will lose the trust and support of the very constituency we are trying to serve, and that will further hinder our efforts to address affordability, accessibility, and equity in the Commonwealth. We are already bracing for significant changes in federal policy that will challenge our healthcare system. We must take bold action to improve health and healthcare in the Commonwealth across all regions and populations, and instill hope for a healthier and more equitable future. Thank you to the HPC for your leadership and for the opportunity to testify today. We all have a shared responsibility to contribute to the difficult and essential work ahead. Thank you.
Thank you, Dr. Shea. I'd like to call Eileen McEnany, who's the president of the Employer Coalition on Health. Welcome.
Good afternoon. I want to commend you for your endurance as we get to the 7th hour of this hearing. As you indicated, I'm Eileen McEnany, the president of the Employer Coalition on Health, and I'm here representing small employers concerned about the unsustainable cost growth in Massachusetts, but I'm also here as someone who spent 30 years in the health policy world. And I know I'll be very brief, but I want to make a few quick points. You heard a lot about how the healthcare provider system has undergone change. I want to highlight some changes from the employer perspective. One is that we have a very diminished small group market. It was about 800,000 covered lives, and it's now less than half of that. And so that could mean that there are fewer small businesses in our state, or there are fewer small businesses buying coverage, or more employees are getting coverage through the public plans. But none of those scenarios bode well. The second thing is the average family premium in the U.S. has grown by 62% since the inception of the Health Policy Commission, but that number is even higher in Massachusetts. We know it exceeds $30,000 a year. And to put that in context, if you are a full-time worker making minimum wage, your gross salary that you bring home, $31,200. Also, there's been an enormous consolidation of providers. There were 90 when Chapter 224 was passed. There are 70 today. That consolidation provides hospitals with more leverage in negotiating reimbursement rates, as we heard from Sarah Islin, about 50% increases to take or leave. The other thing is we've seen a lot more people on our public health programs. Medicaid has grown considerably by over 300,000 after the redetermination process, and as our state ages, more people are on Medicare. And that means that there are fewer people in the commercial market cross-subsidizing those payers, which does lead to higher premiums for those in the commercial space. And so I have 5 suggestions. One certainly is we need to acknowledge that the healthcare system is in crisis. John Fernandez said it explicitly. I think everyone else who testified said it, if not in so many words. And I see today's hearing as a collective call for our cry for help. And so I'd like to add kind of the employer voice to that chorus, because they're the ones that are shouldering the cost, right? It's the employers, their employees, consumers who just purchase healthcare outright, and taxpayers. And so I think that there are several things that the Health Policy Commission can do in the short term. One certainly is to enforce a meaningful statewide benchmark, and because to do so not only signals that you are serious about cost containment, but to do otherwise renders it meaningless. And I think we have to do that. But equally importantly, I think you have to take your show on the road. And by that, I mean educate the public, small businesses, the media, about how the current system is faltering, what's driving cost, how to make more informed decisions. I talk to small businesses every day, and unfortunately, they don't even know of your existence, let alone the data that you can provide. So I really want you to, I encourage you to proactively get that word out. Certainly, many people have talked about adding pharmaceuticals, PBMs, I would say medical device companies, to these discussions, and I underscore the need to do that. I would say the other thing I think we can do longer term is, this crisis warrants action, and I think the Health PC the HPC can facilitate transformational changes across the industry led by hospitals. And Steve Walsh aptly talked about how our payment system was designed for a very different time, when we rewarded volume and when we had far fewer people on the public programs, and so that cross-subsidy worked. It's not anymore for all the reasons that we've heard today. And I think that Dr. Kolbansky offered some very concrete suggestions about how to innovate our delivery system and move it forward. And I would say the answer simply cannot be to get more payment from purchases. They're contributing their fair share already. We know that commercial payers pay about 130% of Mass Health and sometimes double what Medicare provides for many services. I would also say taxpayers are contributing greatly to the healthcare system. Some recent information from the Senate Ways and Means Committee. Taxpayers have provided $1.3 billion in direct relief since fiscal year 15 to hospitals and over $3 billion in total payments to hospitals and community health centers. And that's above and beyond the Mass Health reimbursement payments. So what I would suggest, and I would encourage you to encourage lawmakers, but we need to get a return on that investment. And so we can demand innovation for that money. We can require some results. But I think, we really have to do that if we're going to change the system in a way that we're all asking. And so the employer community, certainly ECO stands ready to help you. I think we all know that when we work together, we can accomplish great things. We did it in Chapter 58. I hope we can do it again, and I look forward to collaborating. So thank you.
Thank you, Eileen. Terrific. We'd like to take our last few minutes to give each of the commissioners an opportunity to comment on one takeaway, something they've learned today, something that they're leaving this hearing thinking differently about, and then we'll close. But if I could ask each of you to, provide one reflection on the course of the day. And could I start with you, Commissioner Kwasnick?
Sure, I'll set a low bar.
Thank you.
Thank you. I'm really appreciative. I don't know how these things work. I'm sorry.
It's always on.
Okay, great, even better. I'm really appreciative of everyone who took the time to come and speak with us today. I think these are always really thought-provoking conversations. I think especially from where we sit at administration and finance, we're always asking the question, how are you going to pay for it? So it's always really nice to kind of pull up and get the full picture and be reminded of, everything that goes into how you pay for something. So I think that was really interesting. The other thing that I've been thinking about is a comment that Sarah had made about health planning, over multi-years, and how to square that against, annual budgets, not just on the state side, but also for annual plans, for annual hospital budgets, and kind of how those two things are in constant tension with each other. And I look forward to seeing how that develops over time.
Thank you. Commissioner Mastrogiovanni?
What I got out of it was we're in financial trouble. We need help, and we would like the state to help us out of trouble, to actually help fund us.
Commissioner Blakeney?
Yeah, I wish I had 24 hours to ponder and to think through, but I think what I heard most profoundly is the system we've got is not sustainable. It just isn't. It's running now on the backs of providers and on the backs of patients and residents and on the backs of systems and on the state. That's the only reason it's afloat. When we look at what's going to be happening over the next 4 years, and everything is in flux, to go into the next 4 years with a system that is like this is, quite frankly, scaring the hell out of me. But I'm grateful that the commission is here. I'm grateful for the opportunity to serve on the commission. I'm grateful for what I believe is going to be the courage to ask the tough questions and to listen to the conflict, because everybody who's testified here is absolutely convinced of the power of their position and the righteousness of their concerns. And when we put everybody with those positions in the same room, it's going to be very interesting. So this is not for the faint of heart, but it is not sustainable otherwise. So I'm not sure what else I'd add in 24 hours, Madam Chair, but that's my first
We
shot.
look forward to your future reflections, but for today, that's
Thank
very
you.
helpful. Commissioner Foley?
Yeah, I had the same thoughts. Sometimes it takes a little while for this to sink in and think about what our main takeaways were from it. Feel like there is a lot of consensus, as was just stated, that the system currently isn't really working very well for a lot of people, and that the challenges, particularly at the federal level, are only going to be more intense. But that there seems to be more of a willingness now to come together to solve some of these problems. And I think what we need in the state is someone to convene those actors in the healthcare space to really look inwardly about what we're willing to accept to move forward. And in that situation, there are going to be winners and losers, and we have to be able to accept some of that to be able to move forward. And we really, I think it's a clarion call for leadership to bring together the industry stakeholders to solve problems. And I do think that if we were able to do that under the crisis of COVID, which I think was stated earlier, I think we have a crisis at the federal level that should also bring us together with a similar approach about working together as a healthcare system to solve our problems and lead by example for the rest of the country.
Commissioner Castillo?
Take them both. Take them both.
Stereo.
So I think it's, yes, that we certainly have a healthcare crisis, and that, I guess from my point of view, from the people in the community that I work with, which is communities of color. I'm Latina. I work with a lot of the Latino community. I think we failed them, and I think we continue to fail them. I think if you look at every inequity that exists, and I get a little, that's who's being affected. And we can talk about how much money people need, and I get that we certainly need primary care. But we've been doing this for a long time, and we haven't changed anything. And we can keep talking about it, and that's why I ask, what are you doing? What do you want to do? Do we need ambulatory care? Then let's move and do it. We can find buildings to do this. It's not that easy, or at least I don't find an easy solution here. So I think for the communities that I work with, I'm losing hope in that.
Your voice is so important in this and bringing that reality into the room. Thank you. Secretary Walsh?
I really appreciate everything that we heard today, and really appreciate the endurance of everyone in the room as well. I guess I came through with, I think we ran the risk today of admiring the problem a little bit too much, and I think there's a lot of opportunity hidden under this pile of whatever we're digging through. And for me, it kind of shows up in three ways. I think one is the point that Amy made and Maddie made about listening to the communities we're trying to serve rather than doing what we like to do in a way that kind of might work for them, or we have a grant. That's kind of, I think the second thing is, we live in a world that has changed so much. We all carry a computer in our pocket, but the depth of feeling that people have when a traditional inpatient hospital closes in their community, I think misses the opportunity of what they're really grieving is, and somebody used it on one of the panels, the idea of an anchor feature, or like community health centers can play that role, or like what is it that it's not beds in an old building with an air conditioner that doesn't work. It really is what that represents for the community, and we have to find more innovative and frankly more cost-effective ways to create that anchor role in a community that so that we can move past where we are. Because if we keep doing the same things, reopening hospital beds that are financially non-sustainable. I mean, the people who stepped up to take over for Steward, they got some support from the state, but they need our thoughts and prayers. They have there's no magic wand you can sprinkle over the communities of Lawrence and Methuen and make a profitable health system up there. You have to think very differently about how you care for people up there, and how funds flow and how payment flows. And so that's a huge change, because I ran a health system for a very long time. You still count how many operations, how many people come through the ED. We know that's exactly the wrong thing to be counting, but that's what we do. And so how do we convert what is great about our health system into something that actually works for the community in a world where everybody has a computer in their pocket? And then the last thing I think we need is a little more curiosity. I think your point about people believe down to their toenails that they're not the problem, and the person sitting literally 2 feet from them is the problem, is kind of stunning from up here, I think. And I think this is the first time I've been able to sit through the whole hearing. And so I think we all just need to be a little bit more curious about each other's points of view. And that struck me a lot during this Steward work that we were doing. Like, nobody ever asked me, why did it end up this way? People had lots of opinions about where we got, but nobody actually said, hey, Kate, why'd you do that? Or why'd you support that? And it was sort of an interesting experience for me, because I think it speaks to a broader issue of public discourse around hard problems. There are no real easy answers here, but a little less admiration of the problem and a little more curiosity about solutions, I think, would go a long way. And I think that's our work as a commission.
Terrific. I'll reserve and make a last comment.
Cheers.
Right,
prerogative.
yes, exactly. Commissioner Cohen?
Thanks. There were two phrases I heard time and time again today. One was fragile, that the system is fragile. I think it is fragile. I think we know that because we look at the numbers, we look at the margins. My hope is that when we have this hearing again next year, as required by law, that fragile doesn't move to decay. I think we're all very proud. We heard from our Attorney General and from the Governor about how proud we all are to live in Massachusetts for lots of reasons, but healthcare is one of them. We do have an outstanding healthcare system, and our job is really to make sure we can preserve it and make sure it's accessible, the quality is high, but we also have to contain cost. I think I was buoyed by the first panel to see that we have providers who are coming in and working to regain trust and continue quality care in communities that have often been underserved. I am concerned that as a state, we are always reacting. And I think we've got to become more proactive, do more planning so that we're not just in a reactive stage all the time, particularly when it comes to healthcare. So the comments about health planning, I think, are important. I think the recommendations, I leave here thinking that our recommendations in the cost trends report are more important than they've ever been. And so how do we get those accomplished, I think, is really the task at hand.
Right. So similarly, I believe, like many of you, and like has been said already today, that we are at a critical juncture as a health system, as a state, and now politically as a nation. And in these moments, there's tremendous opportunity to pivot, right? In a pivotal moment, it's important that we actually do pivot and we actually do adopt changes that are a substantial departure from the status quo. I don't think now's the time for small changes and incremental changes. We have to do something that that really puts us in a different place than when we started, when Steward came in, right? And so I think today there was a tremendous amount of consensus around the various policy recommendations made in the cost trends report this year. And to echo some of my colleagues, I think it's important that we work together in terms of advocacy to get these measures passed. So I'll leave it there.
I just have to say, the further down you are in this row, the harder it is to answer that question without being redundant. So I'll give it a shot. My takeaway is that we don't have the luxury of time any longer. That's just not something literally we can afford from a dollar and cents point of view or from a patient care point of view. And so I think we need to embrace what maybe we might call radical innovation, but some things that are being done throughout the country. And I would say if we even start by establishing a sort of a quick hit task force to focus on 5 key areas or so that were mentioned repeatedly throughout the day. One of the easy things that comes to mind is using NPs and PAs to backfill that PCP crisis. It's easier deployment. Their debt is less. Yes, they need some overseeing by physicians, but eventually their care capabilities are comparable. Generally speaking, when you talk to people, they're like, I love my NP. They feel like they get listened to and heard, and I think that's one of the ways that we can pivot toward filling that vacuum in the primary care physician area. Certainly the ambulatory centers, surgical centers, and others that we've heard throughout the day. Again, other parts of the country that are much more fully deployed. To Dr. Klebanski's issue, we can take a lot of that workload off of the academic medical centers and provide for that care in more efficient and more cost-effective settings. Standalone emergency rooms, I mentioned Neshoba Valley, and Amy mentioned that the task force out there said that was the #1 concern of their citizens. Over 50% were saying we need an ER in this area, and it literally is a life or death issue. So it cannot be ignored, and I think it's incumbent on all of us to address the 2 hospitals that were left out of the Steward transition. Deploying paramedics in the community to aid in the hospital at home or to aid in primary care follow-up. The paramedics have a good relationship with primary care docs in their community, and they know who their frequent flyers are and the people who are always needing transport or maybe having problems complying with their meds or their treatment. We can backfill with providers who are in the communities, the EMTs and the paramedics, to bring those services to the people so you don't have the transportation issues and you don't have the cost barriers that you have in some other things. And finally, kind of an outlier, but because I come from the employee benefits arena and echoing Eileen's points there, the pharmacy benefit managers need to be part of this conversation, and we need to have we need to talk about money and costs and drugs, and our employers are bearing such a disproportionate cost of medical care. It's not fair, it's not sustainable, and it's not going to be broken, it is broken, and we need to do whatever we can to save that system, so.
So I think a common theme that came up today was around bringing folks together to find solutions. And on one hand, it's a little bit discouraging because I think that we find ourselves in having the same conversations year in and year out. On the other hand, I think I'm optimistic because there was sort of a unified consensus view that we do need to come together, and there seemed to be a willingness to come together. I particularly appreciated the reflection from Dr. Ojikutu that the COVID-19 pandemic really served as a catalyst to bring people together to abandon their own self-interest, where there were instances where folks were taking some upside risks, downside risks, with the shared common goal of patient outcomes and getting through this together. So throughout the day, I've been thinking about how do you use the affordability and capacity challenges as that common enemy, if you will, as a system to come together. And while I feel like coming together alone is not going to solve the problem, how do we really get folks together with the premise that we can't just convene to convene, but we need to do so, and everybody has to be willing to give something up and have some skin in the game. And that really means shared upside and downside risk by all providers. We're sort of abandoning just the traditional payer-provider dyad, but really bringing everybody under the tent. post-acutes, home and community-based providers, CHCs, everybody coming in, so that you don't have, say, an innovative or risk-bearing home and community-based provider that's doing great things, but all of the benefits are accruing to the tertiary academic medical center. But really coming together where everybody's sharing in those wins and losses, because without having everybody have some skin in the game, I think the efforts will be futile.
So thanks to everyone for engaging in these excellent discussions today. Thanks to the witnesses and the HPC. I think maybe like many of you, I've spent much of the last week and a half kind of laser focused on what we might expect in terms of challenges to the progress that we've made here in Massachusetts, whether it's the integrity of our insurance market or access to reproductive care, gender affirming care. So maybe as a final comment, I'll just say it's been really energizing to share space with all of you today and to hear a really concrete and policy-focused series of conversations about places where we may be able to find common ground on the state level and to hear what I think is a shared commitment in Massachusetts to kind of play offense and defense as needed in the months and years to come. So thank you.
Yeah, very important comment, particularly as today we're starting to hear about the leadership at the federal level and some of the new challenges that might mean. Thank you to the commissioners for those reflections, and I'll just add to those by saying that I'm ending the day even more feeling the way that I did when I came into the room, particularly given Sandy Walitsky's comments just now, which is that despite all of the challenges that lie ahead of us, and clearly we've engaged deeply in a discussion of what those mean for Massachusetts today, I guess what I'm reflecting on is what I didn't hear. I didn't hear a lot of pointing at each other and blaming. I heard every single panelist looking at this from a 360-degree view, both in terms of different communities, provider, payer, government, private, and I felt that there was an underlying commitment to understanding that there's going to need to be solutions that are shared and that there wasn't a hesitation around that. And I think that's partially because of the leadership that we saw reflected today. And as you were commenting, Director Peters, that we could have been in a very different place today given the collapse of a major health system in the Commonwealth with different actors and with a different outlook. And I feel that both for those new owners that we know and for getting to know Revere Health, we could have been in a very different place. So I leave the meeting feeling that despite the challenges, which are absolutely daunting and at times overwhelming, I feel like we do leave with a commitment to progress and a lot of shared view on those things that, each of the those who testified hold in common around what the government can do, what payers can do, what providers can do. So I want to thank not only all the participants in today's proceeding, particularly those of you who are hanging in there, and maybe now we've been here as long as it would take to get seen in the emergency room. We know you all have very busy schedules, as Steve Walsh said. Yeah.
Are you kidding? This is a half day.
But we appreciate all of you who have come online, all of you who are here in person, and particularly those who testified in person and did in-depth preparation for that. And I also finally want to thank our team at the HPC. Believe me, the commissioners understand how the work that they're doing and what it takes to prepare both our annual report and this meeting, and also to my fellow commissioners, both for your participation today and your dedication and commitment to the work of the Health Policy Commission. So for that, we will adjourn, and thank you all.
Good job.